looking at the valve. We are looking at the valve from LA side. So, sorry. This is the view. We're looking the valve from the LA side. This is the surgeon's view. This is surgeon's view. And this is the view we're getting from the LV. So you're looking at the valve from the LV side. As you can see, the posterior leaflet is still fine and anterior leaflet, a lot of calcifications there. The mitral annulus is, this is the mitral annulus, which is quite calcified. And this is the mitral valve opening and closing. And this is, I image this left atrial appendage ostium. This is the LA ostium. You can see some spontaneous echo contrast is there, but there's no clot in the left atrial ostial, in the left atrial appendage ostium. And the more precisely, zooming, the left atrial appendage looks clear to me at this moment. And it's a further zoom view. Left atrial appendage looks quite clean. So now coming to the aortic valve. So you need to see other valves as well. So this is the aortic valve. We got aortic valve leaflets are quite thin, but pliable, so it's like normal aortic valve. And there's some coaptation defect. You can see some gap, central gap coaptation defect, but that should be all right. Leaflets look all right, not thickened or anything. And this is the aortic valve we're looking from the LVOT side. And this is the aortic valve we're looking from the aortic side. It looks normal. And this is the aortic valve you're looking from the LVOT side. Quite all right. So as you can see, this is the atrial septum, intraatrial septum. This is the large LA, huge LA. And the septum is bowing down to the right side. Significant bowing of the atrial septum to the right side. And this is the imaging of the atrial septum, intraatrial septum by 3D. This is the intraatrial septum, and this is the IVC, as you can see, and this is the coronary sinus. The coronary sinus size looks quite reasonable. If a retrograde pleasure or something needed, we can image here. So it looks good actually. There's no valve or anything at the coronary sinus at this moment. IVC is all right. Intraatrial septum looks all right. There's no obvious gap in the intraatrial septum. Yeah, this is the IVC and this is the coronary sinus. So next, going to the live. Anything else? Has anyone got any queries or anything? Ask them. Can they ask them?
Yeah, we have to look about the TR also.
That this side of the anterior leaflet will guide about the annuloplasty ring size. Okay.
Okay.
So measure rough. This is a rough measurement anyway. It's like it's a curved distance, so it will be like 2 centimeter only. So in 3D, the intratrigonal distance I got as 20 millimeter to just above 2 centimeter. Here, because the curved distance, I'm getting like, it will be like 2.2 for the annuloplasty ring size. Tricuspid valve. Tricuspid valve. The tricuspid valve is the tricuspid valve. Put some color. This TR will measure the PA pressure here. Not here. There is some moderate TR at the tricuspid valve because the RI is hugely pressurized. So let's take the PA pressure. Let's measure. What's the PA? 6. So the maximum pressure gradient coming at 41 and CVP I can see in the monitor is 7. So maximum PS systolic pressure is 47. PS systolic pressure is 47 at this moment with a systolic blood pressure of 97. So pH kind of half the systemic and PS is an A. I'll not be I'll not be surprised if the actual pH pressure actually bit on higher side actually 50 plus. So patient has got moderate to severe pH, I must say. Uh, you can see the atrial septum. This is plenty of spontaneous echo contrast. The LA is huge, huge LA, and virtually pushing the interatrial septum to the RA, and there's a lot of spontaneous echo contrast, but there is no clots or anything, I find. So let's look at the outer looks all right. Outer looks nice and tubular. That's not a problem.
We are having moderate tear.
Tricuspid, we're having moderate tear. I can measure these. I'll measure the annular size. So it rostral. It's fine. Distance. Oh, 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 oh. Mm-hmm. What's happening with this? Just a second. Just a second. That's a major. That I know what the problem is that it's not same. Yes. So tricuspid analysis 31. Tricuspid annulus is not dilated. As you can see, the RV is not dilated. Tricuspid is not dilated. And this high peer pressure is because of the high degree of MS.
Multiple jets, I think there is
Multiple jets, but I don't think you should do anything to this because the tricuspid will be better once you once you correct the MS. And with a small tricuspid annulus 30, it's better not to repair. Better not to repair. There is no space. What size ring you put? 28. So
but at the leaflet level, we can do something. There's multiple jet.
see, I can see the tricuspid at 3D. Let's look at the 3D and see if there is any problem at the leaflet level. Not been imaged well. If tricuspid valve is not imaged well in 3D, then one indication is that the tricuspid valve is not thick. The tricuspid once imaged well in 3D, that means it's really thick. Valves now. I'm not getting good tricuspid. So this is the tricuspid valve. The leaflet look all right actually. Though it's not a good image, but this is tricuspid valve. You can see it's quite thin actually. In normal tricuspids, imaged like that, it's quite thin. You can see this is the tricuspid valve. I can increase the elevation width. Yeah, this is tricuspid valve. Looks all right actually. Looks all right. I don't think you should do anything to the tricuspid valve. Just leave it. Tricuspid coaptation is fine. You can see this is septal leaflet. This anterior and posterior leaflet looks all right to me actually. And here in the 2D also, it's coapting well. You can see in other views. This is tricuspid leaflet. You can see coaptation is good. TR is because of the high peer pressure.
Hello. Am I audible in the
Yeah.
operating room?
Very loud and clear.
Dr. Arup, since we are not going to address the tricuspid in this small annulus, can we get underway with the proceedings in auditorium? Because I have to give a rundown of the
Yeah.
patient
So,
patient
please,
history first. Yeah.
please.
Okay. Thank you. Thank you.
Proceed.
Thank you. Good morning, respected dignitaries of the dais. This was the TE image of our first case, which has been taken in OT1. We are going Dr. Crawford, Dr. Koselli. He stands truly at the watershed point of cardiac surgery. And we are truly thrilled to have him operate here at Kolkata. Along with him, we also have Dr. Kachu from Division of CT Surgery at Washington University School of Medicine at St. Louis. So to start with the patient, our patient is a 44-year-old female who complained of chest tightness of NYHI class 2, class 3 for last 3 months. On transthoracic echocardiogram, we found there was severe mitral regurgitation. AML was mobile. The tip was mildly thickened and calcified. PML was less mobile, thickened, and calcified. There was moderate subvalvular disease load. Left atrial diameter measured 6 centimeter, which was large, and ejection fraction of 50%. On ECG, patient had atrial fibrillation with controlled ventricular rate at all point of times. On chest X-ray, the CT ratio was 0.06. Right descending pulmonary artery is dilated, suggesting pulmonary artery hypertension. So this is the chest X-ray in a PA view. As you can see, the epi diameter, the CT ratio is 0.6, and atrial fibrillation is there, but with controlled ventricular rate. I just run the transthoracic echo loop. So you have already seen the TE image. This is the transthoracic echo before anesthesia. The AML is mobile, but the PML is fixed. This is the aortic diameter, which was 6 centimeter. So this was our first patient. I'll just give a rundown to the approach of mitral valve repair before we proceed to the actual repair per se in the video feed. So I'm Dr. Sanjay Sengupta. I'm consultant CTVS at MEDICA Superspecialty Hospital. So why repair is chosen over replacement? The very common reasons being there is a low operative mortality and survival is also increased in case a repair is possible. And it, most importantly, it avoids the risks which are inherent in the use of prosthetic heart valves like endocarditis and thromboembolism. And it better preserves the left ventricular function also. So what are the goals of repair? The 3 goals of repair are mobility of the leaflet. We have to attain as much mobility of the leaflets possible. There should be good coaptation of the leaflets to the tune of 8 to 10 centimeter. And the annulus has to be stabilized. So the pathophysiological triad prescribed by Dr. Carpentier tells about the etiology, lesion, and dysfunction. Etiology is the cause of the disease process which is causing the valve problem. The lesion, the structural problem per se, which the insult has caused to the valve. The dysfunction, which results from the bad structure within the valve. So it's more like a triad, pathophysiology triad in every disease that comes around. Like suppose there is a car accident and a fracture of leg is there. So then the victim cannot walk. So the car accident is the insult or the disease. The fracture of the leg that is sustained, that is the lesion. And the incapacitation in terms of not being able to work is the dysfunction. So Why it is important, this triad of dysfunction, etiology, and lesion? Because it facilitates communication between echocardiographer, cardiac surgeon, the cardiologist, and it forms a better language in order to explain what is what. It also is important because in long-term prognosis also depends on the etiology, if it is whether it is rheumatic, whether it is endocarditis, whether it is degenerative, and the surgical techniques mostly depend upon the lesion part. So the functional classification and the segmental analysis are the foundations for performing valve reconstruction. So if you look at the functional classification, it is classified into 4 types. Type 1, where the only annulus is dilated, leaflet mobility is otherwise there. So it falls into category of dilated cardiomyopathy, atrial fibrillation, where there is dilatation of the annulus, or if the mobility is restored, but the leaflet has a minor problem like endocarditis. Type 2 is the one where there is leaflet prolapse, and type 3A is the one which falls under the rheumatic category, where there is a problem in valve opening. So it is a problem both in systole and diastole. And type 4 is the one where there is problem in valve closing. It mostly is encountered in ischemic cardiomyopathy. So there is problem in only systole. So what are the valves which are repairable? Today I'm going to talk only about the approach. I'm not going to go detail into the techniques. So let us first understand what leads us to the repair and how we prepare ourselves, how we understand whether to do repair, how to repair. So involvement of the leaflet, if it is one leaflet or both leaflet, calcification of the annulus, that is one marker which tells us not to go more enthusiastically. If it's a severe subvalvular disease, it's going to be a difficult repair. AML length, is there any formula in order to elucidate whether the valve is repairable in terms of AML length? We just multiply the BSA of the patient into 1.2. If we find that the number that we have is less than the AML length, then the AML length is good enough for repair. Etiology-wise also, if it is rheumatic, there is less chance of repair. It's going to be a difficult repair. If it is degenerative, it is going to be an easy repair. So first exposure, remove all the adhesions. If it is a redo case, remove all the adhesions all the way till the apex. Incision, conventional incision is water stent screw, but transseptal incision is sometimes given in order to accommodate a small left atrium or sometimes a large or giant LA. Sometimes what we do is we also tend to cut right across the IVC and go all the way towards the mitral valve, and then also you have a good exposure. Supraseptal approach is also used sometimes in order to accommodate small left atrium. So the next in line is valve analysis, the segmental function. For segmental function, we take 2 nerve hooks and we use P1 as the reference, and all the way in a clockwise manner, we go to the A1, A2, A3, P3, P2, and then come back to P1 again. So what we actually do is we take the nerve hook and we pull the nerve hook away from the annulus. It tells us whether the leaflet is good enough mobile, if the chordas are elongated or ruptured. And then we also have to identify right in the beginning where exactly are the location of trigones. So in order to find out the location of trigone, we can pull the anterior leaflet downwards to each side, to the left and right, and we can easily understand where the delineation of trigone is there. That is also important in order to measure the valve ring, because we look at the base of the AML, which is limited by the 2 trigones. So look at the type 1 dysfunction. In type 1 dysfunction, as we already saw, there is annular dilatation, so we can go do away with the annuloplasty. If there is leaflet perforation, which is caused by endocarditis, we can go for a debridement. And if it's a small defect, we can directly suture the defect. If it's a big defect, we can go for a patch closure. Then comes the restoring the shape of the annulus. Shape of the annulus, the normal annulus is generally, the transverse diameter is more than the epi diameter. So all the rings that we use tend to modulate the annulus in such a way that the transverse diameter is more. So there are three rings that we use. Classical ring, which is designed for rheumatic valvular heart disease. Physio ring, which is used for degenerative valvular diseases. They have large epidiameter. An ischemic ring for type 3B dysfunction, where there is a dip in the P2, and that dip actually accommodates the indentation at P2, P3. Based on how the ring is sized actually, very warm welcome to ATS members, surgeons, Dr. Piroz Taviriwala, Dr. Rimani, and Dr. Barlow into the auditorium. Ring sizing, we generally pull the AML more towards the posterior aspect. We look at the position of the trigone and height of the AML. If the part of the AML is less than 2 millimeter beyond the particular ring sizer, we are happy with the ring, and we go with the with that particular ring for annuloplasty. So for the saline test, after you push in the saline, if the line of coaptation is parallel to the posterior annulus and the depth of coaptation is 4 to 10 mm, then we are happy that the ring has done the trick. For prolapse or type 2 dysfunction, in case of PML, if it is a limited prolapse, you can go for triangular resection. If it is an extensive prolapse, you can go for quadrangular resection and sliding plasty. Triangular resection is where you just take out a piece of triangular piece of a particular segment and just suture it. Quadrangular resection is where you have taken out a quadrangular piece of posterior mitral leaflet and suture it, but without intention. But in case when you go towards quadrangular resection and you find that you cannot suture it back without tension, then you have to go for sliding leaflet technique. In sliding leaflet technique, you take out, you separate the part of the PML to a tune of 2 to 3 centimeter, and you suture it end to end, and at the same time you also plicate that extra bit of posterior annulus. The good thing about sliding leaflet technique is that you also can modulate the height of the PML, so the coaptation is taken care of. In case of AML prolapse, you can go for caudal shortening, but at which levels? If the cauda is fan-shaped and it is attached with the multiple heads to the leaflet, then you can do the caudal shortening at the level of papillary muscle. In case of extensive prolapse, you can go for a caudal transfer. That means transfer of a secondary leaflet to the margin of primary leaflet. Caudal translocation, where you can use a flip-over technique, where you can actually take out a piece of attached cauda of the PML and then attach it to the AML. You can go for a papillary muscle plasty and artificial cauda. Hopefully, we'll see a few of these techniques today in the video feed that are coming in shortly. So this is the caudal transfer, where the secondary leaflet is transferred to the primary margin, and caudal transposition, where the flip-over technique by PML, a part of the PML is actually flipped over to the anterior mitral leaflet along with the cauda. And this is the artificial cauda measurement. Leaflet procedures, one thing that we have to remember, that minimal AML length should be always 26 centimeter, because the minimal size of ring that we have is 26 millimeter. So if it is less than 26, we have to augment it. Maximum PML length that is allowed is 15 millimeter, because if it is more than that, we land up with systolic anterior motion, SAM. For the leaflet extension, you can use triangular or ovoid shaped pericardial patch to augment. Let's coming to the type 3A or rheumatic repair. There are basically 4 lesions that we have to address: commissural fusion, leaflet thickening, caudal fusion, and prolapse. We can go for a fenestration at the level of cauda. We can also do secondary caudal resection. And in case of leaflet thickening, we have to do an extensive and very enthusiastic leaflet sliding and cuspal thinning. And in case of prolapse, you can use any of these prolapse techniques that we have discussed. So type 2B is the one which is ischemic mitral repair, which is beyond the scope of today's conference. So thank you. Thank you. If there are any questions, we can have a discussion and amongst the audience. Or otherwise, we'll move to the next segment. Dr. Shomojit? Hello, Dr. Shomojit, can you hear me? Hello?
Oh, I can hear you.
Yeah, what is going on there? At what stage?
It is the cannulation is going on.
Okay, so we'll have some time left. In the meantime, can I call upon Dr. Kunal Sarkar to address the gathering?
Yeah.
Okay, just wait.
Yeah. Please.
I'll invite upon the stage respected chairperson, Dr. Lalit Kapoor. So please be on the stage here for this session on mitral repair. Yes. Dr. Shubhankar Bhattacharya, sir, please be on the stage. Since the other chairpersons could not turn up, can I request Dr. Lokesh Saja to come up, please? Just for 1.5 hours, yeah. Please. So, present president of ICTS, please. Please, Dr. Binak Sarkar, please come on the stage, the fourth chairperson for the session. So please come. Yeah, please come. And can I ask Dr. Pradeep Naran to be on the stage, sir? Thank you so much, sir.
Lady, the fact is that she's in atrial fibrillation. So once you're talking of atrial fibrillation, then the repair you're going to be doing it knowing that you're going to continue giving anticoagulant.
Exactly, that's what I was saying.
So you're doing the repair for its long-term benefits on the LV function rather than for any other reason.
So actually, I wanted to put this question to our experts from the AITS. Chris, I mean, this is a rheumatic heart valve disease is very common in this part of the world, but not so common in the US and definitely in the UK. I mean, would you consider repairing this kind of a valve or?
No, well, I mean, that's a great question, and thank you to all the organizers for having us here. The answer, I think, is that we all now, as repair expands, are trying to sort of, get more and more people into a sort of the practical repair group, and the same principles apply all the time. So this is interesting, and it's a challenging case. And I think, as Dr. Moon and Dr. Kachu will be showing later, they're going to but they'll go through the principles. You've got to get 2 pliable leaflets. And I think these leaflets, they're thickened, and they may not be completely pliable. We can't really see what the leaflet bodies are like because the cordia are restricted. Clearly, both anterior and posterior are restricted. So as far as the leaflet's concerned, they're going to have to work on the leaflet. They're going to need to separate the commissures. And then the cordia, they need to somehow render the valve pliable. So now if the cordia are shortened, you can work with that if they're equally shortened, if you slightly reduce the annulus without narrowing it. But potentially you need to do more than loosen secondary cordia and put in new primary cordia. So it's a challenge, but you must get a good result. For anyone to have a mechanical valve with Coumadin to last for life, in inverted commas, is a challenge. Pannus grows in. There are hazards of Coumadin if you're in any sort of accident. So I think it's ideal now in any patient to try to avoid it. But certainly I think there's a lot to be said in an older patient with complex degenerative disease, mitral annular calcification. And I think the right decision is to, as Frank Wells and Papworth says, do a mitral valve insertion. You're not replacing the valve, you're retaining the subvalvular apparatus, and you do a safe operation. But this is a reasonably young lady, in age 44. It would be nice to get a repair, but you need a good, potentially durable repair, otherwise to go for replacement. But again, you can learn a lot from knowing when to replace and how to repair.
So yeah, in fact, that's one of the things that has deterred surgeons in this part of the world from undertaking repairs, because these experience with rheumatic valves is very limited worldwide, and there is a higher chance of failure as compared to degenerative mitral valve repair. And most of these people did, you don't want to subject them to a second operation if you could help it. So that has been a thought process that has been, keeping most of us back from repairing rheumatic valves. But I think experience is growing now, and probably with increased expertise, I think it might be possible to achieve good results in rheumatic, just like we did in degenerative valves.
Do you have a preference for a choice of ring to stabilize the repair?
I personally tend to use a complete ring for everything. I know Craig Miller did great work here, and flexible rings. But I personally, with a case like this, this is actually a good case for a band, potentially just a band, because it's small, and you're really just stabilizing the annulus, not reducing anything. But these are all great points, and there were times when Barlow valve, people didn't want to repair it because they were worried about the pathological leaflet you're leaving behind. At the same time, we now know that's not the case. Degenerative valves, MAC, we can repair. But we don't see these cases as much as you do, but the principles apply, and there's great work, and there's durability data. Manuel Antunes operating on patients.
So, Chris, forgive me for making this small announcement. You mentioned Barlow valve, and I can't help not telling this audience that Chris happens to be the son of the famous cardiologist, Dr. Barlow, from whom the name comes, the Barlow's valve. Great company.
Yeah, well, he was a cardiologist and he knew a lot about the mitral valve. So I'm a surgeon. I'm not entirely following in his footsteps. It would have been a hard job.
So we're really having some unique experience today. Anyway, I just having seen the clinical features of the patients, and to your questions, the patients also having AFib. And this is my also, I have in mind whether we can add some, MAGE procedures in addition to whatever has been done so that we can avoid converting for a long duration of time. And that also sustains the repair for a longer duration of time. And I think this is input from other chairpersons regarding this.
We have a lot of experience in repairing rheumatic mitral valve disease from the All India Institute of Medical Sciences. I was trained by Dr. Sampath Kumar, where he has done many of the rheumatic valves are repaired and stabilizing with a modified angioplasty ring, C ring, that is like that. But in patients where probably this is a 44-year-old lady, I think we should attempt repair in this space. And cuspal thinning probably will take care of all the calcium that is attached. Usually it is on the epithelium, endothelium, the calcium gets segregated. So when you peel off the thing, usually it comes out without making a hole in the leaflet. So that has been one of the experience where Dr. Sampath has published it for the first time, long time back. And this type of valve will do, though they have a atrial fibrillation. Probably anticoagulation, doing that with the repair also not a bad option, because the anticoagulation we do, the INR target would be much less than treating atrial fibrillation INR compared to a prosthetic valve, mechanical prosthetic valve, making anticoagulation. And probably this lady probably will repair better first, and probably after buying some time we can replace it later on if it is a thing.
Dr. Sajja, having said that, I just want to ask you one thing. Like, in this situation where the LA is large and patient has long-standing rheumatic process going on, despite being able to go for a maze and get a successful normal sinus rhythm, is that sinus rhythm going to sustain in this patient, even if you get it? Like, does it sustain? Does it sustain?
Most of these patients, when the LA size is so big, usually it will not return to normal size, right, even after addressing the valvular problem. And probably these are patients benefit from atrial fibrillation surgery. So probably the limited one would be already done, MAGE 3 procedure, thing like that.
Okay.
And because some of people have studied the histology of this, histopathology of this atrial valve, yes, because they graded whether this atrium is going to return to normal size or not. So probably with histopathological examination of the part of the atrium which we are going to excise, if it is too large, that will tell us whether he is going to remain in the sinus rhythm for longer time, or if it goes back to the atrial fibrillation, probably still it will work good even if you repair.
What I think that the choice depends upon the good echo quality, and we should be selective particularly in the rheumatic valve changes in the cases. Very choosy we have to do it, otherwise there will be failure.
Is there any role of decreasing the LA size if we don't want to go for maze procedure? We just sometimes we tend to have Indian surgeons tend to have a notion that if we decrease the LA size, it will do some help. Is it of any use according to any of you? Any real reward we get by?
No is the answer to that.
No,
I personally think the hemodynamic, the pressures and flow dynamics. No, frankly, and that's very hazardous surgery.
Suppose we have a LA size of to the tune of 100 to 110, 120. Even in that case, like there's no point, right?
Well, again, in the context of mitral stenosis, it's what you're trying to achieve. You've lost full contractility,
right?
And the flows are going to be based on the pressures, and the pressure differences are really low.
Yeah, right.
So I think it's risk benefit, and I think there's not much to be gained from it.
Right.
AF surgery as well. We're driven very much by the size of the atrium, and I know much bigger than 5.5. We wouldn't attempt any surgery. And Dr. Moon was just saying yesterday, here it would have to be a cut and sew type maze, and I think he would not.
So LA size is going to be a big determinant here.
Yes. Well, they're likely to clip off or obliterate the LA appendage, and I think there's merit in that from a thrombotic perspective.
Right.
I don't know what you feel about the LA size reduction.
I agree with it. There's no evidence that it helps.
Right. Yeah.
Well, if it's a gigantic LA, you may reduce it. Like if it's like a 10 centimeter LA, but it's not going to affect the function.
Right. Yeah.
So I mean,
I just wanted to share it because we Indian surgeons, we have a tendency to go for a
there's no evidence.
LA decrease on the LA size. Yeah. Right.
Yeah.
We're going to have a cross clamp on the aorta very shortly. Just a few other questions if you have before the video pitch starts.
I believe that the mesh procedure will not be lasting for a long time unless we make the left atrium small.
Right.
Enlarge left atrium small.
Right.
So, I mean, with regards to the LA size, we sometimes do LA ligation and LA occlusion along with mitral valve surgery, but that's primarily to reduce the clot burden.
Chances of clot and stroke. Yeah.
Yeah.
Right.
So can we have the live feed while we are talking?
So they're trying to put a PIP where they and keep the hall.
Let's do it later. We are. They control that, so we're good to go.
Can you hear us from the auditorium? Yeah.
Yes, we can hear you.
Over to Dr. Mark. Yeah. Over to Dr. Mark. Yeah.
We're just getting ready to cross clamp and arrest. And we're using custodial, correct?
So are we using custodial or del nido?
We are using custodial.
Right? How much? 2 liters? 2 liters. And 2 liters, we're going to hemofiltrate. I have before put a suction into the right atrium to collect it as it comes out of the coronary sinus. But if you hemofiltrate, I don't think we need to do that. We've got a very quick arrest. We've got very good exposure. We've got tapes around the cavus so we can pull up and expose the left atrium. We're just going to enter through the left atrium. With it being this size, we don't think we need to do a transseptal. Absolutely. Okay, thank you. That looks good. That'll be out of the way. And we're the tourniquet. What we're going to do is we'll do this and pull it up once the bleed is all in.
Okay, that's all right. Okay, sure.
How much is that for cardiac? What's the dose right now?
How much?
2 liter. Okay. Well, there's the.
How much?
Yeah.
We looked at the tricuspid valve. It leaked maybe mild to moderate, but the annulus was not dilated and leaflets looked normal. So our assessment of our echocardiographer was he thought we'd have improvement with time once we fixed the mitral stenosis. Yeah.
Can we talk with him in the OR there?
Yes, definitely. Yeah, please go ahead.
That's your way out in the main there.
Hey, Mark, it's Cliff.
Hi.
So are you giving retrograde plegia?
No, just antegrade. We're going to give 2 liters of custodial. And we think we're going to be able to complete the case with that.
So how much time do you give yourself with that?
I don't know. How much have we given so far?
No, well, how much time would you think normally with
For custodial, boy, we could do a couple hours. Yeah, maybe 180, they say.
We can safely go for 200 minutes.
And why not Del Nido?
Well, the Del Nido's good too. You don't get quite as long a time with Del Nido. I usually repeat that at 45 minutes. And if the ventricle's not good, I think the Del Nido's a good idea. Yeah.
And then your approach is going to be into atrial, the sort of Syndergaard's groove, rather than
Exactly. Can you guys
transeptal.
see the images yet?
We're seeing you. Yeah, we're seeing you from above.
Yeah, we're just trying to.
We're seeing your left hand right now, but it's nice and steady.
That's Dr. Catcher's left hand.
Okay. Well, okay. That's why that explains that. Then.
Forceps, got it. Whoop, forceps. This looks like the left atrium is quite large, as we expected. So we're just kind of clearing things up to wait for the cardioplegia to go in.
We were talking about the views about atrial reduction, just in order to achieve it itself. What's your? Perose and I've reflected a view. What's your view on atrial reduction for mega atrium like it?
Yeah, I think with it's not going to really affect your macro reentrant circuits, but it may decrease the burden of clot potentially. You can see this left atrium, if you can see it, your left hand's kind of in the way. Right here is quite large. We could potentially do a left atrial reduction of that and eliminate maybe 3 centimeters of the atrium when we close. But, obviously you're not going to be able to reduce the back. Unless you do a full maze type approach. Okay, good.
So it's all from clot burden perspective.
I feel it's probably just clot burden perspective. I don't think it'll fix your arrhythmia.
And what's your cutoff for size for an arrhythmia?
Well, if we were going to do an arrhythmia surgery, I think we found that as it gets larger, it's kind of a logarithmic increase in your chances of recurrent atrial fibrillation. But once I've fixed them that have been 7 centimeters before and had good results. So it's kind of unpredictable. How much cardioplegia? Okay. Another 500 more.
I stop at 6, but again, it just tends to take more time to do the job properly with less resultant.
I agree. It's not. Some people say, doing mazes does not add much. I don't really believe that to be true. It's a pretty significant addition to a mitral valve procedure, I think.
From a hemodynamic perspective, do you think there's any advantage to atrial reduction?
I don't know. I think it's mainly clot burden.
Yeah, we agree.
But wouldn't you think that the pressure in the left atrial wall, that is the stress in the wall, will reduce? Because by Laplace's law, when you become a smaller size, the wall stress will reduce.
That's good. That's good.
Did you hear that, Mark?
What was that? One more
Just
time?
by Laplace's law, if you reduce the size, then the wall stresses and pressures are reduced.
Yeah, sure. Absolutely, I agree with that.
Hello, this is Kunal from OT1. As Dr. Moon is getting ready for the repair, Sanjay, can you hear us?
Yes, sir. Yes, sir.
Sanjay, will you do a quick intro of room 2? Just show the case profile, then Chris can explain his cannulation strategy. They are cannulating in the second OR.
Sure, sir. I'll get away.
Stop. Okay.
Can we vent this? Can we put yellow?
So do a quick intro of the case.
Yeah.
And before
What do we have
Chris
for
comes
suckers?
in, he can
Yellow?
give us an outline of how is he chosen to cannulate and proceed.
Yes, sure, sir.
Yellow.
So the second case in
Okay,
OT2
yellow
is
and
a
suckers, this blue. Do we have another one, or is that
the
it?
second case in OT2 is going to be expected to be a valve sparing root replacement. So here we have a 42-year-old female who is a known case of rheumatoid arthritis, but she has no activity as of now. She complained of shortness of breath of NOHA class 3 for last 3 months. On echocardiogram, she had severe aortic regurgitation, dilated aortic root, and there is prolapse of particularly non-coronary leaflet, and she has got an ejection fraction of 35%. On ECG, she has normal sinus rhythm, no STD changes. On CT aortogram, there is annuloaortic ectasia, there is prolapse of non-coronary leaflet. Aortic annulus measures 4 centimeter. Aortic sinus was found to be 8 centimeter. Proximal ascending aorta is found to be 5 centimeter. We have sat with the radiologist and he was quite sure that the epicardial coronary is absolutely normal and rest of the features were within the normal limit. This is the ECG where there are no STT changes. This is the chest X-ray. The CT ratio is 0.6. Lung zones are good. CT aortogram. Here at the level of ascending aorta it is 52. At the level of sinus it is 8 centimeter. Tricuspid valve, yeah. Coronaries are coming out nicely. STJ level, which is around 7 centimeter at the sinus. Non-coronary sinus is dilated. The sagittal section, the coronal section, yeah. 7 centimeters is the diameter at the sinus level. Okay, yeah. Yeah, we are done with the case here, case presentation. Over to OT2, yeah. Yeah, I can hear you. Yeah, over to Dr. Chris. Yeah.
Oh, this is beautiful.
Good morning. We're in OR2.
Beautiful.
We just got started here. Dr. Niraj has
Are
opened
they-
the
are they in room
pericardium
2 still?
and getting ready to cannulate. Our cannulation strategy here is going to be
Oh, Chris.
distal ascending almost to the proximal transverse arch for the arterial cannula.
Ah, yeah.
We're going to use single dual stage venous cannula, an antegrade cardioplegia,
We
no
can do that.
retrograde,
Just wanted to come back.
and del nido cardioplegia. We'll also
Well,
do a
we're not on
left
camera.
ventricular
We don't
vents
do that.
after we go on pump. And I'm about ready to get scrubbed in,
Why don't we put some?
and we'll cut back to
yeah,
you
put
when
some ring
we
switches
have
in.
the
'Cause I'm gonna
show you what the valve looks
Oh, yeah,
like.
concept. Thank you.
For upstairs, it
Okay.
may be worth it to
Let's not
have
feel this right now.
anesthesia
Why don't we
describe
have a-
the
a
echo.
valve stitch.
Do you want to do that, doctor?
Yeah,
Okay.
duo at the bottom.
I'll give the
Duo.
microphone to the
Non-pleasure.
anesthesiologist here.
I think we are getting feeds from both the ORs. Please switch one of them off.
Big needle? Big needle. Yeah. Oh, yeah. Yeah, there's a hole. All right.
For the time being, please feed only from OT2.
Okay.
Take a stitch.
So we are.
Oh, these are the valve stitches? A whole.
Why don't you tell them off the
The,
back?
do we need the valve? We need 10, 8. No, we don't need that. Towel, just towel.
So while we are setting it up, this discussion about the Laplace's law and the hemodynamics, I don't think the size of LA matters so much to the cardiac output. It's a rhythm probably that is more important.
No, we're getting all mixed up. No,
One of the precipitating
Oh, I see.
factors
This
for
is what we got.
arrhythmias for AF is also the
Well,
stress
yeah.
in the wall. If you reduce
That
that,
might not
stress,
work.
your chances of
Over here?
recurrence of AF might be less.
Over the retractor, there you go.
Okay. Okay. Valve stitch.
Yes. Can they hear me? Yes.
Snap? You have any
So you can see.
That's what I would think, just from the size point of view. But of course, if the wall is damaged,
Hello.
histologically.
Sanjay, can you hear me from OT1?
Yeah, I can hear. I think both the feeds are coming in from both the OTs.
Can you see the mitral valve?
The aortic valve, and this is
repair
the
is going on?
aneurysm. This is the
Can they hear us now? Are we back?
Hi, Mark. Yes, we're back on
We're
here.
gonna put a couple of stitches, a few stitches in.
Yeah, we can
maybe
we can see pretty well there.
So we can see
this
it.
is the aneurysm coming from the NCC, quite a huge aneurysm, but it's
We're going 2 millimeters exterior to the hinge point, 2 millimeters deep to find the annulus. Another stitch.
Dr. Shomojit.
And there's some very interesting findings on this valve. We'll show in a minute. Once we
Can
get
you
a few-
focus on OT1 for the time being for the for a short instance?
Please turn the feed from OT2 off.
We don't need long stitches. We don't need long stitches. You can have shorter stitches.
Shorter stitches? No, he won't know what he's saying. Okay.
Mark, do you
More.
want to explain? So you're putting in your annular stitches now. Does that help you expose the valve better, or are you do you just place these to pull the valve into your view a little bit better? What's
Right,
the
exactly.
purpose
You
of
know, I
this?
think the view here. Let me pull up. The view here is pretty good. We were just killing time while you guys were in the other room, so we put some stitches in. But wait, let's 1 second. We'll take a view at the valve here. Can you guys see the valve? Okay.
Yep, we're looking.
Okay. Well, there's a few findings. This I started to peel a little bit. You can see this fibrous layer that's on top of the leaflet, right at the leaflet edge. And as we come over towards A3, we can see the calcific area build up already here. You have a hook, like something a hook, and you can see this calcium burden right in here. And interestingly, there's a hole in the anterior leaflet, which I'll show in a second. That maybe that's why we were seeing some regurgitation periodically. Can you see where that hole is?
Yeah.
Oh, that's big.
The hook.
Yeah, okay. Oh, yeah, right here. There's a hole where my forceps is going through it.
Come in. Be closer.
Yeah, we can see that pretty well, Mark. So that looks like it's in the area of the calcium. It looks like the leaflet's fractured and created a hole there.
Yeah. So I think what we're going to try to do is get this calcium off, debride this off the leaflet, hopefully without damaging it, repair that hole. And we can see the commissures are very fused. See over here?
Yep.
Right here, the commissure, there's a very long way we'll be able to open that up. And then the other commissure here as well is very fused right here. So we'll open that commissure and we'll open this commissure and try to decalcify this valve.
Mark, what's your view? That's pretty interesting with that. That's probably that sort of fenestration in the anterior leaflet is probably secondary to the calcium, as
I think
Ram
so.
said. But what's your view of the cords at the moment?
Oh, yeah.
I've seen shorter. They look shortened, but not too bad at first. What we can see of cords to A2 is pretty much all we can see. There you go.
Yeah, there's A2. They look good. Those cords look nice.
Yeah, not too bad, right?
There's A1. Cords look all right.
That's a nice. That view there is very nice. We're looking in now.
You can see and this is classic rheumatic. The portion of the leaflet up by the annulus is normal, very thin. Let's look at the posterior.
Mark,
cords.
did the echo correspond with that? Because this looks like it's fairly localized to that A3 region. Did the echo pre-op, the TEE, suggest that it's just localized to one section?
The 3D images did show, yes, that A3 seemed to be where the heavy calcification was and the mass effect. So I think that's what we're going to address. We need to decalcify this.
The
I don't know.
calcium seems to be behind, a little bit behind the leaflet.
Yeah.
Are you debriding by simply blunt dissection? Or do you start sharp and then start to peel?
We're going blunt to try to find the peel of the edge of the fibrosis. See, I'm trying to grasp just a thin layer. Yes, right there. You can see the layers coming. Dr. Ketcher's grabbing it from me. Passing.
It doesn't work. Do you have any
There we
like
go.
finer pickups, Gerald? Or
Here, I
something?
got it. I got it.
Fine.
I'm sorry.
Yeah, can you? Those might be
You're
too
relying
fine.
on forceps. Would a pen filled or some other type of freer separator help with this at all?
Yeah, we're gonna try to look for a freer. You think
Do you have a spatula or
like
some sort of
you know, a freer elevator? It looks flat.
like a little?
Do you guys know how to say freer elevator in Bengali?
Yeah, like spatula to clean.
Here's another edge of the fibrosis right here.
I think the emphasis here really is it's really painstaking, isn't it, Mark? Because if you make too big a fenestration in the anterior leaflet, and then in terms of repairing it, you lose leaflet body by definition, and then you end up having to augment, and then that's when the concern about durability comes in, because putting in autologous pericardium is automatically going to lead to a period of to calcification in a while, and then you don't know how long your repair is going to last.
Well, certainly it would with bovine pericardium, and
Yeah.
I don't know. That's a good question about the native.
I mean, a
whether-
small patch in a very limited region may be okay. We're not if you had to patch this if you
Because it looks like this calcium is really affecting this portion of the leaflet. We may have to patch this.
resect that area so that you're not
And Ram, you would use this fresh. You wouldn't can the pericardium, would you?
well at this in this location a very limited period of time or fresh would probably be adequate. Wouldn't go for more than 3 to 5 minutes in if we were to tan it with glutaraldehyde. But I think in this location you're going to have it's going to butt against that posterior leaflet fairly well. So I think even a fresh would be fine.
Yeah, there's calcification of the leaflet that's
Extends in-
extends almost full thickness. What can we?
There's a sprayer right here.
You want to try here? Try. Clean, yes, thank you. Whoop. Okay, good. Hold it. Is that coming out the back?
Yeah, or just like, yeah, you could you might still.
Rather, because I got it.
I'm trying to. Your
Yeah,
tooth
no.
there.
Yeah.
Do you have we call them a biter, up biter, that like chop and pull? Like a. Yeah. Maybe something smaller? Yeah, that's big. Okay, good.
Mark, it looks like there are some secondary cords underneath there that seem to be fairly thickened as well. As your plan to divide some of those attachments while you're looking at it through the
let's look
leaflet?
underneath. Yeah, let's get the hook and take a look underneath.
Mitral hook.
Where the cords are. Yeah, there's probably a cord going right to this calcified portion. Yeah, there's cord. That's primary though. That one's right there. If we can, those we need to preserve.
Yeah.
I think.
This one.
That's primary.
This there.
I can actually see through.
I know.
I don't know that there are cords right under this area.
Yeah, it looks like those are just thickened edge of the leaflet there, which looks like you're trying to get it, keep that primary cord attached and then trying to debride it from behind.
Mark Pirozia, how broad is the calcified area?
It's very limited. I think it's just this half centimeter to centimeter area of the leaflet. The rest of the leaflet is not calcified.
So the question is, why not excise that and do a sliding plasty? So you don't need any pericardial patch.
We might be able to do that once we do the commissurotomy because it will the leaflet will release.
Correct.
So we'll get it
And-
cleaned up first and then see if it will.
And you can knock off all the secondary cords to the A3 and P3 and limit
There's
the restriction of
secondary
the
cord,
leaflets.
I think. Was it? That one's short. Right there is a cord that. See if you can get the.
Hook, please.
Yeah, I think we're going to end up resecting this portion of the leaflet. Those are. Yeah, I think you're right. Let's just keep cleaning up this area. We can reimplant those cords or replace them with Gore-Tex. Like that. How about the freer elevator? Yeah. There we go. That's the crud on the top. Is that peeling?
Extends still here.
Yeah.
The entire thing is chunk of calcium still here.
Oh, yeah, I think that, but that's going to be mobile. Yeah, we could right here.
Right.
Between those two.
No, like on one side, to keep the two cords together, we can use them.
We have a question for the other surgeons in the audience. Do you see more involvement of the A3 region compared to other regions of the valve?
Can you
Is this
hold this?
heterogeneity in distribution of rheumatic
hands over.
common in your practice?
Okay, I got it.
Okay, that's just the back of the leaflet. Calcified.
More posterior leaflet typically involvement.
There we go.
Mark, the audience is saying here that this is really atypical for rheumatics that the audience is seeing. Most common involvement is in the posterior leaflet. So this is quite unusual.
Yeah, if it was posterior leaflet, obviously we would just simply cut this section out and put it back together. Like a standard triangular, quadrangular resection. But I think I've got sort of the end of the calcium right here.
Freer?
Yeah. Freer? Yeah.
What we see here also is restriction of the posterior is the commonest thing that we see, but we do see a lot of prolapse, mostly in A2 and A2.
There we go. That's it.
So they will come in late adolescence sometimes, like sometimes even like young adults that say, there you would find that this hasn't reached this stage of getting those tips calcified.
I think I'm going to get rid of this piece. We'll have it cleared up. Beautiful view of the cords right in there. That might be the secondary cord that's going right to this, right here. What do you think? Dr. Castro?
That looks like a secondary cord to us, Mark.
Okay. There, right. This cord right here. And it's kind of thick. Can you put the mitral retractor behind it? Here's the primary cords are here, here, and here. Primary. We think this is secondary right here.
Yeah, I think we agree. The
Right there, that cord.
what you were saying, we agree with. Once you've got this off, you need to separate the commissure and see what you've got.
So we cut that. Let's cut that cord.
How is there any calcification of the annulus, Mark?
In regards, no, the annulus is clean.
So you can, if you could do a primary repair, it would be ideal of the anterior
Recording
leaflet,
stopped.
and then potentially
Recording in progress.
do a slight reduction annuloplasty if you lose a bit of area in repairing the anterior.
Yes, that's our, I think that's our plan. Oh, boy. Yep, that's good. I think we should cut this off, don't you?
Wait, that's anterior.
That's anterior leaflet, yep. What is this?
Can I get the crochet, the mitral hook back, please?
Okay, that's the cord.
Okay.
Have, scissors, Mets?
We're denoting
Whoop,
anterior
yeah,
leaflet.
scissor, Mets. Do you call them Mets and bums?
Scissors. I think we're denoting it.
I'm not gonna cut, I'm not gonna peel anymore. Okay, let's see what we got. Okay, forceps. Another? There, another. That's good. Those cords are good. So I think this needs to go. This is the mass portion. Calcific mass portion. Right? This. That's good. That's good. Yeah, cut that, and then we would be able to. You think? There's that? Yeah. Scissors? Here? We're just getting rid of the calcific mass portion of the leaflet. Gone. I think the rest of it is. I don't know.
Recording stopped.
That's probably okay. Yeah. So let's we're gonna assess the commissure, open it up like you guys suggested. Do we have a right angle?
Recording in progress.
We want to see where this is the commissure right there. We don't want to cut any cords. That would be, all right. I think we want to keep more on the anterior side. Right there.
Right
Down there.
Yeah, down. Right
Okay. No, because I'll hold it. I just want to decide which side of this cord to go on. Can you grab the posterior leaf with you? Can I have the mitral retractor again? We're just trying to decide which side of this cord to cut. You see where this cord is? That's probably T3. And so I think we will cut on the anterior side of that. So this what direction? I'm going to put a right angle in there so that Dr. Capture can cut it with an 11 blade, probably within about two to 3 millimeters of the annulus.
Can you see there's always that spray? We can't see it from here. There's like a spray of cords to the posterior commissure. From where we are, that looks like the commissure you've just cut there.
Yeah.
That looks right
Yeah.
there.
One more millimeter. That's good. Yeah, we just opened it up from here to here, about a good centimeter, really. I don't know if we. Okay, well, we'll cut both sides and then we'll get you guys' opinion as to whether we can do a sliding plasty of that or not, or whether we're going to replace this missing portion of the anterior leaflet with a piece of native pericardium. Okay, there's a splay. I don't know if you guys can see it, but there's posterior leaflet cords, anterior leaflet cords, and that one's more natural. We can tell where that commissure is. Watch out for that cord right below. You don't want to cut that towards me. Yeah, you can see it through. I gotta cut through where the hole is, I think. Yeah, that's good. And then towards me, I think. That's good. So we just. I'm wondering if it's a little too posterior there. Why didn't come up with this Yeah, that's good. So we've opened up the posterior leaflet quite a bit. A lot, actually. Got a ruler? You have a ruler measure? Centimeter, 2 centimeter, kind of thing? Yeah. Here, why don't I hold it and you measure? We're just measuring how much of a commissurotomy we did here. That's over a centimeter, centimeter and a half on that side. On the other side, about the same, centimeter and a half on both sides. That anterior leaflet's now quite mobile. No, that's first. I think we cut the secondary cord. I think that was important. That is primary. It's kind of short, but okay. Should we? I don't know. Or just leave it as our. Yeah, there's a little bit more to decalcify on this side.
For your, please. The spatula.
Mark, if you're thinking what we're thinking, we were suspecting that you could slide this and get it primarily together rather than a patch.
Yeah.
Yeah, that would probably be better. You guys think?
Yeah, I think a couple of us sort of felt that
well, I
you
would
did a
leave
good.
this.
You had a pretty good opening of the commissures on both sides.
This is what I'm thinking. Yeah. Yeah, we're gonna just finish cleaning off this portion, this side of the leaflet, and then we'll see how we can put it back together. There we go.
And to begin with, you didn't have much of a gradient across the valve. It seems like the regurg was mostly coming from that hole, so you'll take care of that.
Forceps? Oh, I think that's peel. Actually, now that you look at it, see it? I think this is peel. Yeah. You see, guys, you can see an excellent example of the peel we just pulled right off. Now that anterior leaflet looks, you see this piece?
Yep.
That was all on the atrial side of the leaflet. And now we got it completely thinned out here. Nice. So if we're going to do a sliding plasty of this anterior leaflet, we're thinking to cut this way, right? Correct? Towards the commissure. Is that what you guys are thinking?
Mark, I think you can cut both ways. Like you can cut even into the annulus of the A2 and slide it.
Are you sure? I don't know.
Because if you slide only one way, you might get a bit of restriction.
Okay.
But this looks great actually now.
I'm taking a little bit more peel off. I want to go deep there.
And you've gained so much of area because of the commissurotomies that little bit of sliding is not going to have too much of a negative impact on your area.
Okay. That's what I'm thinking. I just need to know where we're at. Okay, that's good looking leaflet there. I think we could, yeah, that's what, yeah. Just try. Okay.
Mark, are you going to look underneath, through there, make that hole now on the anterior leaflet work for you, and take a look for secondary chords to A2 and A1, because it's looking so nice on A3 now. The bits that you've peeled off.
This is the secondary cord we cut.
Right.
Yeah,
not too many from the look of it.
Doesn't look like it. That side doesn't look to be too affected,
No.
This one. Okay. So I think we've kind of debrided enough. There's a little bit of excess tissue here we can cut off, you think? What do you think? Leave it.
So have you retained the free margin through the whole?
I think we have, yeah.
You got a free margin.
Cut off this piece. Scissors? There's some more debris, fibrotic debris. That? Yeah, that's just garbage. Okay, I think we've kind of cleaned it up. Now we just got to figure out how to get it back together. we've got leaflet here. Yes, this is leaflet there. We need to put that back together, don't you? Hmm?
Yeah, I just want to see if we need to patch though now, because we have a big.
It's kind of a, what do you say?
What do you think? Sorry? 30 minutes. Oh, that's okay, thank you. 30 minutes.
Okay.
I'm gonna be able to slide.
Slide it like that. No.
Then you can.
But what you're, this is the anterior
I
edge.
know.
So. I know. We can do that back together, and then like this.
Some of it's very thin. In P3 is very thin there.
Yes, it is. I think that's normal. That's where we peeled off all the fibrotic material, but it's thin. You're right.
Yeah.
I don't know. That looks, boy, it doesn't look like there's a whole lot of missing tissue.
You can just primarily repair and then put these two back together.
All right. Yeah.
Yeah.
Right
Well,
there,
what
then.
would you? What is your
Double.
technique for repairing a leaflet? If you do any leaflet resection and then if you do the standard P2 resection and then put it together, how do you suture?
Yeah, I
P1 to
just,
P3.
I just generally do a double layer of the proline suture, 5/0 or 4/0, depending on the.
Do you have Cardinal that Carpentier used to like so much?
Yeah, the
I think he patented it. That's why I liked it so much.
Exactly. It's very helpful. The guys are getting us a 7/0 to work here. This is very thin tissue, as you said. So we're gonna see if we can. We want to this A2 segment that's where we debrided. We're gonna put that back together a little bit first, and then what we'll need to do is patch or put A1 to A2 or A2 to A3. I'm upside down, so my 1s and 3s are backwards sometimes.
We've got
No, I'm only
we've got a big audience of surgeons here and some very senior surgeons, including the current president, the Indian Association, all here. I'm just going to reach out to the audience and see if there are any comments from anybody.
A little bit, I think.
Yeah. Has anybody in the audience got
Real little.
some ideas and advice for Doctors Moon and Kachu?
Towards me.
Mark, there's just a concern that's been raised about just tissue, dropping into the LV from an embolization perspective. You're keeping your eye on that all the time.
Yes. Our assistant here is continually cleaning our forceps, and what we're going to do is wash it out here in a moment when we're done and take a look. But we can see very clearly into the ventricle.
Okay.
And we'll get it washed out.
Yeah, that's such a tragic complication, is it not? In any patient to have a great result and have a neurological injury.
Three's good, huh? Do you have a shod, a rubber shod?
Yes.
Yeah, good. Well, you have to do them both, right? But I don't know which one do you want me. Okay. Okay. Yeah, let me follow you. Yeah, you're going to do it forehand.
Mark, Ram's just said we're going to switch across and just
Okay.
see where they are getting on in the other OR. You're just going to now repair that slight defect you've got.
Let me get the stitch. You pull it. I don't have it.
So, Mark, we see what
Okay.
you're doing, and
Yep.
we'll be back with you in,
Okay,
in
sounds
5
good.
minutes. All right.
Yeah, right on the edge. So we don't
Should we move across to the other room?
Camera, please. Can you move this back? I'm sorry, just for a minute, and then I'll show you.
Should we go to? Can we go to operating?
Yeah, just a little bit so we don't roll it in. But that's this side okay. That not so much. Yeah.
I just make a small announcement. Whatever is happening in OT2, we'll have a recorded section of it right after this case gets over, and we have a talk by Dr. Piros. So after the inauguration, we'll have a recorded section, so no one miss out anything. Thank you. So over to OT1 again.
Short
Yeah.
advances, so we don't accordion it.
Needle is like the tiniest needle on the planet.
No, I mean, can we not have a small glimpse there in the meanwhile?
We were just wondering if we could go across and just, in case of asking Dr. Malestri some
Dr.
questions.
Shomoji? Dr. Shomuji, are you there?
Hello. Hello, Sanjay, are we audible?
Yes, sir. We're audible. Yeah.
Sanjay, we will just ask Chris to give us an update of
Microphone
the next
on.
walk for 5 minutes, then we come back
Yeah,
to
right, sir.
OT1 again.
Right, right.
Not here.
Hi, Chris. Ram here. How are you? Looks like you've gotten in and getting cannulated.
Yeah, Ron, we're on pump right now. You guys can hear me, right?
Yes, I can hear you well.
Yeah, we're on pump. So I've been seeing this for ages. A metal tip. Ron, you probably use this all the time in pediatrics, but metal tip arterial cannula. We have that in the proximal transverse artery to the level of the innominate artery. This large venous 2-stage here, it's flat in the center. It lays pretty nice, actually. I like this. And Dr. Niraj is putting in an LV vent through the right superior pulmonary vein.
Great. Any observations initially looking at the root? We were concerned about a dissection potentially.
Yeah, we'll see in a second. Once we cross clamp, we'll show it to you, but you can see how large the aneurysm is on the non-coronary sinus. Let us put this LV vent in first.
Chris, what's your plan for, you said antegrade cardio with the AI, how you plan to manage antegrade? You're not going to give retrograde for this case.
Well, it's going to be a Del Nido, and Dr. Del Nido said all this, that has to be all antegrade, so we did not put a retrograde cannula in. So I think we'll do is we'll cross clamp and open up the aorta, and then give direct steals.
Right.
Niraj, do we have an antegrade needle or a cannula? Yes. What does it look like? Antegrade? Let's see what the antegrade looks like. Yeah. Okay, good. Well, we got an antegrade needle. I think we'll try to at least stop the heart with the antegrade needle first after cross clamp.
That'll be that one. That's not going to touch against anything. Okay,
Hello.
so
Okay, chair, another pair pickup?
Hello. Can you hear me, Sanjay?
Yeah, I can hear you.
So we are coming back to OT1.
Okay, okay.
I think we leave.
OT1 feet, please.
Right, so what do we do with this? Is this, can you hold this open so I can see? Just wondering what to do with this. Just leave this garbage here.
But it's this cord support.
Hi, Mark.
that's
We're
cord,
back. We're
So
back
if
with
they
you
leave
here.
it,
So
the free edge and then primarily bring these two down.
They were talking about a sliding
You don't
class
need it.
B. I don't
Okay,
think we need
how
it.
much?
Dr. Mark, can you hear us?
Yeah.
Yeah, we are back to you.
Okay, good.
Yeah.
We have,
Please.
let's bring the camera back in. We'll get the camera back in here. We've got the A2 put back together here now. And so what we've got is where we did the debridement. We think we can just primarily put that together. We don't think we have so much free tissue from releasing the commissure that I think this will be plenty of tissue.
Yeah.
Without doing a plasty or adding tissue. Think.
looks like you made a transverse connection between the edge of the leaflets where the chordae were coming into the body of the leaflet in that
Yes.
the O2 region.
Yes, we did. That's where the calcium had gone all the way through the leaflet. And so where we debrided it. But we don't have any calcium left. This leaflet looks, I don't think this is going to be under tension. There's a lot of leaflet. So you can see do you guys have a sizer how about that 27 sizer? Ring. Taylor. So this is her BSA was what, 1.3? 1.3. She's quite small. This is a 27 Taylor, which is a flexible ring, fully flexible ring. That looks about that'll be fine, and we'll have plenty of anterior leaflet.
Yep.
Do you guys feel any differently? Let's see the 29.
29.
What do you want to put it together with? What,
Another
7 or that? See, that 29 that'd be huge, I think, on her. She's 1.3.
Yeah, we saw her yesterday in the clinic at the Echo, and she's a very small person.
The edge for
What do you want,
line it up
6-0?
and then- Yeah, let's shot him and then I can run it. You know,
So put them together here.
Yeah,
They can
exactly.
start here and go down. Yeah. So 2 sutures.
yeah. So
Okay.
line them up and then I can run it from the top towards the free edge.
Right.
Okay.
Agreed. We're gonna need 2 6-0.
So, Mark, when you stitch the leaflets together, do you use continuous running or you use continuous interlocking?
We did continuous running. Now, of course, when you do continuous running, you want to make your advances quite small so you don't kind of
Pucker the leaflet.
pucker it, or like I say, accordion, turn it into an accordion.
I'll take a shot on this side. Oh, okay.
And do you want to be down where this is where the cord is down here? That's the primary.
Right here. I was gonna just line up the free edge and then I'll put it
Okay.
together. And then we can do whatever.
Okay.
I just kind of put the two sides. So I know where
Okay.
to stitch to, right?
Yeah, and we'll go all the way to the edge. So we've got a 6-0 in here to kind of align up, to give us alignment so we can see where we're going to put this back together. That's okay. That's 6-0. We'll use the 6-0. We used the 7-0 for the very thin portion of the leaflet before, but here we'll use a 6. And we'll advance these very small advances so we don't do it accordion.
Is
Yep.
there a cord going
That is a
exactly?
cord. I just noticed that. I'm wondering, shall we cut that?
Yeah, I think so.
Yeah.
It's not
I
very-
think so. Let's pull up and cut this cord right there.
Okay, 11 please.
Let's cut it in the middle. We can use some of that as buttress. Yep. Yeah, that was good. That saved us. It wouldn't have looked good at the end. Thank you, Bruce. You want to tie it? Put 3 throws? Can you squirt us a little bit?
Squirt a lot.
I know. It's close enough. Okay. Yeah, perfect. Okay, then I'll follow here. So we've got it lined up now, how we want to give it a go. The 7-0, 6-0 needle is quite a bit bigger than our 7-0 was. Yeah, please. So I can't see anything, so I'm looking at the camera now. Yeah, that looks good.
Yeah, well, Mark, this tumor leaflet now looks pretty nice after a good amount of cleansing that you have done. And you know, I think this anterior looks a bit thicker in comparison to posterior. I mean, towards the annular side of the leaflet.
Hold that straight down.
So do you like to do that? That will be taken care of with the 6-0 at the anterior. I mean, towards the anterior edge of the leaflet.
What was the question?
However, that looks less rugged than before, but it's still, you know, it happens to be a bit thicker.
Yeah, this portion right here is a little thicker. Yeah, yeah, there's some fibrosis there. Yeah, we didn't hear that one clearly because
I think the question was that the leaflet towards the base is much thinner than
Yes.
towards the edge.
Yeah, oh, definitely. Yeah, I mean, that's the classic, with rheumatic. And it also was not that thin when we started. We peeled that and made it thin, by taking off the fibrosis with that calcium. And so yes, it's quite thin, actually quite normal. Don't advance too much there. But you can get a good bite of the tissue there towards the,
We're just gonna take the other soup,
coaptation.
so- You want to take the other soup salad?
Well, we should save it.
Well, because it's getting tangled up.
I know. Here, if you move your hand, I can do it, but I can't see the other. Where's the other side of it?
They're on both. on
Oh,
both
oh,
snaps.
okay. Take that for a second.
that was good.
No, this is,
It is, it's not even here. Nerpa, or do you have a, it's a pair.
So, Mark, have you got primary cord right at the end? I can see a primary cords
Yeah.
right on each side of the defect. Do you have a primary cord next to A3 near the commissure, or
I'm gonna hold that. Yeah, I'll get a hook around it in a second.
Opposite
Wait,
side.
let's make sure this is the right one. Okay,
These are the two
they're
six
sliding
ones.
together. Okay.
That's why I said this got looped under. so
Let's,
we'll take it out.
let's just cut one and leave portion in case we need it. Scissors? Right here?
Not for me.
Right, and then just take the whole thing out. Drop that. No. Yeah, good.
Thank
You can save 6-0? Okay. Can I have the mitral hook? You can see we've now put together probably 2/3 of it. And yes, there's a primary cord right there I've got hooked. No, wait till I show the cords. And there's a primary cord. So here's one that's to the A3 side. And then there's one that's right, here, let go. That's right at the A2 side. So we've got primary cords on both sides. This is nicely supported. Just grab the whole thing, full thickness. Yeah.
Lift.
Okay, yeah, and then you can leave that.
Should I tuck this underneath?
Yes, just leave it, and then take the bite above. I do that in 2 bites.
Yeah.
Yeah, that's good.
I know Gilles Dreyfus is always emphasizing how important it is to get a nice smooth area of coaptation if you can.
We are going to, yeah, we're getting all this material in the back.
Are you burying it? That'll
Yeah.
be very nice.
No, I get under there. Yeah, that side. So it'll look thick when we're done, but it should be quite mobile.
The posterior leaflet won't know how thick it is, right?
No, I don't think so. You guys will though on the echo, so don't be critical.
So this is the bit that's this is the 7 or 8 millimeters that are going to be opposing the posterior leaflet. So this is nice and smooth. That's important, and that you're achieving that nicely. It looks like.
Yeah, this is actually, we are now into the place where we did the commissurotomy. So we're using some of the new A3 that was part of the commissure. Yeah, you can get a good bite of that.
Very much restricted.
And then down into this, is that the leaflet? Is that a cord? Yeah, I go get the cord. Yeah, and then tack it up. Oops. That's good, I think.
You and Dr. Couture are operating very nicely. We don't know who's throwing the sutures and who's.
I'm. Are you done?
It's happening very nicely.
Yeah, that's. I'm just standing here. At one point, I couldn't see anything that was going on because our surgical team was helping follow. Dr. Katchu was putting these bites in. The suture's too small for me to suture.
Hello.
Hi.
Sanjay, can you hear me?
Yeah, I can hear you.
Yeah. Going to the OT 2, Dr.
Okay.
Chris Morris will explain what he has.
Let me just show you what we got, and then you guys can go. So here we've got, we've now put A2 back to A3 with one layer of this 6.0. We're going to take another layer of this 6.0 to reinforce it. And then you have the valve tester with the bulb. Okay, relax this. Yeah, perfect. And
We're going to go to the other, but could you do a test? Oh, we're in the other, but we'd like to see a test. Anyway, we've moved to the other OR.
We're in. Okay, Cliff, can you see my head cam?
Very, very nicely, Chris.
All right. All right, so we have the aorta open here. Here's a cross clamp. We've opened the aorta. Niraj is giving givers down the right coronary artery here. We just did the left. Here's the aortic valve. And here's the surprise focal
Do
you guys see this?
we moved back to the mitral theater. We can hear you. We're going to come back to the aorta. That's good. We're back with you,
We're
Chris.
back. Okay, well, here's the focal dissection of the root. So here's the intimal flap. This is the false lumen. And here's the non-coronary sinus. So that's the etiology of this aneurysm.
I think you and
right here.
Ram suspected this because of the very asymmetrical nature of this. I'm going to hand you to Ram, see if he's got some comments.
Certainly looks like a broad area of dissection there in the non-coronary sinus.
Yeah, I've seen several of these already. It's an unusual place to have a sinus of Valsalva aneurysm, right, Ron? Usually, Ron,
Yes.
it's usually in the right coronary sinus. We know those can fistulize to the RA or RV. I've never really seen it from the non-coronary sinus. Mark Moon and I were suspecting a focal dissection here, and here it is.
Yeah, absolutely. It goes all the way down to the, how far down does it go to the annulus?
I think it's going to go all the way down the annulus. Yeah, that shouldn't be a problem for us doing the valve sparing. Niraj, are you happy with the Delmito?
Oh, yes, sir.
Is that enough? I usually give 1.5 liters. Ram, how much Delmito do you dose?
Yeah, we usually give a liter to 1.5 liters. That's right.
Just 300?
A liter to 1.5 liters, correct.
Total.
Total.
1,500.
Total 1,000. Okay, that's it. Off. Yeah. Scissors, please. Okay, so we'll get a better look at this aorta here. I'm just going to transect it here. We'll get rid of this thing here. Yeah.
Chris, now that you've got this pathology, how's your thinking changed now that you're dealing with this
Diathermy.
as your localized dissection? You got pretty normal left and right commissures, presumably, with your pathology.
Keep pulling right here.
Hello. Hello, can you hear
I
me?
think our strategy remains the same. but
Just hold on,
we are-
Shomajita, once.
We are moving to OT.
Shomajita, just hold on for 1 minute. They're having crucial discussion as to whether to go for VSSR or Bental.
Okay,
Dr. Chris, please go ahead.
Okay.
Yeah, strategy remains the same. We're going to do a valve sparing, but
Okay,
certainly
that's
my confidence is a lot higher.
that's a good news for us. Yeah. So Shomajita, over to
Bites into the edge of the leaflet coaptation point.
Dr. Mark. We are at OT1. Back to you.
Okay, good. Yeah, we're just finishing up the leaflet reconstruction. One more bite probably here, and we're good to go. And we're gonna tie it down, and then we'll test it with the bulb and see if the leaflets move okay, and make sure that the commissures are okay with closure after we did the commissurotomy.
John.
These gloves are a little sticky.
Okay.
Thank you.
Well, Mark, can you hear me?
Yeah. Scissors?
Yeah, the leaflet looks quite fantastic. But my concern is, patient is having a FIV. So would you like to do some exclusion procedure with a left atrial appendage? Because
Yes.
in this condition, so because it's contributes very little to the hemodynamics of the
Yes.
patient. So if you want to do something, so what will you do in this
Yeah.
case?
Right, I think, yeah, so we're definitely going to exclude the left atrial appendage, which is over here, but we'll get that into a minute. Well, we're going to exclude the left atrial appendage, which is over here, but we'll get that into a minute. Well, once we put the valve sutures in, probably once we put the ring in as well. But the atrium is so large, we would, in order to get a reduction, we can do the anterior surface quite easily. Posterior surface, we'd essentially have to do a maze procedure to do that. I mean, the old time maze procedure where we cut up the pulmonary veins. I think that might be a bit aggressive. Once we fix this, we're going to be, I think, in good shape. But here's the appendage. Can I have another forceps, long forceps? Good. Is there yeah, okay. Why don't we get you got a proline, 3O proline? Here's the appendage inside out. It's going to be a huge appendage, no doubt.
Yeah, really it's used and
We'll do double air running, huh? This is part of the appendage.
Mark, can we do the water test?
Oh, yeah.
Because we have to get to the other OR.
Yeah, okay, let's
soon.
do that. Help me. But don't pull
The
them up.
anterolateral commissure looks a little bit
off.
unsupported, I think.
The anterior lateral?
Yeah.
Okay.
Or just, I don't know, we can't see it very clearly, but.
Anterior lateral. Let me look at it because we haven't actually inspected that yet. There's the very edge, yes, might be unsupported. There's a cord right here. There's a cord right here.
Yeah, but deep into the.
We could either
You can.
do a magic stitch or put cords on either.
Yeah, magic stitch, I think many times works well. Then.
Magic stitch?
Yeah.
Test it.
But let's test it first.
Yeah, sure. I want to look at the other side too. The other commissure. The other commissure we've left, there's cords right up to the edge. I think. Yes. You guys see the mitral retractor?
Okay.
Here, there's a cord right at the commissure. I'm trying to hook it, but yeah, right there's a cord. So that one's probably supported adequately. Okay.
Looks that is my view of the anterior commissure, Mark, is you don't want to.
Can you see the anterior commissure? This is, I meant on the camera. Can you look at the camera?
Well, if you do, I mean, it's no good just putting back together what you just cut, right?
Well,
you got to shift it a little bit to.
Yeah.
To.
I think we can put a cord on that. No, we need the power sucker. I think you're right here. We'll need something to support. I need a longer forceps. Thank you. See, the anterior leaflet looks pretty good there, I think. There's certainly no prolapse anymore. Can I, another fill? Yes.
Is your yellow off? Off. Yes. Okay, good. The ventricle's not so where I'm like.
Well, I know.
Yeah, absolutely. Mark, we were just wondering whether you might put a ring in first and then see what you've got. And
Okay.
you can always put a magic.
Oh, there we go. That's a good view. Can you guys see that?
We see that nicely.
That's good coaptation. I think I don't see prolapse of the commissure. So yeah, but why don't we put a ring in and then we will take another look.
Yellow back on.
If you did, it would be pretty small, pretty short magic stitch,
what?
just right at the edge, maybe.
Nah, let's do the ring.
Yeah.
Okay. Okay. We're gonna close the appendage, guys. So if you want to go visit with Chris for a minute.
3-0, please.
Right up here. Bill,
In the meantime, here at auditorium.
Okay, we're leaving you, Mark.
Yeah,
Okay, we'll be about 5 minutes closing
yeah,
up.
Sure, Mark. Yeah. In the meantime, here at auditorium, we have one of the scheduled talks. We have here with us Dr.
Wait, can I have a shot?
Piroz Daviriwal.
Stop for a second.
Having done his MCH at Mumbai, India, he had a 3-year clinical fellowship at Toronto General Hospital, following which he had a staff position at Leipzig, Germany. And presently he is associate professor and surgeon investigator at Toronto General Hospital. He's going to talk on step-by-step approach to MICSC ABG. Over to Dr. Piroz.
Doing two.
No, we got a whole. Watch out, kids. back there, I think. Somewhere. You're all right. Well, I would go over here, because that will roll. Because you're going to have to go all the way here. Real.
Slide. So first of all, I'd like to thank Dr. Sarkar and the AATS for the kind invitation. It's been a great meeting so far. Excellent first case, and we're looking forward for the next 3 cases as well. So in the meantime, I thought I'll give you a short talk on a step-by-step approach to minimally invasive multivessel CABG. So the first actual step starts before surgery. Selection of the patient for a multivessel. All patients are not suitable for undergoing a multivessel off pump. If you want to do it off pump, if you plan to either do it on pump or clamp the aorta as Dr. Babliak in Ukraine does it, then yes, you can use this approach as an all-comers approach. But if you're planning to do it off pump, then I think you do need some amount of selection. So the most favorable patients to undergo this type of surgery are males with a body mass index preferably less than 30. As you gain experience, you can obviously go higher. And I think the most important is the cardiothoracic ratio. So patients having a cardiothoracic ratio less than 50% are ideal, because this is a ratio which gives you a relationship between the size of the heart and the size of the thorax. Because if you want to do the surgery off pump, you have to remember you do not have the luxury of enucleating the heart out of the thorax as you do in a sternotomy approach. The entire movement and mobilization of the heart has to be done within the thorax, and there's a limited space within the thorax to do so. So the more space you have, the better it gets. As a result, if you have a very high cardiothoracic ratio, like 60-70%, which translates into a dilated heart, then it becomes very difficult to mobilize the heart within the thorax without causing hemodynamic compromise. So a surrogate marker, again, for the size of the heart is the left ventricular internal diameter, which should be preferably less than 50 millimeters. Lung function should be relatively normal. You avoid a right internal thoracic artery harvest in patients with pectus excavatum, because in those patients, the artery disappears behind the sternum because of the pectus. So it's very difficult to harvest the right mammary in such situations. And in patients who have undergone radiation therapy, especially in the 80s and 90s, it's sometimes difficult to take down the right mammary because it's stuck because of adhesions. So you preferably would avoid using a Rita harvest in such situations. And of course, you want to choose good coronary targets, especially when you're starting off doing this procedure. So you avoid intramyocardial vessels, you avoid heavily calcified vessels where you suspect that you might end up with a large patch or an endarterectomy. So the ideal patient as far as the coronary anatomy is concerned is a patient with 2-vessel coronary disease. So you can see here the patient has a normal right coronary artery on the right side, and on the left side you see he's got just left-sided disease. These patients are ideal for a left-sided approach. Or you have patients in whom you have a non-graftable right coronary artery. Either it's because the right side is completely burnt out and does not need a bypass, or in patients with I don't know why the videos are not. Was that? They were all autoplay, so they should play on their own. It's autoplay. Can you put it on presentation mode? I don't need this. video. It should have played. I don't know why. Can I get my laptop?
Yes, sir.
I'll just get my laptop.
Yes, sir.
Okay. I'll just use my laptop.
Logo मारो.
When you bring the other guy down. Okay. Real stupid. Yeah, right. That's a good turn.
So, as I said, you can also choose patients with three vessel disease who do not have the need for right-sided grafting. And the third situation is where you can use patients with three vessel disease who can undergo hybrid coronary revascularization. So as you can see here, you have right coronary artery disease on the right, you have left-sided disease on the left, and you can do a double vessel bypass. You can see that and the major advantage is you can test your grafts as well. So you can see in the upper, we've done a Lima-Rima to the left side, and the right side has undergone a PCI. So this is a great approach for certain patients. So what are the indications for patients? So which patients benefit really from a mixed cabbage approach? Then those are who are at a high risk of sternal wound infections, like those patients with uncontrolled insulin-dependent diabetes, obesity, peripheral vascular disease. But there is a caveat to that. You have to be careful with patients with peripheral vascular disease because putting them on peripheral bypass may be a challenge, especially in an emergency situation. Smokers, again, benefit from this approach. Again, a caveat that they should not have severe COPD because single lung ventilation is not possible in these patients. Patients with severe osteoporosis or other bone disorders and patients with long-term steroid use really benefit. Then there are patients who are handicapped, either dependent on crutches, they're wheelchair dependent, they have amputations of their toes or lower limbs, who really benefit, especially early after surgery. Then there are job situations which compel patients to avoid a sternotomy. So especially like bricklayers or patients who are truck drivers, for example, they would like to get back to work as soon as possible, and heavy lifting is usually not recommended after a sternotomy. Then there are certain individuals who want to get back to sports as soon as possible. So these are again patients who benefit from avoidance of a sternotomy. And at the other end of the spectrum is some old lady who's frail. You definitely do not want to crack open her chest. And these patients usually, again, really benefit from a minimally invasive cabbage. There are certain contraindications, the absolute ones being an occluded left subclavian artery where you cannot use the left internal thoracic artery, although you could use the right internal thoracic artery and base all your grafting on that. Patients with cardiogenic shock, this is one situation where you would never do a left-sided thoracotomy approach. Patients with severe COPD and severe obesity. Severe obesity is more amenable to a robotic approach rather than a minimally invasive direct vision approach. Then there are relative contraindications such as intramyocardial vessels, severely calcified vessels, and small vessels. So the incision is usually in below the nipple, submammary, and it's usually in the fourth or the fifth intercostal space based on the type of vessels that you're going to anastomose. And now if you're going to do the LAD, the high OM or the diag and the ramus, you would prefer to go in the fourth intercostal space, whereas if you're going to go to the PDA, then you have to be in the fifth intercostal space. The other issue is that your incision has to be more lateral than medial because you want to look at the heart from the lateral side. So if you're going to do the OMs and the PDA, you do not have to retract the heart too much to the right. If you're more medial, then you will be on the heart over the LAD. And to reach the lateral side, you have to really push the heart to the right, and it will not tolerate, it will not basically tolerate it hemodynamically. So it's more important to be more lateral, looking at the heart from the side. So we usually take down the I usually take down the left internal thoracic artery first. I always try and use the skeletonized technique. But even if you can take it skeletonized for whatever reason, it doesn't matter because you're not worried about the blood supply of the sternum in this situation. But I usually use this clip and cut technique, which I'll try and show you this afternoon as well. And you can take down the entire length. Here you see the bifurcation, and you'll also see up top the left subclavian vein. So it's a myth that you cannot take down the whole mammary artery. You can always take down the entire length of the left internal thoracic artery. So once this is taken down, I usually transect it after giving about 5,000 of heparin and then move on to the right side. So there are different ways or tips and tricks how you can expose the right internal thoracic artery for harvest. So in the early days, first I think 40 or 50 cases, we used to use this sub-xiphoid approach where we made a very small incision and used a hook and elevated the lower xiphoid process. By elevating the xiphoid process, you increase the space in the lower third of the anterior mediastinum, and that really facilitates the takedown of the lower part of the right internal thoracic artery. Many times you do not need the entire length, as also in this case, you need mainly the upper 2/3 of the right internal thoracic artery if you're just doing right-sided grafting. If you're going to do more grafts, sometimes it's also useful in taking the radial artery if you want to go all the way to the PDA. So what we do is we move to the right, we open the right pleura and push in a sponge in order to keep the right lung away. And here you can see clearly the pulsating right internal thoracic artery. Another trick that we nowadays use, and we avoid using this sub-xiphoid hook, is we put 3 silk sutures as lateral as possible in the pericardial fat on the right side, and then we bring these sutures out through through a small stab incision on the left side as posteriorly as possible. You can see here, and you'll see in how the space within the thorax increases. So this usually is sufficient in order to take down the upper 3/4 of the right internal thoracic artery. So takedown of the right is pretty much the same as you take it down through a sternotomy approach. Your vision is exactly the same. You're looking at it from the left side of the patient. You can use the same technique. The only difference is that you have to train yourself in using long instruments to take down the mammary artery. You should always remember that small movements at your end translate into large movements at the other end. So you have to be careful, especially with small branches, because they can easily tear off and cause a small hematoma. So that's the main thing. And as surgeons, you always imagine that the right is far away from the left, which is true if the sternum is wide open. But when the sternum is closed, the right internal thoracic artery is not that far away from the left. It's about 5 or 6 centimeters. So you have to change your imagination in order to, when you want to start doing it. So then what I use is I call it the graded pericardiotomy approach. So you don't open the entire length of the pericardium in one shot. Especially you never open the pericardium around the apex initially. Because the moment you will open the pericardium around the apex, the heart will herniate, and it straight away herniates into your incision. So there's no way you can do anything after that because it's just the apex and that's all in your incision. So you always want the heart to be within the pericardium all the time till you've completed your LAD anastomosis. And then you can go around the apex, as I will show you. So the initial incision is just over the RVOT extending up to the aorta. where you will decide where you want to do your Y graft. So your Y graft pretty much always has to be at the level of the pulmonary valve, more on the lateral side towards the LA appendix. So the next step is you construct the Y anastomosis. I usually use the Octopus Novo as the stabilizer. We'll just run along for the sake of time. So what I do is I use a single finger glove onto the pods of the octopus, and it is clipped on inside, and use this as a stabilization technique to stabilize the left internal thoracic artery. And the Y anastomosis is then performed under stabilized conditions within the thorax. So that really makes this Y anastomosis extremely safe. And here you can see the Y anastomosis is completed. And following this, I fix the Y anastomosis at the level of the pulmonary valve. Then we further open the pericardium as a graded approach. And following that, we stabilize the LAD and perform the anastomosis between the lima and the LAD graft. I usually use a shunt for that. And the anastomosis is a routine anastomosis that we all do for a lima to LAD, even through a sternotomy. Following that, we now move to the lateral wall. This is the high OM or the ramus, and it's very easy to expose this vessel without the use of any other heart positioner. And I use this silicone loop, clip it and cut it off, and then open the artery, and then as well. And following this, we use the starfish, head of the starfish, we call it the armless starfish, because it gives much more versatility to mobilization of the heart. So the starfish is usually placed on the area of the heart where we want to perform the anastomosis, and then the area of the anastomosis is stabilized with the stabilizer. So here we see the starfish has been put, and then once you elevate the starfish, you can see you can expose the vessel. This is the circumflex, which is in the area of the PLV. In this case, then you put the stabilizer, and once it's stabilized, you can perform the anastomosis. And this is the last thing. If you want to do a PDA, you can do it as well. You can place the octopus even through the incision if required, and perform the anastomosis between the PDA and the RETA. So, just for the sake of time, so that's the way you do it. You can also use it as an in situ LETA RETA. You can use the LETA to the OM and the RETA to the LAD, or vice versa, and do these techniques depending upon the grade of stenosis. And that's basically what you have. There's no risk of sternal wound infection. And for the sake of time, I think I'll stop here. If you have any questions, you're welcome to inquire. No, we put, if you're taking the mammary, then we took 2 drains, 1 for each pleura. You want to go to the? Yeah.
We can have the discussion when the MICS CABG will be fed in here. We can have a detailed discussion. Let's go back to OT1 once. Dr. Shomajit, can you hear me?
Yeah, I can hear you. The ring is just placed, flexible.
Hello, Dr. Shomajit?
Yeah, I can hear you. The ring, tailor ring is just.
Let's get back to OT1, the concluding part.
Yeah, can you hear me?
Yeah, Dr. Mark, we are
Yeah,
with
good.
you.
Yeah, we've got, we're just tying the ring in. We'll be done with that in about 2 minutes. We picked the size 27. That was our smallest. You know, as you remember, she's 1.3, so quite small lady. And we also closed the left atrial appendage, and we put in 11 sutures, 5 along the anterior and 6 along the posterior. So we're tying those in. And with the tailor, it's a totally flexible, so we need to tie with the holder still on. Unlike the memo, we could take the holder off and it would be fine to tie.
Please squirt some more, sorry.
Can we squirt?
Yeah, a little bit more. Thank you.
couple more to tie here. Working our way around. Yeah, the last water test, we did not see prolapse at the commissures. We're just gonna have to take a look here. As soon as we get this band in, or ring in. Now we got it. Good. Last suture.
Fifteen blade knife. 15 blade, yeah.
15 minutes.
I think it's the top and the bottom. Right
It looks
here.
like 4, but. Yeah,
2.
on either side, you see them too?
Yeah, I do. Got it. Okay. How about the squirt?
Turn the orientation.
You got it oriented how you want it. I don't see any prolapse. Okay, that looks all right. What do you guys think of the anterior commissure on that? I know. I think maybe we lost those.
No, we back here, Mark. That looks right.
You think we need any cords over here? It doesn't look like it's prolapsing badly at all. See, if you do that, I can see that it leaks when I do that.
Yeah, I don't think you got much coaptation there. I just what sort of orifice area do you have? Do you have a Hagar dilator that you can put in? I'd be tempted to put a magic stitch there.
Over here? Yeah.
Yeah.
Yeah, no, I had it. No, that's
There's just one area under A2. It
had
just
it
kind of looks as if
blown
it's
up.
restricted by a secondary cord, or maybe that's just a result of your.
You mean over in the anterior?
Yeah, it's kind of
Sure.
bowing inwards, not outwards.
Right here, you mean? Yeah. Yeah. I don't know. The cord's okay.
So if you do a magic stitch there, then that would look pretty good to me.
Okay. Yeah, magic stitch. You can see right there. I'm gonna press it now, and then yeah, we'll do a magic stitch there. What do you want?
And then will you be able to test how much coaptation you've got?
Yeah, I've got a blue marker, blue
On a burlish or on a.
pen, marking pen. Yeah, good, perfect. Yeah. Thank you.
You want to,
Yeah.
burlisher or something?
They don't know what that is.
Like a clamp, long clamp.
Okay. And a little more. Good. Saline? Bill?
Oh.
Okay, you got it. Hold on, let me do that. Well, great, thank you. Okay, you got the sucker there. Okay, we're gonna. Okay, yeah, go ahead.
Oh, very good.
We drew a nice fish mouth there. we've got about a half centimeter there. That's okay. See this,
Yeah,
that's the primary cord
that looks good.
coapting back pretty well there. Let me check over by A3. Yeah, you can see that's the end of our repairs here, and we have coaptation here. So we've got a good coaptation there. And then on the A1, you're right, it's coapting right at the edge.
Yeah, the A1 you need a magic suture there. And
Okay.
posterior P2 looks good.
I think so. Yeah, let's take a look.
Yeah, that looks very good. That's
Yeah.
very good.
Okay, so we'll put a magic stitch and see if that will take care of it. Hmm? Yeah, sure. We're gonna fill it up to see where we want to put that magic stitch.
Right there. Down. Good.
Yeah, sure.
I'll call up on stage Dr. Rituparna Das from Department of Cardio Anesthesia
we're
to
gonna
take on
show
the
that.
proceedings on the stage. Thank you.
Which way are you gonna go? Exterior?
You've done the atrial appendage already.
Yes.
We missed that.
Yeah, we'll show you it in a minute. I think so. Let's do that. Yeah, over here you can see the atrial appendage closure line right here. Double layer 3O proline. It was very big, to say the least, as we would expect. And you can see that suture line right down there, the proline.
Mark, we've seen a lot of it. That looks very nice. There's some dignitaries that have arrived.
Oh yeah.
And they've seen the end of this, and it looks very good. I think there's various formalities that are going through, but I'm sure we'll come back to you at some stage and potentially see an echocardiogram and see more.
Let's take one more. I'll show you one more injection with the magic stitch, the bulb. One more injection, and then we will close up this atrium and come visit. Okay, we now have it. That now looks with the magic stitch. I think we are good. Okay, I think we're good.
I think that's very nice. You got no stenosis there, and I think that's
right.
If that leaves a physiological amount of mild MR or less, that's very much preferable to a
Use the vent.
mechanical valve. Okay, I think we might be leaving you.
Okay, guys, we'll get closed up.
Dr. Moon will come back to you in half an hour.
That'll be great. We should be have our heart beating by then, I hope.
Yeah, yeah, sure. You carry on.
Thank
Please,
you.
Have a seat. Right.
Extending a very warm welcome to all the faculty and delegates present today over here. I would request Dr. Kunal Sarkar, sir. Sir, please.
Friends, colleagues, I think it's very unkind to come between you and what promises to be a real collection of the surgery of the highest complexity, and which we are all eager to see our friends from AATS sort of discuss, operate with us. Now, what transpired as a discussion between myself, my friends in the AATS about a year back, we are so happy that with all your help and all your assistance, we were able to put it to fruition. AATS, sir, is the apex professional academic body of cardiothoracic surgeons world over. So it embraces not only the community of North America, but they are very inclusive and very international in their academic approach. And with them, they have been intimately involved with the clinical and academic training of cardiac surgeons, not just in North America, in Asia, in India, in world over across the years. And what we are doing today is a faculty delegation has come over from AATS, and they are heading towards our national meeting, which is in Bhubaneswar, in a day's time, and they are stopping over in Kolkata to do this live surgical session. Today, we not only have 100-odd young surgeons gathered over here, we also have a few thousand people who are tuned into this worldwide and watching. Tomorrow, once we do about 5 surgeries today, as soon as we finished over here, we'll take in live feeds which are coming in from Europe, from Athens, because they will be giving their live surgeries and feeds. And we would probably go through 5 or 6 very interesting, very complex, like operative tutorials throughout the day. After we do that, tomorrow morning, we take our friends from AATS faculty to SSKM Hospital, and there they will interact with our young surgeons, with our young trainees in the system, and will discuss how we can take our academic and technical training forward. 2024, in a nutshell, friends, is going to be a very threshold year for cardiac surgery in India. To all my American friends present over here, take no offense over the fact 2024 India might overtake United States as the most cardiac procedure performing country in the world. Right now, we are running level at around 240, 250,000. So let's see where the scoreboard clicks at the end of 2024. But having said that, we are only still operating at 200 cases per million population. We are a fraction of the population of United States. We are 200 per million as opposed to the developed Asian average of 400 to 500 per million, as opposed to the North American average of 1,000 per million. So even if India has to compare itself on equitable terms with the Asian average, we really have to climb up to 450,000 surgeries per year. And we have a challenge in front of us. The whole of India presently has probably less than 800 active cardiac surgeons. So as we encourage and take more youngsters in our community, we have to look after their academic, their technical nourishment, their training. And it is opportunities like this, it is the encouragement that we have received from international peers like AATS and the European Society time and again that enables us to do so. So once again, thank you all very much. And I think we have been so overcome with the wholehearted support from the AATS. Can I ask Mr. Clifford Barlow to join us? You see, Clifford comes from England, and in England, the moment you become a surgeon, you lose being called a doctor. So we are not a doctor anymore. So Clifford, please join us on the stage. Clifford is a part of the international academic collaboration of the AATS. Before I move any further, we were very fortunate to receive a message from the doyen of aortic surgery, the present president of the AATS in Cleveland Clinic, Dr. Lars Svensson. Can you please play Dr. Svensson's message to us?
I'd like to welcome you to this joint session with AATS and AATS faculty together with the Indian Association of Cardiovascular Surgery. This is a great opportunity to cover new areas of innovation and new developments in cardiothoracic surgery, and I think you'll find it very enjoyable. Please ask the faculty questions. There's a great opportunity to make connections with them. And then also welcome to Toronto AATS 2024. It's going to be an incredible program with complex valve scenarios, great speakers, special guests, including Governor Schwarzenegger. There'll be a leadership course, a lot of innovation, a lot of potential publication opportunities. We had some 1,700 abstracts. There will be 700 podium presentations, another 2 to 2024, and enjoy your meeting with our colleagues from the AATS that have been able to meet with you.
Thank you, Dr. Svensson. And can I just mention that the AATS Foundation amongst the youngsters present over here, AATS has not only supported the academic endeavor, but AATS has actually sponsored travel grants for 20 young surgeons outside of our city to come. We welcome our friends from Bangladesh as well, who've traveled all the way today over here, and we are grateful to AATS for giving us this support. Can I ask my friend, Dr. Clifford Barlow, who heads the international collaboration part, academic endeavors of AATS, to share a few words with us. Clifford.
Well, thank you indeed, Dr. Sarkar. We've knew each other in South Africa. Our mothers were friends and played tennis together, if you want to know. And then we've gone our different ways, but we've remained in touch. The ATS has an international, has a membership committee to join, and now there's an international membership secretary, because we really are reaching out, and I'm currently serving in that, but we're looking for international members to recognize the very different excellence that exists all over the world, the standard excellence that exists in terms of public.
Like that maybe it's quite a tough surgeries. Maybe the way we look at it in our generation or generation now, which is coming in the field, is looking at the IRR and ERR. So with all those returns, sir, we'll opt for dermatology. So this is what is a priority and the interest at many times which the opinion makers are guiding into the system. So this is a very good initiative from that direction to invoke an interest in the subject. Second, which is a very interesting part of it, if the more such conferences all across the medical fraternity can be organized, the medical advances cannot be limited to a state, to a region, to a city. We are into an era of globalization and the information technology revolution. When I look at it, if the doctors and patient distances can be minimized, if the teachers and the student distances can be minimized by this process also, they should be always welcome and they should be encouraged. With so much of the advent which has taken place in the information technology field, I think this is one of the brilliant ideas. In fact, Dr. Niyogi is here. I will request his own counterpart. Why not we organize? We have now in government, we run 24 medical colleges. We have a lot of ideas. We were thinking of why can't the best forensic surgeon, say in NRS, can organize a classes in which all the 24 medical colleges attend it together. Maybe this also gives us a new idea. We wish you the best. For us, as far as the health administrators are concerned, I am now almost a part of you. It's a issue which we are going to face much more in near future. India is a country of 141 billion people. Now the debate is going on whether we are the highest or the China is highest, but still our population is increasing. China's population is on a decline. With this thing remain, with the health-seeking behavior being improved, it will be the best if we don't get the people up to this stage. That is also as a part of the surgeons or the part of the doctors, we must encourage that we don't reach up to that level. Otherwise, the kind of your resources that will be drained out towards providing health care will be phenomenal, and your other issues of a good life may not be available at all. With my best wishes once again to Dr. Kunal Sarkar and team, Mr. Anab Singh Gupta, and all the guests who have arrived from all across the globe and the people who are performing online or attending. My best wishes to everyone. Thank you and all the best.
Thank you so much, sir. Moving on, this workshop has been enabled by the Association of Cardiothoracic Surgeons of West Bengal, requesting Dr. Debashish Das to be on stage and share his thoughts with us.
First of all, a very warm welcome to all of you, dignitaries on dais, Mr. Nigam, Dr. Niyogi, and our guests from abroad. I think in addition to that, we also have our Indian Association leadership here, the current president, the incoming president, and the secretary.
We have had a galaxy of delegates from Bangladesh as well as other places in addition to Kolkata. And this initiative was basically when the whole discussion started, we thought that keeping a live workshop has its own challenges of logistic organization. But I think after the initial discussions and all, it went on smoothly and it started. So we are all glad that this exchange of knowledge and technique in a manner which is having live cannot be replaced by other modalities of pedagogy. So it is probably one of the best form of surgical teaching. And we thank all of you that you took time out and the efforts towards this. We thank the AATS leadership and the educational initiative part of the AATS that it could be held in Kolkata just prior to the conference which we'll be having in Bhubaneswar. So there could not be a better way to start the academic calendar of year 2024. So thank you all.
Thank you so much, sir. Moving on. Clinical and academic cardiothoracic surgery in India is under the auspices of IACTS. Requesting the President, IACTS, Dr. Lokeshwar Rao Sajja, to grace the dais and share his thoughts with us.
Respected people, the dais, and friends, I am honored here today to be here for this live surgical workshop that is conducted by the Association of Cardiovascular and Thoracic Surgeons of West Bengal and the American Association for Thoracic Surgery to just prior to the AATS, IACTS cardiovascular postgraduate course, which is going to be held on 8th at Bhubaneswar. This collaboration between American Association for Thoracic Surgery and Indian Association of Cardiothoracic Vascular Surgeons is not merely a congregation of professionals. It is a forum for intellectual exchange and collaboration and the sharing of knowledge. So it is our shared responsibility of the both associations to foster an environment that encourages open dialogue and sharing of the experiences, thereby enriching the collective understanding of cardiac surgery. Probably with these type of meetings and live workshops, probably we can collaborate much where we can learn from the American Association as also from the Indian counterpart. I am also a member of the American Association for Thoracic Surgery, and during the AATS, my presidency, this live workshop happening here in Kolkata under Dr. Kunal Sarkar. He has taken a very great initiative to show us all the during the workshop, the learning. It would be a very great learning experience for all of us attending this meeting. I wish this live workshop a great success, and thank you to Kunal for this.
Thank you, sir. Moving on, Dr. Siddhartha Nyogi has been the pivot for healthcare in our state as the Director of Health Services. It's a privilege to welcome him as our guest of honor today. Sir, please.
Good morning to everyone, the delegates from abroad and the dignitaries here on this dais and of the dais. It is my privilege to speak something to so many cardiothoracic surgeons. So, Dr. Satyajit Bose is sitting, and at some time we worked together in NRS Medical College. And it is interesting, this operation of cardiothoracic surgeon research was started in Bengal only by Professor Ajit Basu and his team in NRS Medical College with operation of the dogs. And there was a dog house in NRS. They used to practice with that. And gradually it has improved. And now you see, you are working on the humans. And it is like the gallbladder surgery nowadays. Am I right, sir?
You are.
But previously, we used to enter the OT at 9 o'clock and leave the hospital in the 9 p.m.
He was in cardiothoracic.
Yes, with Satyajit as a medical officer. So I had some experience. So when the heart breast operation was done, I was telling sir that they are replacing the valves. Anyhow, this is a great opportunity, and I hope we should encourage the surgeons, especially who are doing MS, to join the cardiothoracic surgeon. It is unfortunate some specialist surgeries, cardiothoracic, pediatric surgery, neurosurgery, we are not getting students. So I think their 3 years curriculum, they should get the exposure of cardiothoracic surgery, pediatric surgery, and neurosurgery. So someone will get interested. Unless you see what is going there, you can't be interested. And such workshop has to be done frequently. And I think the postgraduate students have to be involved, whether in any subject. So they can be encouraged. They are joining cardiology, but not cardiothoracic surgery. So most of the seats are going vacant, and we are having a dearth of faculty also. So I invite everyone who wants to join West Bengal, sir will accommodate them. So I wish success for this program and hope it will continue, and the people of West Bengal will be benefited. They will not be required to go outside Bengal for any treatment for heart operations. Thank you.
Thank you, sir. Moving on, requesting the MD of MEDICA Superspecialty Hospitals, Mr. Ayanab Devgupta, sir, to please be on stage and give his vote of thanks.
That's the easiest job to do. But again, as we all know, I mean, our motto at Medica, our punchline was to bring the best in healthcare to East. That's what we started off with, and I don't think there could be a better example than what's happening today. And it's just puts our motto in place. Thank you, Dr. Sargar, for organizing this. And the two gentlemen on the dais, Mr. Nigam, Dr. Niyogi, they've been mentors to the entire health fraternity, and specifically, I take the liberty to say to us in many, many more ways than we know. And thank you, sir. Thank you for being here. It means a lot to us. I have a long list. I'll just read it out. But at the outset, Dr. Barlow, Dr. Moon from American Association of Thoracic Surgeons, thank you very much for being here. And there's been a lot of word going around in media about live surgery. Should it be allowed? Should it not be allowed? I think this is one of those perfect examples to show how powerful it can be, how impactful it can be, and how much can knowledge be shared. In today's era of collaborations and partnerships, I can't find any better than this. Between private association, private healthcare, and government. I mean, it completes the entire loop 360 degrees. And that is very, very powerful. I'd also like to thank Dr. Lokeshwara. He is here from the Indian Association of Cardiovascular Thoracic Surgeons. We have Dr. Shubhendu Mahapatra, Dr. Debashish Das from the West Bengal Association of Cardiac Surgeons, and everyone else who's here to make it happen. It's a long list, and the press and media. It's very important that you capture the ethos of what the discussions are, what it means, and how impactful can such partnerships be. Thank you very much.
Thank you, sir. Moving on, I would request our moderator for the day, Dr. Sanjay Sengupta, to carry you all through an interesting long day.
Thank you.
Thank you, everyone. After such a grand inauguration and warm welcome, we'll move back to the next session. Can you go back to the recorded session of OT2 for some time? Yeah. OT2 recorded session, the valve sparing root replacement. Dr. Shomojit, can you hear me? Hello, Dr. Shomojit.
Dr. Moletri will.
We can't hear you actually. We can't hear you properly.
Yeah. Yeah, who's moderating? Is it Cliff Barlow? Ram Amani?
We're back with you now, Chris.
Scissors, yeah.
We've missed a bit. Mark's had a nice result in the other OR, and we've just been very warmly welcomed by dignitaries, both from the hospital and the healthcare system here, and we've had a message from Lars Svensson, and now we're back with you, and we're seeing you suturing in your graft. Can you summarize what's happened while we've been away?
Yeah, so we did the deep root dissection, which was a little bit challenging because the non-coronary sinus was dissected, as we saw, and it was pretty scarred in. But we're able to get down to the level of the basal plane, which is important because these stitches that are in the level of the basal plane have to go below the level of the aortic valve. And we've done that, and we put it through the bottom of a 32 millimeter hemoshield graft. And scissors, please. So Niraj, it's okay we use 2 grafts today, huh? Let's get rid of this thing.
And your landmarks for that basal plane, that is such an important part of this operation. So when you're going down between the
scissors, please.
Right and non-cusps, what do you? And then again, the left and right cusp. Those are the 2 really important parts to get into the right area.
Forceps. So let's show the audience the valve here. The valve looks pretty good. So we have it inside the Dacron graft here. So hold here, and hold that one. And the valve doesn't look bad to us. Here's the left cusp, here's the right cusp, and here's the non-cusp. These are all the stitches in the subvalvular plane. I usually don't use pledgets, but I did today because the tissue is so friable here. So next step here is to get the commissures implanted. Scale. So we could measure the
Chris, have you got a completely symmetrical valve here, or are you showing? That's what you're showing us now.
Yeah, it's a totally symmetrical 3-leaflet valve.
And then your tips for both the spacing and the height.
Yeah, so so the next trick here is to measure the commissure height. I call it the Brussels height for El Curie. And we're getting about a 26 millimeter height here, 27. So we'll mark it on the outside. So hold this, Niraj. Yeah. Marking pen. Yeah, stretch it, Niraj. Stretch, pull. Yeah. And it looks like 26 is going to be right around marking pen. You have 4.0 pen. You have a 4.0 pledget. 4.0, 2 needles, yeah. So that's the Brussels height on the outside here. 4.0 pledgets, please. Yeah. All right, let's see the St. Jude sizers. So I sort of tied these down freehand. I usually tie them over a Hagar, but we don't have a Hagar that's large enough. Do you have the St. Jude sizers back? We had them before. Yeah. Here, those sizers right there? Yeah. Give me a 21 and a 23. Yeah. Let me just show the, yeah. So get a 23 next. So here's a 21 St. Jude. Gonna get caught on those pledges. Huh?
Dr. Chris? Dr. Chris?
That's, yeah, it'll be okay.
Dr. Chris, I'll just take 1 minute from you. Can I call up on stage the next set of chairpersons?
Yeah, go ahead. Yeah.
Dr. Satyajit Bose,
4-0 pledge.
please come on stage, sir. Dr. Ratanu Shaha,
4-0 pledge it.
Dr. Shubhendu Mohapatra,
That's fine. Okay, just give me a 4-0. It doesn't matter. Yeah.
Dr. Shubroto there, sir, are you here?
You don't have soft pledges, huh?
Yes, sir, we can make it.
Yeah, 4-0 pledge it. Yeah. All right, let's do the Del Nido here. Golds, Del Nido. You make the pledge it. Okay. Del Nido.
Yes.
That's fine.
Can you request Dr. Debashish Das to come on the stage for this session? This is going to be a short session, sir. Thank you, sir.
Del Nido.
Since I see that you're using a straight draft, I thought you would use a to use a straight draft.
Yeah, the technique I use is called the David 5 Stanford modification. The bottom graft here is a straight graft, a lot like the David 1. Yeah, please go. But the Valsalva graft is fine. Yeah, Ruggiero de Paulus designed that. I think it's nice because the lengths are pretty much fixed, so you don't have to think about how high to put the commissure. Please, John, please. Del Nido.
Not ready.
Okay, here. So you do it. Did you make the stitch?
Tell me once ready.
All right, scissors, please. Yeah, just a very small one. Yeah,
You want larger, sir?
that's good. That's that size. Yeah. But I prefer the straight graft. There's a couple reasons for that. It's so that I can. Is please, John? Good. Yeah, Niraj, you do it. The straight graft allows me to set the commissure height at my discretion. Marfan patients have really tall commissure heights, maybe about 28, 29, sometimes 30. Most people are about a 25, so it gives me the ability to set the commissure height. I thought I marked it earlier. It's gone. Do you see the mark? Yeah. You have the, it's gone, yeah. Scale? Yeah.
Hello. Sanjay, can you hear me? Hello.
Yes, we can hear you.
Sanjay, can you hear me?
Yeah, I can
That's
hear
good
you.
there.
Yeah, go ahead.
We are
That's
still
good.
the
Oh, are you guys there? Can you hear us?
Yeah, we're here, Mark.
Okay. Yeah, we've got, we measured out a gradient of 4, mean of 4, peak of 8. There's no mitral regurg. You can see that the secondary cord area is no longer tethered. We're just trying to figure out what the orifice is. Kind of hard to tell. We didn't really open the orifice in the mid. We opened it towards that commissure, obviously. What do you think? You want to show the gradient?
I think that looks really nice, Mark. That's great.
So this is the mitral valve in port chamber. We use one.
If you see how so firstly, it's so nice to see how mobile that anterior leaflet is.
And there is some flow acceleration across the mitral valve, as you can see. Some flow acceleration is there. And when we measure the gradient, the peak was 8 and mean of 5. And this is another. This is 2 chamber. There is small paravalvular leak, as you can see. Small paravalvular leak there. And some flow acceleration.
Yeah, it's kind of hard to, unlike a degenerative, those leaflet coaptation points are pretty jagged, especially where we completed that repair. So that little small jet's not.
I think that little jet's probably, I would have thought it's insignificant. It's probably up at the the area of A3 that was very
So this is the gradient
thin, right?
I'm going to measure. Gradient across the mitral valve. So it's mean of 5, maximum gradient of 10. So mean of 5. Now I'm going to show you some 3D
Thanks to
images.
Barlow's nice.
Well, that's
You know, it's
that's pretty good, I would have thought, for that valve.
there's really only one way to cure rheumatic mitral valve. It's to cut it out. But
You can 3D and you can see the orifice there. So to me, not much of opening, honestly. Looks the orifice is slightly less than what it was before. That is the black color is also. And this you can see from the LV side.
That's a
Orifice opening from the LV side.
yeah, that's a good view there.
Say how much more mobile it is.
Okay, we'll see how that goes. Heart function looks good.
I think that looks nice, Mark. And here you got a 44-year-old lady who could potentially go onto a NOAC, I guess, for her rhythm, and she's going to avoid Coumadin, warfarin. So that's
maybe she can get.
So that's
maybe she can get another decade or 15 years out of this.
which is pretty good, and you're getting panisin growth in the best anticoagulated valve. Sometimes I think. What is your thoughts, and what does Dr. Kashru think?
Here, what do you think?
Mark your own homework, you two.
I'm trying to find my mouth. Where's my mouthpiece?
Is it here?
Yeah.
We can
you
hear
hear me,
you.
Dr. Barlow?
We can hear you.
Yeah, so I mean, I think the result was actually pretty decent. I know on echo it's difficult to see. I think when we looked visually, we could all see that the anterior leaflet was much more mobile now that we decalcified it. The opening was quite, it was significantly improved by opening up the commissures. And I think we did all the right techniques to buy her some time. You know, hopefully it lasts a while. It may not look ideal, but there were no secondary chords. It opened very well. We weren't able to size it with a Hagar at the end, but visually we were able to open up that anterior leaflet. We looked at the coaptation zone. So I think all of the principles of mitral valve repair we looked through, and I think it was a pretty decent result with a mean gradient between 4 to 5. We would have accepted much more than that.
And the RV.
Yeah, I think so. Let me ask Ramamani to give some thoughts here.
Yeah, no, I think it looks like your valve opening is there's still some restriction of movement. I think that somewhat has to do with the thickening of the leaflet edges, but I think your effective orifice area is probably adequate for this. You did have a dilated annulus, so I think relatively speaking, things may look a little bit. I think the gradient is reasonable, and you have a good cardiac output. Obviously, gradient is going to be dependent upon how much flow you're going across this. I think that looks pretty adequate, so I would be satisfied with that.
I know we were talking yesterday, the tricuspid annulus was only 26 or 28, I forget, but there was a little bit of TR there. Have we had a look at that? Mark, are you still listening?
Yeah. What did you say again? I missed that.
No, I see you're interrogating the valve, and we don't want to stand in the way of anything.
No, we're just.
But I was commenting on the tricuspid. The annulus was measured on the TTE at 28.
So
It doesn't look big, but there was a bit of
Can you guys put color on the tricuspid?
26.
So it's all right. It has not worsened. It is moderately.
So the issue with these rheumatics, as we all know, is you can get rheumatic tricuspid disease. So that's not a big annulus, but there's a bit of TR there. I don't know how much we interrogated that pre-bypass.
So pre-bypass, there was moderate TR, and the annulus we got was like 30, and moderate. Now the RV function is all right, And the tear has slightly gone down, probably, I must say. Tear is slightly less, and RV is functioning slightly better. Obviously, some dopamine, but it's still all right. RV is small, nice and contracting, all sorts of contraction. The septum is contributing, nice septal bounce, good radial and longitudinal contraction, and tear has come down. So that's a good sign. And there is
So, Mark, I got a feeling that's a Tyrone David, leave alone. David Adams, we got to do something about it. What are your thoughts about that tricuspid?
Yeah, we talked about it, and our echocardiographer thought that over time it might improve. The annulus wasn't dilated, and there wasn't anything wrong with the leaflets. So I think if we would have done an annuloplasty, it would have been downsized it a lot, maybe made it stenotic, or what do you think?
It is 30 only. So what size of the ring we put, like 28, it will not help much. And we also looked at the tricuspid leaflets with 3D. The leaflets are nice and pliable. It's very thin. It's not thick even.
You'd have been stuck with it at Vega. We've got another ADS member, our friend Prakash Punjabi's arrived. He's
Thanks, Cliff.
here we go. We're going to have some thought. How are you, Prakash? Lovely to see you.
Well, thank you. Thanks. Hi, Dr. Boone. Great to see you.
Hey, welcome. Welcome to Kolkata.
Thank you. And so same to you. But I think you've done a great job on the mitral. I was just discussing and getting some information. Sorry for arriving so late, but her body surface area is 1.3. And I think that's why a 27 annuloplasty ring is probably okay. And we got a acceptable result. But I think with the same corollary, a 30 on the tricuspid with moderate. I'm very aggressive when it comes to rheumatic. The resolution of tricuspid in degenerative is on a different pathway as compared to resolution on a tricuspid in rheumatic. And we've got a lot of literature supporting that. And usually, I don't go by the absolute annulus size. And if I do, I use 22 to 24 per meter square, which in this lady would just cross my threshold of intervention. And I'll present over the next few days my tricuspid repair technique. But essentially, I would have intervened on this tricuspid as well, just to prevent long-term and ensure that the tricuspid doesn't become a problem before the mitral. Thanks.
Yeah. I mean, we hope that to be the case. We don't have any tricuspid rings here. Our options would have been a De Vega or a pericardial annuloplasty. So given those options, we weren't overly eager to be aggressive. But I'm with you. We could have just as easily done a downsizer on that and tried to improve it. But
I think
it's certainly not significant, and the CBP is only 5 or 6. So I think clinically it's okay for the present time.
Oh yeah, and it would be interesting to see, because this is a rheumatic with rheumatic MR, not sort of classic rheumatic MS MR or mixed or predominantly MS. So they don't necessarily behave the same in all parts. So it could be, it may resolve. Thanks.
I think these are all good points. 2 points to make. Firstly, I think Prakash's point is, well, that I made as well. I think it's absolutely imperative that you consider TR in rheumatic differently to in degenerative. That said, I think our tricuspid sessions at the annual meeting would be half the length if we didn't have Tyrone and David Adams interacting with each other and disagreeing. So there's no firm evidence about these, and I know that you can double the rate of pacemaker requirement by putting a tricuspid ring in, and that's a big problem as well. So given that you'd be doing a De Vega, I think this is probably a sensible decision. The right ventricle looks very comfortable. It looked comfortable before, looks comfortable now. So I think this is a nice operation that you two have delivered.
Just to let you know, these nice echo images on TE are being brought by Dr. Arup Ratan Maiti. He's an invited faculty here for this session. Can you go back to the aorta case, the OT2, the rest
All right.
of it? Yeah.
Guys, we're
Yeah.
gonna check
Yeah.
out of here. We'll come down and join you for a few minutes and we'll take a look at things that are going on.
Thank you, Mr.
Bruce is getting things organized to get started as well.
Okay, thank you.
Okay, thank you. Thank you. Thank you.
Chris,
Over,
can you hear
over to
us?
OT2 to Chris.
We're back on. Okay.
Hi, Chris. We're back on here. They're finished next door.
I heard
And,
you guys got good news over there. So fantastic. That looked like a tough mitral valve repair.
Yes.
Okay, so I'm sewing in the sinus remnants here. I'm using a 4-O-proline. I do over and over from the inside. Unfortunately, this is the boring part of the case. It's going to take me about 20 minutes to get all these stitches in. But when you stay around just for maybe one edge of it, so you could see the suture line here. So it's over and over all the way up to the top. And I start at the nadir and come up. So give me one of these guys. Give me one. Yeah. Yeah. Yeah, one key point of this is when you tie these, when you sew these sutures, sew the cusp in, is to push the cusp out as far as possible. The shape of this line should look like a U coming up rather than a V. That way you create neosinuses. So I'll show you the first couple bites here. So put this on a separate one. I'll take this one.
You generally start down in the left sinus and work your way around.
Yeah, I usually do the left, then the non, then the right. The right is the hardest one for me. I'll show you these bites here as I come up. Roll a bit towards the left, the table left, please. So these first bites here are going to go directly horizontal. Do you guys see that? Yeah, just a little bit to the left so we can go faster.
Yes, we can see it quite well, and it looks like your line is sort of showing itself as to where the sutures want to go.
Yeah, exactly. Yeah. I'm going to go horizontal for about 2 or 3 bites.
And you've already set the height of your graft because you marked all 3 commissures before you brought those the tips of the commissures through the graft. So the rest of it should just line up relatively straightforward.
Yeah, this I measured at 26. So the Brussels height I was talking about earlier. Yeah, and that pretty much matches up with the annulus size. So here I could start coming up on it, and Niraj just hold like here.
Dr. Chris, while you are taking the sutures, can you come up with the idea of how to exactly pull up determine the height of the commissure? How did you get that number 26?
So El Curry went ahead and measured all the commissures for us. You can find that in his publications. They're usually about 25 to about 28. I measure them myself. So I get a ruler, I measure from the basal ring here to the tips of the commissure. So I knew that was, we measured it just now, Niraj, at 27. So once I knew it was 27, I marked it on the outside of the graft here, 27. So I know exactly where the commissures are going to come out.
So you have taken a marking stitch on the outside. Yeah.
Easy on the follow.
Yeah, yeah. Okay.
So you could pull, but easy on the follow. Don't pull too hard there.
Okay.
What's 10 minutes, guys?
10 minutes. Second page.
No. So let's make sure we're not grabbing stuff back here. Okay, scissors. Scissors. Yeah.
Did you stretch the graft while you put that stitch, or you took the stitch on a non-stretched graft?
On a stretch graft, yeah. It's like
Stretch graft.
This is earlier because we tied it together, huh? This is all in our way now. See that? All right, now that's better. Okay. Yeah, it's a stretch graft 26.
For the non-hemostatic layer at the bottom, did you take suturing all the throughout the circumference, or you took just 3 stitches of the 3 corners? All through the circumference, yeah.
Yeah, keep me from getting all that stuff back there. Huh? Yeah, so this is the boring part of the case. As you can imagine, I got to come up on all 3 of these. So now is a good time to break if you want to give another talk. And we can come back in about 30 minutes because it's going to take time for me to get all of these things.
Okay. So, Dr. Chris, a quick look on what we had discussed yesterday night. Like, are you worried about the tissue texture or need of glue or anything? Looking at the tissue so far.
Tissue looks not bad. There were some thinned out parts. We repaired them.
Okay.
But the tissue that we're sewing into now looks pretty good.
Okay. Okay. Thank you.
And Chris, just to sort of emphasize the dissection, because once you've completed the coronary, it's going to be hard to see that. You just take a bovie down in the intercoronary commissure down to beneath the level of the annulus, right? You were sort of seeing that when you pulled the graft towards you a little bit, we could see the extent of your dissection.
Yeah.
Outside of that.
Yeah, this went
graft.
all the way down. And the dissection ends right at the annulus. But we're going to have plenty of tissue to sew back into the graft.
Nice. Great.
All right, guys, give me one of those there.
Chris, when picking the size of your graft, did you use the commissure height, or what was your methodology for choosing the size of your dacron?
Yeah, the graft size just determines the size of the valsalva, and it goes back to how you could set everything freely. So we can set the sinus of the neosinuses independently of the root, independently of the commissure heights. So basically, the 32 graft is going to give us a 32 root. Okay, give me another 4-0, please. Yeah, and we'll need one more after that. Yeah, let me get all these in, and you guys should break through what I'm eating, and then I'll come back and we'll do the probably in time for the valve stitches.
Sounds good, Chris.
Okay,
Thanks.
Dr. Chris.
Maybe we can move over to the cabbage.
Yeah. So before the cabbage video starts, we'll give a small rundown of the case summary.
In there, huh? We got to get all this tissue together, huh? Boy, I'm thinking of going all the way down here, huh? Okay, the other side.
Can I get back to auditorium for the case summary? No.
Okay, shot this one. Here, take this one. Needle driver.
So we have 161-year gentleman for our MICS case, which is getting underway. So body weight addiction, no family history of coronary artery disease, no past surgery, no history of any CVA, and he is non-diabetic. So he presented with angina on exertion of CCS class 2 through class 3 since last 1 year. On echocardiogram, the LV function is preserved. On ECG, there is normal sinus rhythm, no STT changes, good R wave progression. On chest X-ray, the CT ratio is 0.5, no abnormality in any of the lung zones, normal bony cavity. So this is the ECG of the patient. There is no STT changes. There is good R wave progression. 12:30, no? That's 12:30. 12:30. We have half an hour, yeah. Yeah, 12:30. Yeah, that's 12:30, sir. So this is the angiogram which we have. The LED is having CTO right at the beginning. The WAME is fine. And once we look at the RCA injection, you can see nicely LED, the rest of the LED is getting filled up nicely retrogradely from the RCA. There is a small diagonal which Dr. Piroz is expecting to be large enough. And he might, if he sees it epicardially, then he might, he would like to graft it with a bit of LED, with a Y graft or with a bit of radial or RIMA. So let's get back to OT3 for our MICS case. Dr. Shomujit. Dr. Shomujit, can you hear me? Hello? Can I go to OT? Dr. Shomujit, can you go to MICS CABG just to have a look?
Dr. Piroj will brief.
Yeah. No, let's go back to OT4. OT4. Let's go to OT4. Dr. Shomujit?
Hello.
Can you go to OT4? We are still at OT2 here.
The camera is not there. Still in OT4. I was arranging it.
Okay.
I'll
Okay.
show you the position.
Okay. Okay. Let's welcome Dr. Mark Moon here. It is President 2020. He was involved in the first case of mitral repair. Dr. Pooja Karchu from St. Louis. Yeah, yeah.
Hello, thank you.
Can you
Welcome.
just have
Thanks
a
for coming,
share
everyone.
some words with us?
Yeah, that was a very abnormal mitral valve. The area, the A2 and A3, that was so heavily calcified, even had a perforation of the leaflet that had the calcium had burrowed through. We were able to peel off the calcium so that the leaflet became pliable and we could reconstruct it. And we had enough leaflet tissue. We did not need to do a sliding plasty in order to move it over, and that was rewarding. We increased we couldn't see on the post-operative echo the fully appreciate how big the new orifice was, because once we put in the ring, then there was dropout of the echo at the commissures, and we couldn't really visualize the commissure opening, which is where we did a commissurotomy for at least 1.5 centimeters. So on both commissures, we did put that magic stitch because the coaptation point was right at the leaflet edge at the anterior commissure, but it was not very far into our commissuroplasty. So I think as far as the rheumatic, the tricuspid valve improved. Hopefully that'll stay that way with time. We did not address that surgically, and hopefully with improvement in the pulmonary pressures, that'll get better as well. So welcome everybody, and it's been a joy so far, and we look forward to continuing this afternoon's program.
Dr. Pooja, would you like to share some words with us? Yeah.
Hi, good morning, everyone. Just a little background. I actually did my training with Dr. Moon during my fellowship for CT surgery, and then I've sort of stayed on at Washington University in St. Louis. So, obviously in the United States, we don't have a lot of experience dealing with rheumatic mitral disease. So I think these are some of the very challenging cases when we do see in Asian countries as well, but there's significant calcification. I think, you want a lot of leaflet mobility. So we just go through the same basics. We evaluate the same way. Sometimes we put in the annuloplasty sutures to sort of bring the valve up in our field. I think those are a couple of things, for exposure is most important in this case. The left atrium was pretty large. We also put a retraction stitch in the posterior wall in order to bring, again, the valve up towards us. And then we took our time to look at what sort of cord we had, what primary cords were, what secondary cords were. I think that's pretty standard in all mitral valve repair. Then we, in these rheumatics, you obviously have this commissural fusion, so we addressed that. And then it was really hard to just sort of identify the rind and take out the calcium. So I think that was a little bit challenging. Did we end up denuding a little bit of the leaflet? And how much do you actually take out? Where do you stop? I think those are sort of decision points that we were both talking about throughout the case. And then using just, it doesn't really matter what type of suture, Cardionel, Prolene, things like that, in which you repair. You want to try to avoid that all sutures around the coaptation. And then at the end, when we tested, we weren't able to put a dilator in to see how big but visually we could see we had a pretty big anterior leaflet. And then we look at the coaptation surface. Do we have enough valve below the, leaflet below the coaptation zone? So again, those are all, like, even in degenerative repair, which is what we're mostly doing it in, those are some of the things we look forward to. And again, I think Dr. Moon's point of not being able to evaluate the entire effective orifice when you have a ring in place in 3D is very challenging. So I think a lot of the 2D shots were a little bit better. And then you look at the gradient, and these patients, you accept a higher gradient. And I think she has an acceptable gradient, 4.5. In terms of the tricuspid, she had a lot of septal bowing on her anterior or her atrial septum towards the right side, and that improved at the end of the case. So I'm not sure the tricuspid is really going to become her primary significant problem. So I think those are all the decision points, and I think it was nice to have everyone's input in there, and nice to be working with Dr. Moon again. So thank you, everyone. Okay.
Thank you, Dr. Pooja. We'll get back to OT4, where the MICS is going on. We'll just need to see how the positioning is being done. Over to OT4, to Dr. Piros.
Hi, good afternoon. Can you hear me?
Yeah.
Can you see us?
No, not exactly. Yeah. You can see the incision now. Yeah.
Oh, you can? Okay.
Yeah.
So we just wanted to show you the position of the patient. He's given a slight, about a 30-degree right lateral position. And we usually put the arm down like this. With the elbow pointing downwards. You don't need to put the arm up every time. And you can see that we have roughly marked the incision. So the site of the incision, usually I decide on the X-ray chest. We can go to the X-ray if possible. We just show you the X-ray here. Can you see the X-ray?
Yeah, we can see. Yeah.
So what I generally do is I count the number of intercostal spaces. So it's like the first rib, the second, third, fourth, and the fifth. Now, usually I see the lateral border of the heart and the point at which the intercostal space crosses roughly the upper two-third and the lower one-third of the lateral border of the heart. That's the space which I usually choose to go into. So here it's, this is the first rib, this is the second rib, this is the third rib, this is the fourth rib, and this is the fifth. So it will be roughly the fifth intercostal space. And when you're doing a mid-cap, like this is sort of a single vessel actually, even if we have to do the diag. I prefer to go a little bit more medially. And the second thing you have to see that this heart is pretty small. So if you're too lateral with the incision, the LAD will be far away medially and it might become difficult to do the LAD. So in this situation, we will go a little bit more medially than usual as compared to a mixed cabbage where we go a little more laterally. And you should also take into consideration that this position of the heart will slightly move to the left because we'll be doing the entire operation on single lung ventilation. So once the left lung is down, the mediastinum will move a bit to the right. And if you still find difficulty in doing the LAD and if you're a little more lateral than what you want it to be, you can always give PEEP on the right lung in order to sort of push the mediastinum more towards the left. So that's all that I wanted to show you right now. You can go back to either the talk or the other OR. And once we are ready to make the incision, we come back.
Okay.
Peruz,
Okay,
can we
Dr.
ask you a
Peruz.
quick question
Sure.
in terms of, what sort of anatomy would make this challenging? Like, what about an obese patient? Do you shift your skin incision anywhere differently? What
So-
about somebody who has scoliosis, things like that?
So if you're doing a single vessel like the Lima LAD, then usually it doesn't matter too much. Obviously, if you're doing a multi-vessel, then obesity and all comes into play. Because it's just due to the access of other vessels, access to other vessels is pretty difficult. Like you have a 8-inch layer of fat on top of the rib cage, then you're operating through a long tunnel, which makes the operation difficult. So if you have a BMI of like 40, 45, then things start becoming more difficult for the lateral vessels. Anteriorly, just doing the LAD, usually you're not operating in a long tunnel because the fat on the anterior side is usually a little bit less, and the LAD is right up front, so it even if you have to operate through a tunnel, you can manage to do it. For the lateral vessels, I would prefer not to be operating through a long tunnel, and in such situations, I think a robotic approach is much better. Does that answer your question?
Thank you.
Yeah, thank you. Thank you, Dr. Peruz. We'll get back to one of our talks. We have an invited talk by Dr. Atanu Shah. He's one of the most prolific aortic surgeons of our young generation. He's going to give a talk on aortic disease spectrum at Naran Rudalai Aortics. Thank you. Over to Dr. Atanu. We'll transmit this. Yeah.
Then we are screwed. And you have to try and find
Good afternoon, everyone. It's a real honor and privilege to present our experience in aortic disease in front of such an esteemed and a distinguished audience. I've been allotted 10 minutes of time, so I'll just quickly run through the presentation. So, the spectrum of cases that we actually deal. What are the cases that we have dealt? Aortic dissections, both type A and type B, aortic aneurysms involving the proximal aortic arch, the DTA, and the abdominal aorta. Complex distal arch and DT aneurysms, frozen elephant trunk concept with arch aneurysms, thoracoabdominal aneurysms with Coselli grafts, reoperative aortic surgery, and a hybrid approach with debranching of the arch vessels and renal artery reconstruction post-renal transplant. So, as we see, so basically this is a type A aortic dissection, standard dissection that we come across quite frequently. Now, either we go for a root replacement or an interposition graft or an arch replacement, depending on the complexity of the tear, the expertise available, and the so these are the spectrum of cases that we have dealt. This is the type A dissection. This is the root opened up. This is the distal DTA. We perfuse it with a Foley's catheter. This is the completed proximal anastomosis. So this is one of the real challenging cases that we dealt with. This was a young lady with 22% ejection fraction. The aorta was entirely dissected, and the challenge was basically the distal tear had two intimal flaps actually, distal to the left subclavian artery. So we had to replace the entire root, the ascending aorta, as well as the total arch. So this is the completed anastomosis, as we can see. This was the tear which involved the DTA just distal to the left subclavian artery. This is the graft used for the distal perfusion. This patient presented with acute limb ischemia. We had just done an interposition graft, and just interposition doing the graft restored the flow to the limbs. This is one of our cases, angry aorta. Now, this patient had an interesting history, had a history of angina for the last 3 years, found out to be a case of chronic dissection. There was a huge pseudoaneurysm involving the ascending aorta. We replaced the entire ascending aorta and resuspended the aortic valve. So, as you can see, for the distal perfusion, we use a Foley's catheter, inflate it, and perfuse, so minimizing the distal circulatory arrest time. So, these are the spectrum of cases. I'll quickly run through it. Now, this one we had an interesting case. This one was operated for an aortic dissection. Came back 3 months later with a partial blowout of the from the right coronary button. As you can see, the clot protruding out from the sternum. We opened him up and repaired the blowout using a short pump run. Now, this is our experience for the last 10-15 years. We had 149 patients with acute aortic dissections. We had a total mortality of 15%, 15 cases out of them. We had a potentially salvageable patients of 14, and we had non-salvageable patient of 16. Of them, we had ascending aortic and hemiarch in 78 patients, and we have a total arch of around 12 patients. We had a total arch. So, arch dissection. This was a patient who came in with an arch dissection. We replaced the total aortic arch. As you can see, this is the post-op reconstruction image. This is the entire ascending aorta, the arch, and the DTA has been replaced. This is the completed, this is the pre-op scan, this is the intra-op image, and this is the post-op scan. This is one of the type B dissections that we dealt with. This is the reconstructed distal thoracic aorta. This is the reimplanted left subclavian artery. So we use a combined approach actually for this type of complicated cases. We do a stenotomy as well as a thoracotomy. So stenotomy allows us to get a proximal control, access to the better access to the proximal suture lines. One of those cases, another type B resection cases. This is the view to the thoracic. This is the view to the thoracotomy. The completed anastomosis. Another case of DTA, you can appreciate the hugely dilated descending thoracic aorta. This is a false lumen and the true lumen. So for distal arch and distal DT aneurysm, we use a completion of the left subclavian artery as well. The same approach we used, thoracotomy as well as stenotomy. This is the completed anastomosis, as you can see. This is the descending thoracic aorta, the proximal anastomosis, and the reimplanted left subclavian artery. So this patient had a coarctation repair, presented with a stenosis post repair. We repaired the entire descending aorta, part of the descending aorta using the same approach. Another patient who had a DTA underwent the same procedure. Now the thoracoabdominal experience from our center. This is we use the Coselli graft for treating this huge thoracoabdominal aneurysm. This is the intra-op picture, as you can appreciate, and this is the post-operative scan. Similarly, this patient actually had an aortic dissection repaired by me 12 years back. She had a aortic root replacement and using the right and the left femoral artery. Similarly, this patient had a Marfan's syndrome, had a David's operation done before. So we replaced the entire descending thoracic aorta using the Coselli graft. Okay. So these are our experience with a frozen elephant trunk. So this patient basically had an intramural hematoma involving the arch, the descending thoracic aorta. We use the frozen elephant trunk technique to replace the arch and reimplant the arch vessels. A similar case, we use the frozen elephant trunk like. Now, reoperative aortic roots. This patient had a infective endocarditis involving the previously implanted mechanical valve. The root was dilated. We replaced the entire root and did a ventral operation. Now, these are the infrarenal aortic aneurysms that we have dealt with, a few cases that I need to show. So this is basically the infrarenal aortic aneurysm. We replaced it, the entire infrarenal aorta with the Y graft. Now, hybrid TVAR with carotid bypass, extra-anatomic bypass we did, and this was stented using the TVAR. Now, this one had an interesting history. This patient had a renal transplant done a few months back. He came with limb ischemia as well as a blowout of the reimplanted renal artery. So we did we reconstructed the renal artery and used a technique to perfuse the solid organ to preservation. As we appreciate, preservation of the renal function is very important. So we used a technique where we took blood from the opposite femoral artery and perfused cold blood to a separate circuit and into the kidney, into the renal artery. So we reconstructed the area with a 8 millimeter graft. So this is one of our patients who are present with an adult coarctation in an adult scenario. We used the interposition graft to replace this descending thoracic aorta. So thank you for your time and attention. Thank you. Thank you.
We still have a fresh aortic case coming up towards the fag end of this session. So if there is any discussion you want to have with Dr. Atanu Saha, we can have it at that point of time. Okay, sir. Yeah. So we'll go back to Athens now. Athens feed will be coming in. So in the meantime, I'd like to call up on stage our distinguished chairpersons, Dr. Saptarshi. Saptarshi, please. Dr. Vinit Mahajan. Dr. Himanshu Das Mahapatru. Dr. Pinaki Mojumdar is here from the anesthesia side. Okay. Dr. Hiramat is back to auditorium, sir. So we'd like you to chair. Dr. Hiramat is Executive Secretary of ICTS. This is going to be a mitral repair talk from Athens. Unfortunately, the patient whom they had arranged for the mitral repair, he or she had less than significant regurgitation on TE yesterday. So for patient's sake, they have cancelled that case, live case, which was supposed to be there. So Dr. Theodore Kofidis is going to give a lecture, probably a interactive session is underway. Dr. Shomujit. Dr. Shomujit. Dr. Shomujit,
hello,
can
am
you
I
hear me?
online?
Hello.
Hello? Hello, can you hear me?
Is the blower?
Dr. Prakash Panjabi, sir, please
I hope
come on
it's
the
blower.
stage. That's it, sir. Yeah, that's it.
Okay. Can you hear me?
Minutes?
Back to Dr. Theodore Kofidis. Yeah.
Yeah, go ahead, yeah.
Yeah.
Can you hear my sound, please? Can you hear?
Yes, sir. Loud and clear. Yeah.
Okay, excellent.
Okay, something hit the floor.
Can you hear me?
How do you make the hole in the,
Hello.
I hear a lot of background from the operation theater. A bit confusing, but
Hello.
anyways, hello? Hello? Hello?
you make a hole with electric cautery?
Yes.
Hello?
Oh, that one, okay. I think it'll just, yeah, it'll just go right there.
Hello?
Yep. Okay, hold right here, yeah.
Hello?
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 Okay, you have a 5-0?
Yes. Hello?
Hello, we can hear you.
Yes. Okay,
From
now I
Calcutta,
have
yeah.
signal again. I was cut off the auditorium. I'm saying I have a lot of background from the operation here, hearing double voices. Is it possible to cut the sound from the operation theater as I
We've
realize
done that.
We've done that. We've done that. Yes.
Okay.
Please go ahead. Yeah.
Thank you very much. Okay, good afternoon, everybody. I'm truly sad to miss this great opportunity to be there myself, sharing the stage and the auditorium with very good friends and also with very good friends and colleagues, surgeons from the United States and Canada. Well, my regards to all. Thanks for having me. The patient yesterday was reported to me when I came over a last minute transesophageal echo with a mitral valve regurgitation about 2 plus or 3. I didn't feel comfortable before we have that TE and have a look at it myself. As it turns out, it was a 3 eventually, not really convincing for a very asymptomatic patient, and a lack of marginal coaptation just because of annular dilatation, actually, which is he had an annulus of 43 millimeters with an anterior leaflet of 28 only. And he also developed atrial fibrillation, which further aggravated that picture. And the mitral valve regurgitation was also very blood pressure dependent. So we provoked the patient and we could see the variation. So I didn't really feel comfortable going in and showing my new techniques because there was simply no doming.
We lost the sound again.
Hello, can you hear me?
We lost the sound again, sir.
But how about now? Can you hear me without microphone, without earphones? Hello? Hello? Can you hear me?
Yes, sir, we can hear
Yeah,
you.
we can hear again. Yeah.
All right. I have a good signal here, actually. All right. Without much ado, this was the reason why we canceled this case. We don't want to go online and try to repair something that doesn't need repair, actually. So let me share my slides and do alert me if the sound is gone for whatever reason. I'm going on presentation mode. And, you know, I titled my slides, Mitral Valve Repair Revisited, Thinking Laterally. Truly, I'm not here to contradict the well-validated Carpentier techniques, because the techniques I proposed and published about a year ago, they based on the same functional restoration of the mitral valve as posed by Carpentier in his French correction some 40 plus years ago. And we all know, you know, these are some of the gurus of mitral valve disease, with all due respect. But, you know, it's inherent to human nature to change, and sometimes we have to think laterally to better the way we do things eventually. In this case with the mitral valve, look, take for example, very common pathology like a P2 prolapse, symmetric or asymmetric prolapse. What are we gonna do? We're gonna use cords. Some people use one cord, others two cords, three cords. They position them in different positions. And I was myself very surprised last year at the mitral conclave to see the data of how many of those individual cords fail because of fibrosis, stricture, and or even tear. Some people use chordal loops, for example. So meaning to say there is a great variability here. Other people prefer to do resections, sliding plastics, butterfly plastics, depending on the underlying pathology. And there is a lot going on with the Barlow's disease as well, where people truly improvise oftentimes, and still after 15 chords, 17 chords, I've seen it happening, still come out with a significant regurgitation. In Barlow's disease, you may use a combination of procedures to get the best possible outcome. So I started asking myself, after decades in this business, how standardized are our techniques? How comprehensive and intuitive are they? How much variability is there from surgeon to surgeon? And do we respect or reject? Is it complicated or are we making it complex? Well, the mitral valve is a complex system. It's not a complicated system. That means there is a lot of confounding factors that affect the mitral valve and its leakage. And what kills the outcome in any complex system is variability. So every surgeon, as I mentioned, does a little bit of his approach to repairing the very same pathology on this very same patient eventually. So why is then that surgeon X coming out with a good result and surgeon Y not so much? So is there any way to standardize the procedure of mitral valve repair? So I was inspired by the reverse parametric test by Antoni Gaudí, famous Spanish architect of the last century, ancient Greek mythology, obviously, and architecture, and came up with a series of techniques that are standardized. You just follow a pattern. You don't need to think where you put the cords, how many cords, and so variability is largely reduced. And all these techniques are based on running sutures, mostly one running suture. As I said, it was published a year ago in the European Journal in 2 back-to-back papers. Let's move on to the techniques, and I'm not going to take you through all of them. There are 2-3 of them which are very popular and I believe can cover 75% of your practice. The Roman arch technique, for example. Here you go. You enter through the anterior papillary muscle. Let's say you have P2 prolapse or A2 prolapse for that matter. You enter through the anterior papillary muscle with your first Gore-Tex needle. It's a simple Gore-Tex suture like any artificial cord. Enter the anterior papillary muscle, come up the prolapse into the margin of the posterior leaflet, dive in and out 2-3 times, come down the posterior papillary muscle and wait. Do the same with the second needle of the Gore-Tex and you're done. Tie on the papillary muscle once your saline test is satisfactory. That's the Roman arch, and you can do it for the anterior leaflet as well. Look at this animation here. It shows you the course of the thread, the course of the suture, down the posterior papillary muscle. Same with the second one. You can adjust with hooks, pull it up a bit, or you can pull on the Gore-Tex that will push pull the system down into the ventricle. And you can make your adjustments as you test with saline, and you're basically done within 5 minutes. So I'll show you an example here from the operation theater. In the interest of time, I'm going to the actual image. And here you see I'm using our self-made endoscopic system that doesn't penetrate through the chest. I'll explain a bit about that. It's a IP we developed here at our university. So the 2 Gore-Tex needles go into the anterior papillary muscle. The first one traveled along the margin of the anterior leaflet as already. It's the anterior leaflet that is prolapsing here. And you see the P or the bridge that is formed. The second needle will do the same, will travel along the margin and then descend down to the posterior papillary muscle. Here you see the second Gore-Tex needle traveling through the margin of the anterior leaflet. Then the ring goes in and you do your saline test. Once you are happy, you can tie down on the posterior papillary muscle, or you may choose to bring the needles up to the posterior or to the prolapsing leaflet, anterior leaflet, and tie on the leaflet itself. Final saline test, which proves to be satisfactory, and here is the final result. Enjoy it. Please try it out. With hardly any regurgitation. I have more vignettes here, but in the interest of time, I could show you posterior mitral valve. Then we have the crescent technique that encompasses the A1, the P1 and the P3, if those are prolapsing. The V technique, it's, you know, the Alfieri stitch, which is a salvage stitch for most of us, and we try to avoid it if we can, you know, repair the valve structurally. So in this case, if you have an A2 P2 prolapse, for example, you enter with both Gore-Tex needles in the anterior leaflet, go down the papillary muscle and exit through the posterior leaflet. The two needles meet in the middle of the margin of the posterior leaflet. Of course, you can do it reversely. Start in the posterior, go down to the papillary muscles, come up to the anterior leaflet. And if you look at it from the side, it looks like a V. That's the Roman V. And that takes care of an A2 P2. Omega technique, the Longhorn technique, which is also called Minotaurus, it has proven in my hands and in other surgeons' hands very, very favorable for Barlow's. It really takes care of most of the work. As you enter the anterior commissure with the first needle of the Gore-Tex suture, down the papillary muscle under your P1 leaflet, up the margin of the P2, you may choose to take P1 as well. Travel along the prolapses, go down posterior papillary muscle, and then out through the posterior commissure. And the second needle does the same. And it entirely takes care of the posterior apparatus. You may have to put a second one for the anterior. Most of the times I don't have to. Particularly, sometimes you may have to close a cleft or add on one single cord, but Barlow's is taken care of. The Argo technique, Nessie technique. As I said, eventually we don't have time to go through all of this in detail. Here's the corset technique. Looks like a Belle Epoque time corset about a century ago. Let's take the posterior leaflet. This again will associate the papillary muscles, the prolapsing posterior leaflet, and the annulus with a partial annular reduction, as you will see here. Here is an example of the corset technique, very good for the tricuspid valve as well. Here is the preoperative echo. You see a very lengthy posterior prolapse, a long segment is prolapsing. I go in the anterior papillary muscle. Here I felt the papillary muscle was a bit weak, so I added on a pledget. The first needle goes directly under the P2 out into the annulus, and the second Gore-Tex half, the half of the thread, goes up to the prolapse, travels along the prolapse, goes down to the posterior papillary muscle, and out into the annulus under P2. The two needles then meet in the posterior annulus and are tied. Here you see the threads after the ring is in. The sutures are now tied after the saline test. And the final result is quite satisfactory. No residual regurgitation. And it really literally takes a few minutes. Buffalo head, the phoenix, the anvil. Here is a posterior leaflet prolapse, significant prolapse. Here is the secret with our non-penetrating atrial retractor. I'm using a kind of a USB retractor, which we modified, but the camera goes through the shaft and attaches on the underblade of the retractor, hence providing you spot-on view of the mitral valve with a wide-angle camera, but you don't have to use all this big apparatus, penetrate through the chest, defog, clean all the time, reposition, all this is gone. Here you see the prolapse. Again, the Gore-Tex, you see both Gore-Tex needles went through the anterior papillary muscle. The first one is now traveling through the margin, the rough margin of the prolapsing segment, goes down the posterior papillary muscle. In the interest of time, I fast forward. The second needle now follows the same pattern. It's just a blind pattern. You don't need to think and guess where to put multiple cords. You do your adjustments with your hooks, put in the ring, do your saline test, and when you're ready, you tie on the papillary muscle. Final result, as you will appreciate here, no residual regurgitation. These are some of the vignettes. Now here's a Barlow's with the Minotaurus technique. Look at the sequence of the thread of the suture. Commissure, papillary muscle. Take all the prolapsing segments, P1, P2, P3 if you have to, down the posterior papillary muscle, out the commissure, and that controls the diameter as well, the intercommissural diameter. So here is a such a case of a Barlow's. You see the first Gore-Tex is at the commissure, sorry, the second one. The first one is already traveling through the rough margin of the excessive posterior leaflet. In the interest of time, I jump forward. And it exits here on the other commissure, exits on the posterior commissure. Saline tests as we go. Then the second Gore-Tex needle will follow the same pattern down to the papillary muscle, up the margin, travel along the margin, exit through the posterior commissure. Now you have both needles on the posterior commissure. Here I chose to close the cleft with the Prolene and add on an additional single cord to the anterior mitral valve leaflet. Here is the additional cord there, but certainly not this mess of 20 cords, 15 cords, 12 cords, whatever, and then you add on, you're still not happy. And quite satisfactory correction of the Barlow's. I'm glad to say that even Altieri and his team in Milan are using the technique. Yesterday it was, those techniques are now being used globally, and we're producing a database in order to publish a follow-up on all those patients. And of course, let me, disclose with great satisfaction that I was contacted by a Parisien, by a French surgeon from Paris, who is using these techniques. That was a bit of an enclave of Carpentier techniques, which I continue to use, don't get me wrong, but I think it's okay to add those techniques I'm presenting in your armamentarium as well. These are, the video is not running, but in conclusion, the techniques I proposed are simple, standardized, intuitive, less intuitive, more intuitive and more standardized compared to the existing ones. They involve less foreign material, they reduce variability, and they make the mitral valve repair accessible to junior surgeons as well. So I repeat what Perrier himself actually said, there are many ways to skin a cat, and we must change, in his recent talk at the ESCTS presidential lecture. So I have to repeat that these are verified techniques, but to speak of validation, we need to give them time, produce follow-ups. But I'm glad to see that a lot of surgeons across the world are using them with ease and with very good success. The first robotic Minotaurus for Barlow's disease was done successfully by Dr. Nambala of Bangalore, India recently, and the list is growing. With that, I come to the end of my presentation today. Again, I'm very sad I wasn't there this time, and looking forward to the next time of being present. Thank you very much.
This is Kunal here. Thank you very much. Thanks for your time. Thanks for being patient. And can I ask Prakash to open the discussion? Yeah.
Thank you, Kunal. It's a pleasure to be here. Thank you, Theo, to hear your wonderful overview. I think after your talk of various techniques and the, as you quite rightly pointed out, the neocord doubts, we are moving towards long-term dynamicity, and we saw this morning how we can buy more time. We are more comfortable with on-table success, but we are more looking for durability. What do you think for the long-term durability, which would be, I think the doubts for neocord have made us think a lot more harder for the various techniques. Thanks.
Yeah. very good question. And this was one of my initial self-reflective questions as well when I developed these techniques. Now, the individual chords excite a lot of punctual pressure, tension on the point they insert on the rough margin of the leaflet. And durability is in direct association with the tension at the point of insertion. If you have an individual chord, of course, the tension, the traction on this point will be very, very, very high. And that is what is causing the mechanical irritation, the proliferation of tissue, and the fibrosis in that area. However, as I mentioned, I was inspired by the parametric tests of Anthony Gaudí or the Roman arch. The arch, that means if you distribute this tension over lengths of tissue and not on one single spot, then eventually the tension will be lesser and the structure has much more stability. So I can imagine at this point and speculate that in the long run, the damage, the tension to the rough margin of the leaflet is less. The distribution of pressure and control of that area of prolapsing leaflet will be better with the arch technique compared to punctually inserted individual chords.
Yeah, thank you. I think the philosophy and the principles that you are utilizing certainly seem very sound and would probably explain, but we do know that in normal anatomy, we get disease in the P2 part because of the fact that it is the smallest leaflet with the maximum force. But yeah, I think this has all the potential, but thank you for sharing with us. If there's any other question on the floor, otherwise I can carry on. There would be another thing. I think we would all be very interested in the choice of the supportive annuloplasty ring, and how far would you be willing to compromise rigidity versus flexibility, and does that contribute to the long-term durability? Thanks.
Yeah, I mean, to be very honest, I don't relate the choice of my techniques or the techniques I've shown to the choice of ring. I'm a bit of a conservative person in terms of rings. I don't use a large choice of rings. I work with semi-rigid rings most of the time. For most of the pathologies, I use complete rings. There are a few occasions where I use open rings from trigon to trigon. I don't use flexible rings myself or bands, but this is, I guess, a matter of choice for the surgeons. And with that humble experience, I've had a very good run over the last decade or so.
Maybe I can ask Dr. Boone for his view. Dr. Boone, what do you think? Maybe if oh, you got a mic. Thanks.
On the rings. Yeah, I've always used the bands for many years to support the posterior annulus, feeling the anterior annulus itself is supported by the fibrous body of the aortomitral curtain. Today we used a band, full ring, but because we didn't have a band available. But I think in this particular case of today, we could have used a band or a ring. I think the support on the anterior annulus is in most cases not necessary. If we're trying to downsize the annulus, certainly we'd probably want to use some support on the anterior annulus as well. What is that a thought process?
Yeah, absolutely. I think you're quite right. It's a choice of ischemic, degenerative, rheumatic, and
right.
Degenerative. Absolutely, fully flexible, doesn't have to be complete. Ischemic by law must be complete, must be rigid, and rheumatic. Most of the times, actually, I mean, in my cases, which I do here in Ethiopia, it's complete ring because it's very difficult to get a good result.
Right.
And you really want to stabilize the annulus completely and not leave anything to chance. And whilst they say that the anterior part of the annulus between the two fibrous trigons does not dilate, we all know now with anatomical anomalies that that's not entirely true. And certainly in rheumatic process, which is an ongoing process, I feel very strongly that it's better to use a complete ring.
Right. Yeah, that's what we did today. And I agree with that assessment with the degenerative versus rheumatic versus ischemic.
Yeah. Thank you.
Thank you, Dr. Prakash.
Thank you.
We have 2 cases waiting in the OR. So
Thank you,
we need
Theo,
the
for
video feed
this
coming.
enlightening talk. Thank
Thank
you.
you, Dr. Theodis.
Thank you all. Thank you.
Thank you. So over to the MICS CABG where incision has already been given. So let's get back to OT4. Dr. Shomujit? Sir. Dr. Shomujit, can you hear?
Hello.
Yeah, OT4, Dr.
Hello,
Shomujit.
hello.
Yeah.
Can you hear me?
You are at MICS?
Yeah, I am at
Yeah.
MICS. Can
Yeah.
you hear me?
Yeah, I can hear you.
Yeah.
So go ahead.
We have not given incision. Can
you see us? Okay, you're waiting for us.
Going
Yeah,
to give
fine.
the incision.
Yeah.
Can you hear me?
Yeah. Go ahead.
And can you see the? You can see the incision here. Nicely. Can you see us?
Yeah, we can see.
So usually in a mid cap we would go equally on either side of the nipple, whereas in a multi vessel we would slightly displace the incision laterally. So we would start at the nipple and then go laterally. Okay. So we would make about a 5 to 6 centimeter incision in a right angle. Yeah. You have a right angle. So you basically are you on single lung ventilation? Forceps, please. Debegi. So what I do is generally make a very small opening here first in the interspace. And then let go. You put my finger in and you try and feel the apex of the heart. So that gives you an idea exactly where you are. If your finger goes downwards, like so caudally for about a centimeter and a half, then you're usually in the right intercostal space. On the other hand, if the apex is high up, then you're too low on the incision, and then you have to go one space higher. So that's how we decide. So here, actually, I'm going caudally, so it looks like we are in the right space at the right side. So then we open up the entire interspace. I need the longer cautery, the long without the insulation. No, this is. Can you take mine, please? Do you have? Yeah. Can you take my long one? Yeah. This is not working. So how do you do it? Can you change it? On the spray. Yeah. Can you change it to no? I want to spray. There's now on spray. Okay. So you go along the length of the fibers rather than cutting the fibers off of the pectoral at least. I mean the intercostal muscle you have to cut. Can I have my headlight on? Headlight on. Headlight. Headlight is on. No, it's not focused. Can someone focus, please? You have to just yeah. Can you focus my head to the left? Okay. Are we live or? Can you see it?
Yeah, we can see you.
I'm not. Just let us know if you can't see at all. Because
Perose, this is Cliff. We can see you nicely. We're just going to swap back to the aortic room.
pardon?
We're swapping back to the aortic room. I think Chris is coming to the end of his case.
Sure.
And we'll be back with you if you just
Dr.
tell us
Shomajit,
what you do.
Yeah, that's all actually I wanted to show as far as the incision is concerned.
Yeah.
Yeah,
So let's go to OT2 then for
Okay.
for the
We're going to OT2.
towards the completion. Yeah.
We'll be back with you, but
Yeah.
that incision's about the size I put the drain in, right?
Cut. Have you taken my copy? Yeah.
Dr. Shomajit, can you hear me?
Hello.
Dr. Shomajit?
Yeah.
Can you swipe to OT2?
Yeah, I'm going to OT2.
Yeah. Thank you.
Wait.
Okay. Real. Here, Niraj, come here. You do. Yeah, 3-0. Stitch.
The voice is from OT2,
3-0.
but the image is still from OT4.
Where's Niraj? Can you do?
Just a minute.
There's a little bit of a mismatch, okay? The bottom graft is bigger.
Yeah.
New glove.
Chris, this is Cliff. We're hearing you, but we're not seeing you just yet. We're joining you again.
Dr. Shomajit, we are still having a image of OT2.
Focus the camera.
Yeah.
I think we're back.
Yeah, I'm going back to OT2.
Oh, you got me on the wrong one.
It'll take some time, just a few minutes.
Yeah. Setting up.
Okay, new glove. Right side.
Right. 5 minutes. They're moving a camera from OT1 to OT2. So it'll take a few minutes. It'll take 3 to 4 minutes.
So the bottom graft is bigger, okay? So small, yeah. Big and small there, yeah.
So in the meantime, Dr. Chris, can you just give a rundown as to what happened till now? We're not able to see you, but we'll see you in.
Yeah, nothing's coming off of my camera now, huh?
Yeah, no. It'll take a few minutes because the camera is getting ready. It'll come in 3 to 4 minutes. Can you give a rundown as to what happened in your?
Oh, unhook here.
Yeah.
Yeah, no problem. Yeah,
Yeah,
so we're
please.
just finishing up we're actually almost done here. So graft to graft anastomosis. So we got the we left you where we're sewing the sinus remnants in. So we finished that. And then we had to do central free margin plications because the leaflets were long. I usually use a caliper to help measure the effective heights. But today I just use my eyeball. But we ended up doing central free margin plication of all 3 cusps. I showed Niraj how to equalize
Camera is getting
the
ready.
cusp lengths. The buttons went on. We used 5-0 polypropylene suture, no bio glue, no lifesaver, no pledge it. And for the ascending graft, we picked the 24 millimeter graft to replace the ascending aorta. And this is the David 5 Stanford modification, so 2
Right.
graft technique. So the 24 millimeter graft is going to narrow the sinotubular junction down when we sew it graft to graft. And Niraj is doing that right now. Have you got the camera up?
Yeah, we
Yeah,
got you now.
We are
Yeah.
seeing you.
But you don't have my camera.
It's not in focus.
Nothing is happening now. I'm gonna have to unscrub to get this fixed. Yeah. What about the overhead camera? Is the overhead camera going?
We had the overhead. We've gone to the other room, Chris. The overhead camera was great, but it was just looking
Oh, yeah.
at the Venus
Yeah.
pipe.
So do the overhead camera. Because my camera, I'm not in the
Okay,
field
it's
anymore.
we're looking at the Venus pipe. That's the only problem. We can't. If you could just shift it down
So
a
that
little
one
bit.
there?
You just shift it a little bit. We can't quite see what you're doing. We're looking at the Venus pipe. I'm familiar with it. You were commenting on it. It's a nice one. It's flat, left, right, drains beautifully.
So guys, can you see the overhead camera now?
We
No,
do. Chris, can you hear us, Chris?
Yeah, I can hear you.
Yeah, it's the camera is not looking at your operative field. It's looking at the Venus pipe. If you could just shift it slightly
upward, yeah, upward.
Yeah, that one up there. Cameraman, yeah.
Oh, yeah. Now, yeah, that's okay. Yours would be better.
Yeah, I got to fix my camera. It looks like it got.
No, we see you're doing the graft to graft. Just
so you're finishing the anterior part right now.
the theory
Yeah.
being, Chris, the smaller one is for resuspending and to make that easier, which is the other reason that Craig Miller didn't like the Valsalva graft, right?
Yeah, that's correct. So with the Valsalva graft, you're pretty much locked at both the proximal and the distal. This one gives us the freedom, like I said, to set the annular diameter. We can set the commissure height. We can set the sinus size. And then we can also set the sinotubular junction. So the sinotubular junction is going to be the distal graft size. So that's pretty nice.
And you find it's also shorter, obviously. So it's so
Yeah,
you're not working in so much of a tube.
Yeah, that's right. Can you guys see the valve from where you are? You should be able to look straight down in the valve. and
You'd
can
have
see
to
the
if you
central-
open it a little bit where you're suturing now. If you open it a little bit, we'll be able to see in.
Niraj, can you show that to him?
You got to open that a bit. Yeah, there we go. Just
Headache.
you can just pull it slightly inferiorly. If you can pull it slightly to the venous pipe, then we'll see better because we slightly obscured by the top of the sternotomy wound. That's better. That's great.
Yeah.
Yeah, you can see the
Is that visible?
We
Sort of-
saw you suturing the commissures nicely. Just in terms of tips and tricks for your coronary button height.
Yeah, the key to the core button is to get good mobilization. If you get good mobilization, you can put them anywhere you want. And what I do is when I mobilize the buttons, what I think of is mobilizing the root away from the button rather than mobilizing the button away from the root. So all the mobilization happens with the alongside the root only. So I don't mobilize around the coronary artery because you could injure it. But if you mobilize the root away from the button, then you get enough mobility to put it wherever you want. Because we want to put it in the middle of the neosinus.
Chris, can you just go over again what you did with the leaflets? That was obviously you did some plication. How do you normally decide how much to plicate the leaflets, and how did you decide today how much you wanted to plicate each of those leaflets?
Yeah, so I look for a reference leaflet. Usually there's one leaflet that is a good effective height. And if you have a tough time picking, it's usually the left coronary sinus or left coronary cusp. So pick the left coronary cusp. From my eyeball, again, I usually use a caliper, Hans Schaefer's caliper. But from my eyeball, it also looked like the left coronary cusp was sagging, so it's prolapsing. So I went ahead and put one central free margin plication on the left. And then from there, you could use that as a reference point to set the other leaflets. And the key thing there is to make the free margin lengths all equal to each other. And that would have been better demonstrated if you guys were, when you finish it off, Niraj, we got to get out of here. Yeah. Yes. Yeah. Yeah, I wish we could have shown that to you earlier when we're doing that.
You're actually measuring the free edge lengths of the leaflets.
It's not working anymore. The head cam.
Recorded?
Oh,
Chris-
I have it recorded. Yeah.
Chris, I was just going to say, I believe it's all recorded, so
Yeah, we can show it to you later. Yeah, finish.
we're going to be able to see it later.
Finish. Yeah, finish. We got to come off pump. Yeah. We've been operating for a little while here. Yeah.
You can get the playback from there.
Oh, good.
They have it recorded.
Okay, so we can go back and take a look at it. Yeah.
OP2 recording.
Can I go to MICS CABG once again, Dr. Shomujit?
Chris, we're leaving you again, Chris. We're going to watch the recording of that. That's going to be really great to see you doing that leaflet work. But we're going to go and join Perot's now, and because he's getting all set up with his mini and mid-cab cabbage.
Dr. Shomujit, can you hear me?
Hello.
Can you go to MICS once again?
We're going, but before that, some recorded part of that
Incision.
rental. Yeah, we'll show you.
Okay.
We're going to watch that recording now.
Yeah, that's what they're suggesting.
Chris, can I ask you a quick question? It's Pooja. Can you talk a little bit about your evolution of, doing the David procedure? Did you start off with one, a straight tube graft? What do you think are some of the advantages of downsizing at the STJ within a Dacron graft in itself? Do you feel like the flow dynamics are different at the root? And are you worried about early valve failure for that? Chris, did you hear me?
Hello? Dr. Shomujit?
Oh, hello.
Can you hear me?
Yeah, I can hear you.
So what are you up to? Are you going to get
I'm
the
going
recorded
to,
video?
show the recorded part of that rupture and root repair.
For a minute, can you get across to Dr. Christopher to put across Dr. Pooja's question? Hello?
Yeah, Chris, we can hear
Yeah,
you now.
I can hear you, Chris.
Not yet.
Hello?
Yeah, we're trying to get you the recorded video.
Okay.
I think this is an important point. So if we could show this video, it'll inform those of you who want to do valve repairs and David's. I can see you guys.
Yeah, we got you now. We got you.
You can see the video?
No,
It's
it's
not,
just a
we can-
static
it's-
image
It's
till
still
now.
now. You can run it now. Yeah, you play and you talk us through it.
So already did central free margin plication on the left cusp. That's my left hand. Now I'm doing a central free margin plication on the right coronary cusp. And you just have to match the lengths of the leaflets. I find that the nodulus of Orontius gets elongated with these aneurysms. So this is a 5-0 polypropylene suture. And then when I tie these down, what I want is for the leaflet to evert outwards. So I want it to point outwards towards the grafts. You see how that's pointing out that way?
Yeah, we got that nicely.
That's exactly how I want it. These can be pretty delicate. If the leaflets are really delicate, I'll use a 6-0 polypropylene, but this one, the leaflets are pretty good where the nodulus is. I think this next one is going to demonstrate how to equalize the lengths here. Raj is helping me pull the leaflets, and you can see where the stitch has to go from here to the left cusp. See that?
Yep.
And I'll put a stitch right there to equalize the lengths. That one's a good example of the nodulus of Orontius getting really, really big. It looks like a dumbbell, which turns out to be pretty convenient. That's all we end up having to close.
So you're shortening all three in this particular individual.
That's equalized to the right, and then we can do the same on the left. We can equalize it there. We know exactly where to put that stitch, which turns out to be a pretty thick part there. Raj is an excellent surgeon. He helped me out a ton on this case. When I tie this one down again, I want the nodulus to evert outwards towards the background graft. You can put an extra stitch at the nodulus. I sometimes do in order to reduce billowing. If you grab more leaflet down on the belly, it'll help reduce billowing of the leaflets. We'll see what this one looks like on echocardiogram.
Chris, you assessed that all three of these leaflets then were somewhat redundant and stretched because of the aneurysm. So you've shortened all of them.
Right. Yeah, I shortened all of them. Again, I think that's where the
The same sort of distance, or was that last one slightly more?
I thought they ended up pretty good.
Okay, good.
Eyeball test, yeah. And then from there, we just put the buttons on. So I think that's probably the most important part.
Just before we did, Pooja had a question for you, which, and then we're going to leave you and go to the car or anything, but that was very, very nice case. Thank you for sharing that with us.
Hi, Chris. Nice job so far. So just couple quick things of, how you've evolved in doing your David, if at all. You know, Tyrone David, you know, reports his 20+ year experience with using the David 1 approach and with good long-term outcomes. So, you know, what do you feel is the benefit of, you know, having a smaller sinotubular junction within a Dacron graft? Do you feel like the flow dynamics at the root are any different? Because obviously he's demonstrated that with a straight tube, it may not really matter long-term. And then I guess on a secondary question to your leaflet repair, if you're ending up plicating all 3 cusps, would you have selected in retrospect, one size smaller graft to sort of have increased coaptation and not worry about this much prolapse?
Yeah, I'm not so worried about gradients after tri-leaflet repair. You can cinch up that leaflet a lot and not get any gradients. That's because it's a 3-leaflet valve. When it opens, it'll open up all the way. I'm more concerned about getting gradients with bicuspid aortic valve repairs. That one, you have to be really careful about over-tightening the leaflets for a bicuspid aortic valve repair, because in those cases, you will create a gradient. And that leads to your first question. I think it's important to get a narrow sinotubular junction for your bicuspid aortic valve repairs, because that will not stretch the coaptation together and will reduce the amount of gradient you get. The sinotubular junction doesn't matter so much for 3-leaflet repair, so the David 1 is totally fine, but I think it's very important for your bicuspid aortic valve repairs where you can create gradients if you're not careful. Well, I'm going to check in and see how Mirage is. I'm also interested to see how this echocardiogram looks here.
We'll see in a little while, I think, and just see it all, but thank you for that.
Yeah. Can I go to MICS again?
Yeah, we are now going to OT4.
Yeah.
To the liver harvester.
Okay.
Hello.
We're back with you. Right.
Can you see the scope?
We got a very nice.
You can see the mammary, right?
We can do. We're looking at it now.
Is this please? So I've just clipped, just to show you how I usually try and do a clip and cut technique.
The one slight problem we got with the cameras, we got the picture on picture. If we could just, yeah, that's better. That's great.
Keep showing exactly where I'm working. Okay.
So we saw your setup, and just in terms of insertion of the retractor, is there anything
I can maybe
we can
show you
learn?
the retractor. Maybe 1 sec. I'll just. So you just basically push the mammary down and push everything, all the rest up. So we just show you the setup. Can we have the boom camera? Do we have the boom camera?
See, we're seeing it, but it's the
see-
small one in the corner. So what we got is
So can we?
we just need to swap it. Now we swapped
can you-
across to the wrong one. We swapped across to your head cam. We need to swap to the other one.
So you're on the boom camera now?
We're on your head cam now.
No, I don't have a head.
Oh no, okay, we're
We're on the scope right now.
on the scope. That's good. That's the one. We got it.
You got it?
Yeah.
So this is what is known as the roll track system, which is connected to the table, and it's got a pulley here. And this is the thoratrack retractor. This is from Medtronic. And this basically helps to elevate the upper part of the thoracic cage. So we put this in and then we connect it to the pulley, and the pulley pulls up the blade and the blade pulls it up. The one thing to be careful is when you put the blade in is that your blade should be facing laterally and not medially, because if you elevate the blade within the medial position, there is a chance that you might trap the lemma, and that's pretty much the end of your case. So you have to at first direct the blade more laterally, pull it up, and once you have a look at the mammary, then you can readjust the blade as you want it to gain optimal exposure. We'll go back now to the scope. Can we swap the cameras again?
Yeah, we saw that really nicely. Now we're back with your scope cam.
Yeah. So just change it around.
Bruce, when you're doing this, you're looking at direct vision, or are you typically using the
No,
scope?
I'm looking at direct vision. The scope isn't just to show y'all. You can have the suction, the fine suction. So I'll just show you this. This suction is really very helpful. What I use for this is the pulmonary end arterectomy suction cannula, which is just amazing because it's got a very fine tip. Can you see it now?
Yes, we can see it now.
So you can, even a small little amount of blood obscures your vision. So this really gives you very clear vision, and you can also use it as a retractor to push the mammary down.
And you said you like to use a skeletonized mammary harvest. Is that
Pardon?
You like to skeletonize the mammary when you're harvesting?
So I'll just show you. So here you can, I'll just show you. So you can, so that's the subclavian vein already, right? Can you see it?
Yes, we can see it.
Yeah. Can I have a clip? Hold it, please. Clip. Scissors. The long one, please. The longer one. Yeah. You have it open, right? What is it? Can you have scissors, please? Y'all could probably go, if y'all want, go ahead with a talk or so, if y'all like. You're welcome to stay.
Sounds good.
But
There's one question. If you happen to have, if your incision isn't perfectly placed, what other tricks do you have to be able to get this exposure? Or do you just reposition your incision going to another intercostal space? You were mentioning earlier
So,
about the sensitivity of that.
sometimes you may find that, just because of the patient's anatomy, taking down the mammary is probably easier from one intercostal space, and doing the anastomosis is probably better from a lower space. So I wouldn't hesitate to open two intercostal spaces.
Right.
You could can open two intercostal spaces as well through the same incision.
Right.
So you're completely separate now, almost, from the subclavian vein. The problem in showing this procedure is that we have to keep cleaning the camera as well. Your forceps now?
Firoz,
Yeah.
it is Saja. If you go through two spaces, do you increase the skin size, skin incision size?
Pardon?
Do you increase the size of the skin incision if you are
Not
going to
really.
do? Not.
You can go in through the same size incision generally. Size of the skin incision increases only if you're in a sort of a desperate situation and you have a problem or bleeding which you cannot sort of control it. In that situation, you could extend your incision. The best thing is, of course, if you have a harmonic scalpel, that's great. It really facilitates takedown of the mammary.
The instruments that you're using are just typical minimally invasive instrument sets or anything specific?
I can't hear. I can't hear you very clearly. Can you, little louder?
The instruments that you're utilizing, anything? So, are you just using a standard minimally invasive instrument set, or
So my instrument set is like the mini. I think the endo forceps are from failing, but you can use any. Many of the companies make these instruments nowadays. So whatever you're comfortable with, you could use. But they have to be fine forceps, right? And it's not the ones which you use in many mitrals. Those are a bit thicker, like the DeBakey's and all. They are 2.8 millimeters at the tip. These are like 1 millimeter at the tip. So you need that for the mammary.
And once you've taken the left mammary down, the space opens up for you to then get over to the right side to take down the right
Correct.
mammary.
So the right, then you have to. Can you see? Yeah. So you just you can open this here and start going to the right.
Yes.
Like I'll show it to you later on.
Okay.
And if we need the right, we'll take it. But if we don't, I'll show it to you once I take down the left.
Sounds good.
Flip, please. I'm trying skeletonize. Skeletonize. Is this? So the harmonic scalpel saves you all this time of clipping and everything. Can I have the head up, please, again? And turn the table to the right. Okay, to the right. Okay, that's good. So you have to take this fascia down. There's no alternative to that, obviously. So as you come downward, it becomes muscular. On 30. Yeah. Yeah. Are we still live or?
Yeah, we're watching it.
Yeah. Go ahead and ask any questions that you all may have.
Well, we heard your comments on the harmonic scalpel. That's very important. You reckon?
Was that?
No, just in terms of having a harmonic
Yeah.
scalpel rather than regular Bovie.
Turn the table to the right, please.
And in due course, you're going to decide on that diagonal when you actually see it.
Yeah, we'll open the pericardium and have a look.
And your strategy would be to then use the distal.
And then I'll have a look whether first is it possible to sequence it. Well, first of all, whether it's possible to bypass it, and if so, whether it's possible to sequence it, or do we need a separate graft? If a separate graft, then is my left internal mammary long enough that I can use a small piece and do like a Y or a T graft and get that done, or then whether we need another conduit. So if we need another conduit, we could always go to the right, or take a small piece of vein. Or
Would you factor in the future in terms of keeping the right for the future if necessary, and just for
well, this guy,
diagonal use a bit of vein?
yeah, I find it a bit of a waste to use the right for the diag, and for the diag that we have. And to be honest, for demonstration purposes, otherwise, like, as you know, nobody dies of diagonal disease. And the diagonal that we have here, I don't think leaving it or doing it is going to change his survival or his quality of life. So, but for the sake of completion of revascularization, we always do it, right?
Well, I mean, the blanket statement's right. I mean, you don't die of diagonal disease, but I think it's really important to recognize their diagonals and diagonals. If a person has a really redundant circumflex system, really small, then I think a big diagonal that's going quite
true, yeah.
sharply onto the lateral wall is an important vessel. But in this patient, those of us we saw,
a huge circumflex, yeah.
Yeah, so it's a very big circumflex. So and then your rule in terms of jumping as opposed to
Pardon?
Your own thoughts in terms of doing a lemur jump graft, leader jump graft, as opposed to getting another conduit and doing a Y or T.
So when I do a diag, I've pretty much never do a diamond anastomosis. If I can do a nice parallel anastomosis for the diag, then I would go ahead and do it. is just because of the lie of the graft. There are high chances of the graft kinking when you do a diamond anastomosis to the diag and then come up to the LED.
Well, I agree, and
you're jeopardizing the the main graft.
well,
right?
that's the main point in my eye. You're jeopardizing the main graft.
So unless it's like a slam dunk, then many times you get a nice parallel diag. So I don't think that should create a problem.
I
Firoz,
spoke with.
Again, the important thing is to see the degree of stenosis between or the difference in the degree of stenosis between the diag and the LED. Like if you have an occluded diag and you have a 70%, pottery please. If you have a 70%, so just to show you, this suction is really nice. You see that? Like even if it bleeds a little, it clears
Yeah,
it
we
off
see this,
very
sure.
well. So this is sort of, I think it is mandatory to.
It's kind of two in one, suction and retractor.
Correct. Um,
Firoz, if you have a larger diagonal and you are not able to do a jump graft on that, would you prefer doing a baby Y with the same memory?
Would I do the?
Baby memory Y graft? Baby Y, the same.
Yeah, that's what I
sort of-
said, that if the memory is long enough, we'll do that. We just take the end of the left mammary and do a sort of a Y graft to itself sort of thing. In this case, we could probably do that because it's a occluded LED. So you can anastomose the LED high up as well.
Just while you're working, just your thoughts. You use sort of Y graft, T graft interchangeably. How strongly do you feel if you're doing a say an OM Y graft, that it's a Y graft, not a T graft?
So most of the times I do a Y graft because I get a nice big anastomosis. A T graft is only for the sake of the lie. Sometimes where you would end up doing a T.
So
And if I'm doing a vein graft, then I would do a T because the vein graft is huge as compared to the mammary. So the T graft is not a problem. But any arterial graft, my first choice is.
I don't do many side to side grafts because I'm almost entirely on pump. And secondly, so I only do it when I'm short of conduit. But I'm very keen to use a Y graft because I had this discussion with John Puskas. John says he always constructs the Y graft himself because he thinks or the Y or the T because he thinks it's so important. He lets the resident do the bottom end, but constructing the conduit he does.
That's correct.
So I said that T graft to me is unphysiological. He said, well, it's not, because if you think of the renal arteries, they come out at a right angle. I said it's bigger. Whereas the other ones are small vessels, must be a Y graft.
I agree. I mean, I don't think the flows matter too much. Whether you do a Y or a T, it's more important how the lie of your graft is and whether it's prone to kinking and such. That's more important, I think. And of course, it's like in an Indian situation where the mammaries many times are really small. I would say that doing a Y graft is safer. My Indian colleagues could give their take on that? Dr.
Yeah,
Sarkar is
yeah.
around?
Yeah. Probably for Indian coronaries, the memory size are definitely smaller than what we find in the West. But in the even when you do a smaller size lima, when you do the Y graft, equally the proximal segment of the lima, it grows much faster. Even at 3 months,
Yeah.
we have demonstrated that the proximal part of the lima
One more.
has grown significantly at the 3 months time. So probably whatever is the size, if the flow is good, probably we can do Y graft anastomosis with the lima.
Yeah.
Pros, I've always figured it's one of the easiest things to test. You know, you can create your Y graft and then put a couple of bulldog clips off, release it, put each side into a test tube and see how quickly the two test tubes fill.
Well, there's a study by David Glinner comparing Y grafts and in situ grafts. And he's found that there's no difference between the two. You have to take, of course, into consideration the grade of stenosis. I think that's one of the most important, and the runoff that you have. For doing composite grafts, if you're going to disregard those two parameters, then you might have grafts that go down. They don't usually cause harm to the patient, but you know, the graft goes down though.
And any concern for your Lima graft going down if you've got, say you got a sort of 70% stenosis?
70?
Yeah, 0.7 John
70?
FFR, and then you got a very tight lesion, say on a large OM. Are you ever worried?
70% I wouldn't worry, but anything less than obviously I always get an FFR done. And if the FFR or IFR are significant, then I would go ahead and do it.
But I'm just talking yeah, sure. But in the context of a Y graft, whether
that you should avoid. Like if
so you'll avoid a Y graft in that more kind of borderline situation.
correct. So if you have a distinctly like an occluded OM, and then the LED is positive on FFR, then no, then I would avoid a Y graft. Then I would do individual grafting.
Yeah. Because if the LED stenosis is not significant.
Pardon?
If the LED stenosis is not significant and a very tight OM is there, it's always better to do a individual graft for them than the Y. Even for the flow that occurs through the circumflex territory is much more, automatically the distal flow to the LED will come down because of the preferential flow to the circumflex. So in all cases, when there is a LED stenosis is not critical, and probably patient should receive individual grafts to the LED and circumflex.
No, that I agree with you. Painful here.
Perose,
Yeah.
we were just thinking of getting on and having one of the lectures now.
Yeah, just go ahead
Ram's
with the
got a
lecture.
lecture, and then that'll be.
Then we'll come back when we are done with the mammary and we've exposed the diagonal.
Yeah, so it's only going to be about a 15-minute.
Yeah, so we should be take
Lecture.
another 10-15 minutes. I have to get it down till like the last quarter is left.
Okay.
Sure.
So for the last session, I'd like to call up on stage the chairpersons. Dr. Manoj Daga. Sir, please come. Dr. Rajarshi Basu. Dr. Anshuman Mondal. Sir, Dr. Anshuman Mondal. Yeah.
Can do you have a Dietrich person? Dietrich? It's a
Dr. M. Das.
Fine debate.
And Dr. Mrinal Bandhu Das. Dr. M.B. Das is here. We spotted him in the morning. I think he has left.
And there are some people finishing off their lunch.
Yeah.
I think they'll wait in the OR. I think if we wait for 10.
I think we'll wait for the hall to fill up.
Yeah, I think
5
we-
minutes.
I think we wait for-
because we'll miss the talk otherwise.
Yeah.
Just for 5 minutes. They can wait.
Let's continue because by then Bruce will be ready. I think we should.
We can have a discussion then properly. Yeah. So we have an invited talk by one of the distinguished doyens of congenital cardiac surgeon, Dr. Sitaram Imani, who is an associate professor at surgery at Harvard Medical School, and he is a director of complex biventricular surgery program at Boston Children's Hospital, United States. Thank you. Over to Dr. Imani.
Well, thank you for the invitation. I hope everybody is enjoying the live session, and we will talk a little bit about shifting from adult to the pediatric patient. And I'll be addressing the management of congenital mitral stenosis, and I look forward to hearing. Yes. So I look forward to hearing any questions about management of the pediatric patient with valvular disease. You know, this is a little bit of a different game altogether because now you're trying to tailor your approach to the pathology that is present, and frequently it is not always easy to assess this. Do I have control here? Okay, so this is why the imaging is so important, and I'm always very careful about assessing the mitral valve by echocardiogram. It's really our best imaging. So you want to pinpoint the mechanism very specifically, and you should almost imagine what the valve will look like by looking at the echocardiogram. So in the assessment, we think about obviously dividing the mitral valve into the separate components, annular, subannular, and at leaflet level disease. So here in this patient, obviously there's prolapse of the anterior leaflet. But I want to know not only where is there prolapse, where the prolapse is located, what the degree of prolapse is. In many patients, though, you can get what appears to be prolapse of one of the leaflets, but in reality, the problem is that there's restriction of the contralateral leaflet. And so this must also be addressed. So here in this situation, even though it looks like there is prolapse of the anterior leaflet, in reality, there's more restriction of the posterior leaflet, leading to the posteriorly directed jet. So in terms of interventions that we perform at the annular level for congenital mitral stenosis, frequently there's a fibroannular ring at the level of the leaflets and the annulus that can be debrided. Many of these patients can also have dilation of the annulus, even though that there is truly congenital mitral stenosis that becomes congenital mitral regurgitation because the annulus itself dilates. The leaflets are typically thickened, but you can also have a deficiency of the posterior leaflet that leads to regurgitation. And then finally, the subvalvular restriction, which is very characteristic of congenital mitral stenosis, fibroelastic tissue, shortened chordae, and papillary muscles that are abnormally positioned. So we have to address all of these separately with our repair. So in the patient with a typical annular membrane. So this is a membrane that's located at the level of the annulus, commonly present in patients with Schoen's disease. The way that we address this is to start by removing the leaflet and annular fibrosis. But you have to be a little bit careful because once you start to debride this tissue, you might end up with an annular dilation, which can lead to mitral regurgitation. So you just have to be a little bit careful about the extent of resection of this membrane tissue. Here, the other technique that we commonly utilize is detachment of the papillary muscle from the free wall itself and splitting of the papillary muscle. Frequently, the commissure appears to be fused, but the fusion is not because the leaflets themselves are fused, but because the papillary muscles underlying that leaflet are fused together. And so trying to make an incision in the papillary muscle to open that up becomes very important. One of the common techniques that we talked about this morning was division of the secondary chordae, and frequently these are best seen when we take down the leaflet, but sometimes you can also get underneath the leaflet and pull those secondary chordal attachments and to divide those. The secondary chordal attachments do provide some structural element to the valve, so unless they appear to be thickened, you don't want to divide those secondary chordal attachments willy-nilly.
That's it. So
go ahead. Thank you. So in this situation, the posterior leaflet was tethered by shortened chordae on the posterior leaflet, even though it appears that there is prolapse of the anterior leaflet. In reality, the problem is the posterior leaflet is tethered. And so in these situations, we try to divide the, sometimes even the primary chordal attachments that cause that posterior leaflet to be tethered down. Frequently, we're always worried about dividing primary chordal attachments, but in some of the congenital MS patients, even dividing one primary cord may be sufficient to help that posterior leaflet to come up further. Now, the arcade mitral valve, so this is a situation in which the annulus is of adequate size, but all of the stenosis is at the tips of the leaflets where the tips of the leaflets are basically tethered down by the papillary muscles that are directly attaching to the leaflet edges themselves. Very shortened or non-existent, which are non-existent or shortened. Here you can see that the papillary muscle attaches almost directly to the anterior leaflet itself. And so the only way to really relieve this is to divide that attachment completely and then put an artificial cord. The rest of it seems like you are completely unsupporting the leaflet, but in reality, once you divide these thickened attachments, that leaflet comes up quite nicely, and then you can replace with artificial cords. So here we've divided some of those attachments, and now we're using a cord sizer, and we're putting artificial cords. The key for placing artificial cords for the pediatric patient is that the cord has to go to the tip of the papillary muscle. If you're placing the cord further on the base of the papillary muscle, it will become restrictive over time. But if you place that cord just to the tip of that papillary muscle, then bring it through, over time those cords will not become restrictive because the papillary muscle itself will grow. So we've done this in over 100 patients now with fairly good success. And a patient that otherwise would have to undergo some sort of supraannular mitral valve replacement, we've been able to avoid that. Another technique that is commonly utilized is leaflet augmentation, particularly helpful on the posterior leaflet. So if you have a posterior leaflet that is very deficient, then you can make an incision along the annulus of that posterior leaflet and then place a patch. Now, the one thing you have to be careful about with the posterior leaflet augmentation is you don't want to make the patch too wide or too far from left to right, because if you go around to the actual commissure itself, then you will end up with a leaflet that will become restrictive over time. So very limited incision in the posterior leaflet, dividing some of the secondary chordal attachments, and then placement of a posterior patch. Now, despite our best attempts, valve repair in neonates and children is fraught with hazard. So this is 100 patients that we performed mitral valve repair for congenital mitral stenosis. And the freedom from reintervention, as you can see here, by the time you get to 5 years, somewhere around 50% of them have a reoperation. And this is particularly problematic for patients who are neonates. Now, the other problem that these patients have is many of them will have ongoing mitral stenosis or regurgitation or develop progressive valvular disease, and then ends up with a reoperation, or actually, in worst case scenario, actually a sudden event that leads to mortality. So the keys to management of the congenital MS patients is the imaging. And the component analysis is extremely important. The technique of total cord replacement, I think, has actually really changed the way that we approach the very severe forms of congenital mitral stenosis. I just wanted to give another example of a patient with congenital MS. So here we see sort of multi-level disease. The posterior leaflet is completely tethered, and there is a gradient as well as some degree of regurgitation. So in this patient, we examined and we found that, again, there was essentially no cord on the posterior leaflet. The leaflet itself is okay in many situations. There is leaflet there. It's just being completely held down by this chordal attachment and splitting the attachments of the papillary muscle to the free wall allow more mobility of that leaflet. Well, in this situation, we were able to mobilize the papillary muscle by dividing the posterior leaflet and working through that posterior leaflet. But despite that, we still had somewhat of a gradient. So here at the tips of the leaflet, you can see that there's still some flow acceleration, and that was still a problem for us. So this time, we went back and in order to fix this problem, what we did is we took down our posterior patch and actually enlarged the annulus. And you can enlarge these annulus posteriorly if you know where the coronary artery is. In this situation, we actually were able to identify that the coronary artery was at least a centimeter away from the annulus itself. So then we can actually cut back. It gives you a heart attack to think about cutting posteriorly, but in some of these patients, the coronary artery can be quite far from the annulus. So dividing that posterior annulus, then orifice size. And then lastly, I want to just make a mention of the single papillary muscle in AV canal defect. So these patients have stenosis if you were to repair the AV canal defect by closing the cleft in the on the left-sided AV valve. And so in these patients, what we have gone to doing is a staged repair. So split the papillary muscle that contains all of the chordae on the left side, and then just put an atrial septal patch, not close the ventricular septal defect, and then put a pulmonary artery band. And then over time, what we've found is that you can actually get the mural leaflet to grow and increase in size such that at a later time you can come back and close the cleft in the left-sided AV valve and then close the ventricular septal defect completely. So a staged repair is something to think about in some of these patients who have really complex mitral valve anatomy. So I want to stop there because I want to have some discussion and then we're going to head. So I want to stop there because I want to have some discussion and then we're going to head on to the AV canal patients that I think we see commonly. So let me stop there and just open it up to discussion and see if any of the chairpersons has any comment about the repair techniques that they've used.
Yeah, that was a good presentation, and I would like to point one thing. Congenital mitral stenosis in neonates and non-neonates are two different entities altogether. Because in neonates, congenital mitral stenosis comes with baggage of a lot of other things. For example, they have a small LV, they may have aortic valve problem up to coarctation and all. So how do you assess those kind of patients where this patient will go for single ventricle repair or biventricular repair? Barring repair of the mitral valve itself, is any other modality of investigation would you like to do to find out whether you are going in biventricular, single ventricle?
Well, I think the most important thing is whether or not you can come off the prostaglandins. For a neonate, let's say you have a neonate that's born, you're worried about the left side of the heart. So obviously the echocardiogram will help you to measure the size of the left heart structures, the aortic valve, and any Z score that is greater than a minus 2.5 clearly is going to be okay. But more important is, can you assess the physiology of these patients? If you have antegrade flow in the aortic arch in the setting of prostaglandins being present, that tells you that this left side of the heart is doing enough to be able to pump against the right ventricle. So I use that as one of my major predictors of outcome, in addition to the size of the left heart. But even if you have a good left heart, if you have a mitral valve that you cannot repair, then I think you're better off with a single ventricle palliation for some time rather than trying to repair the valve or replace the valve and maintain the biventricular circulation. So my approach in these patients typically is to start by examining the mitral valve, seeing if we can achieve a good result. If you cannot achieve a good result, then I will usually go to a single ventricle management and then later come back and repair the valve. You can subsequently then convert to a biventricular repair later down the road. But I will use the combination of the echocardiogram and intraoperative inspection to make that decision.
Does MRI has any role of measurements of volumes actually in terms of LV volume and the flow across the mitral valve?
Well,
and how much gradient it is producing. For example, an unrepaired mitral valve, you have a flow of, say, for example, 1.5 ml per minute per meter square, and which is giving a gradient of mitral valve, for example, 10 or 20.
Quite effectively. for making this type of decision. But I think you have to be very careful. The imagers who are doing the MRI know how to do it. In many situations, we
replacing which valve to use or what any other
understand. But also some of it has to do with the flow grow phenomenon. That is, once you have abnormal flow profiles through a ventricle, it somehow signals the remodeling of the ventricle to be inappropriate. So I believe that in some situations, if you stimulate growth, stimulate flow through the ventricle, you can get adequate growth of that ventricle. So we don't know the answer to that, but there's some data to suggest that if in the fetus you can improve the flow through the left ventricle, that you may not develop some of the hypoplastic left heart complex type of lesions in congenital MS. In terms of the replacement options, I can actually show here. So you can see here there's a very dismal outcomes with mitral valve replacement, particularly in neonates and children. But if you look at the graph, probably the worst is a biological valve. We tend to use the Melody valve in the mitral position for the patients that we cannot repair. And mechanical valves, such as the 15 millimeter, 16 millimeter mechanical valves that are present, again, they have about a durability that is somewhere in the order of maybe 3 or 4 years. So once we get to mitral valve replacement, it obligates repeat replacements over time. So we tend to try to repair as much as we can, even if it means multiple repairs. Eventually, we can stabilize that valve over time.
The one what you mentioned about enlarging the annulus by cutting through the post annulus, what I saw just now. So how do we handle that? Do we have a somewhat of MR in those? No?
So in those patients, usually a CT scan is sufficient. Some situations, what we'll do is with cardiac catheterization, if we don't have good enough resolution on CT scan, catheterization to identify the coronary artery, and then either a balloon in the mitral valve can tell you the distance from the annulus. But usually a CT scan is sufficient. If you're doing a redo complex mitral valve repair, I'll use that. In a neonate, you can actually see the coronary artery reasonably well by echocardiogram, and you can tell how far from the ridge the coronary artery is located. So for a neonate, I tend to use that distance.
Thanks.
Thank you. Nice.
Dr. Imani, I think it was a great insight into the anatomical perspective of pediatric population in the mitral population. The question is, first thing you said about when you have an AV canal and you just split the leaflet, how much do you wait for a reoperation?
Right. So in this situation where we have a papillary muscle, single papillary muscle, it can have several different morphologies. So this particular patient has multiple heads of papillary that are coalescing together as almost just fused together. In this patient, if we divide the papillary muscle generally within 8 to 10 months, you can see the papillary muscles grow apart and the mural leaflet develop. So that is the general time frame that we have. If it is a true single papillary muscle without these multiple heads that are distinguishable, then it can take much longer, sometime in the order of years. So it depends a little bit upon the morphology of the papillary muscle. But if you see this type, where it is a sheet of papillary muscles, then it's actually more favorable. And you just have to take the time to split those papillaries and excavate them off of the wall, and then just give it some time.
So given this kind of a scenario, you have somebody with a Sohn's complex with a single papillary muscle. What would be the approach in that circumstances?
So with the Sohn's complex and congenital MS, so not the AV canal type, with the single papillary muscle, again, my approach is very similar to the congenital MS. So I will usually split the papillary muscle, but then in some situations actually divide primary chordal attachments and then put an artificial cord. To create the artificial cord, usually I'm using a 7/0 PTFE suture, and measure the distance of what you want. Generally speaking, in the patient, you have a normal cord. You find that normal cord, you measure that distance, and then that distance divided by 1.6 gives you the dilator size that you should use to tie your PTFE suture on. So take a dilator, just tie the PTFE suture around it, 9 knots, and then that is the length that you can then suture the loop onto the papillary and then bring the suture ends through the leaflet. And that usually can take
So you
care
don't fix the annulus, but in these circumstances,
Correct.
if you develop an MR, you go in again, readjust your sutures, keep doing it again and again.
Well, actually, if you attach the cords to the tip of the papillary, I haven't had to reoperate on many of my artificial cords, even in neonates. So for whatever reason, I think the papillary muscle itself elongates and grows over time. Yes.
What do you do with the ASD actually? Do you leave them, close them, adjustable ASD after repairing the mitral valve?
If I'm worried about the mitral valve, I will close it with a 2 millimeter fenestration just to allow monitoring of the atrial pressure. But if I'm able to get a satisfactory mitral valve repair, then I'll typically close the defect altogether. Thank you.
Thank
you. Maybe we should move on to, go back to the session because I think they're pretty much ready. So thank you very much. Thank you.
So we'll go back to OT4 again. MICS CABG. Dr. Piroz, we are back with you.
So can you see it here?
Yeah, you can
We
see.
have the memories down.
Okay.
The LED, you have the Jameson. So we've seen the diag. The diag seems.
Thank you, chairpersons. Yeah, thank you.
The diag seems to be a bit small. Can I have the coker, please? Coker. Can you show the diagram? Can you see the diagram?
Yes, we can. It's very fatty, right? Just show us the LAD again.
Can you see it?
We can see it. Rose, show us the. It's very fatty heart, right? Fatty heart, right? Can you show us the? Can you show us the LAD?
The LED is down here, so we will have to go in a lower space. It?
So there, I see the LAD.
No, the LED is.
Is that the diagonal we're seeing?
Yeah, that was the diagonal.
All right.
One second. Hold it. The coker, another one. Can you show him the LED? One second. Hold it now.
Okay, we see it there.
Do you see the LED?
We do.
So I'll have to go in a space lower down for doing the LED.
Talk us through that.
So I'll, through the same incision, I'll open one more interspace, the lower interspace, and then the LED will be right in front of us, which will make it much easier. The question was whether we do the diag. Yeah, I'm itching to do it, but it's not, it might be a wrong decision as well. What I would do is I'll score it and see if it's doable. Can you see the diag here? Next to my...
yeah, we can see. Yeah.
Yeah.
It's clear.
Yeah.
It's clear.
So I'll put the octopus there and see if it's doable. If it's doable, then I'll have to take another conduit because this is not going, the memory won't be sufficient. And when you leave the heart down, here it looks as if you can do a sequential. So you'll be tempted to do a sequential. But that's because we are pulling the pericardium upwards. The moment you drop the pericardium, it rotates laterally, and then you'll have a very acute angle for the LAD, the lima to come up to the LAD. So I'm not very keen to do that at all. So if we do the diag, we'll take another graph. Do you all agree?
Yeah, we agree.
Okay. So let's.
Just me ask the audience if there's any comments on this. See what my friend and colleague from London, Prakash Punjabi, is here. Prakash, what do you think about that?
11 later.
I think, thank you. I mean, I think.
Can somebody get a microphone to Professor Punjabi?
Thank you, Cliff. I think Feroz is quite expert, and doing the Lima to LAD. I mean, you know, I'm a sort of very strong believer of something that works. Do not touch trouble. Don't get into trouble until trouble troubles you. So for me, Lima to LAD would be absolutely sacrosanct. I would never compromise with any sequential or anything. I never do that. And of course, if you do need to do the diagonal, then you enter into a dilemma as to how to do that. But perhaps, I mean, I don't know. Was a little bit iffy, but I think the harvest of the mammary was good. I think that was a good length and a good flow and a good. So I think that certainly with the Lima to LAD, hopefully, will be good. And if that is a good anastomosis, then you've got more than 95% prognostic benefit to the patient. A diagonal will add a couple of percentage points, but you don't want to do harm. And so maybe you leave it there. Sometimes it's better to do that. Thanks. I don't know what everybody. Yeah, yes, sir.
I totally agree with what was said.
Shall we go back to the angio view once again? I think
we're going to go back to the angio.
Angio once, auditorium.
I think there's another question from the president.
So, would you ask it, or go ahead with the question first?
Because this diagonal, probably we have to expose it and see the size. If it is doable comfortably, we do the vein graft there. Otherwise, we just go the Lima to LAD. Yeah, because we should not compromise the conduit to bypassing the diagonal, which is, you know, doubtful to whether it's shaded, but the safety would be, even, that's a very important thing. So even if you do not graft this diagonal, it's not going to harm the patient. So probably, but if it is a larger than doing, just we can give another conduit. Probably a venous conduit would be enough for this patient.
So
I'll just put up the angio shoot.
We're gonna have a look at the angiogram. Can you hear us, Pros?
Yes, I can.
Okay, I'll tell you what we're doing. We're gonna have a look at the angiogram.
Robert.
We've had unanimous opinions that the LAD is all important. We got to get a perfect graft, but democracy is going to rule. We're going to have a look at the angiogram. We're going to take a vote in the audience. Ram's here.
Hi, Bruce. So one comment that was made by Dr. Punjabi, which I think is important, is not to compromise the Lima. If you're doing a Y graft, what are are you at all concerned? Is there an incidence of distorting or compromising your Lima to LAD by placing a Y graft off of that?
So in this situation, I don't think you'll compromise it too much because both are occluded vessels.
We were basically looking at this one, this diagonal, which is showing up a little bit. Yeah, this one. Yeah, retrograde view. I'll show that.
I'm not used to this at all. Can I have the octopus?
So they're both completely occluded, as you remember, Perose, but we're going to just take a look at the retrograde.
Actually, it might have a retrograde connection. There might really.
So, but tell me the significance and the importance of this being totally occluded. I wasn't getting around to that point for the sake of sequential. I was getting more about the
completely and drop
the angulation and the distortion and
drop the
the
lungs.
anastomosis and the side to side and the end to side.
Just release everything.
Of course, yes, maybe total occlusion makes a difference, but not so much. I think that was my point.
Look, Sanjay.
It's not that.
Yeah, this is the right one. Right injection.
Can you see the angio?
Yeah, close.
Yeah.
Hello.
Yeah,
we're
seeing
looking at the angio. It's
We are
good.
seeing the right injection. The left is getting filled up retrogradely from the PDA.
I don't know. I still
Okay, okay, Perez. We're gonna take a vote in the audience here. I want with the first. We're not going to tell you until after the vote's done. And
Suction is on, right?
so now I'm gonna.
Yeah, I just want to at least show you all the exposure, if nothing else.
No. We want to see that.
Okay.
Okay, let us see the exposure. We'll see the exposure, and then we're going to vote.
So now, if you can see, that's the
Okay,
diagram.
now hang on. We're still on the angiogram. We got to move back.
Let's go to OT4 again.
Very slowly resume it. Wait. So 15 blade do you have?
We're back with you, but we're looking at the. Yeah, we're back with you.
You're on the scope or?
No, we're not on the scope.
On the boom?
Yeah.
Boom won't be able to show you much.
Yeah,
You
let's
have
go
back to the scope.
Go to the scope.
Can I have the Dietrich, please? Fine Dietrich. We are doing anastomosis. Dietrich. तुम लोग क्या यूज करते हो bypass के लिए? Find the basis. यार ये लोग bypass किया है ना इधर? क्या है? नहीं यार.
Yeah, we got your scope now.
Come on, you'll have to help him. I don't know the terminology here. 15 baby. You have to take the blower. Do you have the blower? Lower one. Wait, lower one karo. Blower, please. Blower. Can we have the blower, please? Why are they behaving as if they've never done off pump here? I thought you're...
So we're off the scope again.
You're on the scope?
No, now we're on the scope.
Okay. Blow, please, here, properly.
Now we're off the scope.
Off?
Off now, yeah.
I don't know why they're switching it, but
Now we're back. We're on the scope.
not a small vessel that you see.
This is the diagonal
Yeah.
is exposing epicardial. Yeah.
Blow, please, with water. Can you blow me? The blower is terrible. Yeah? Can you
Blower up.
increase? So what do you think?
No, you got to expose it a little bit more, I think. What do you think? Okay, wait. Okay, I'm going to ask the audience now. In the audience, who thinks we should just do the LAD? We've got a question. Is this before the vote question?
I think I would like to suggest just a limit to LED is a golden standard. We should go for that only. It's a small caliber vessel and it's poor runoff.
Yeah, poor runoff is the key, I think.
There we go.
Very important point.
Who thinks LAD only?
Okay.
No, just wait. We're taking a vote. Who thinks a lot of people abstained from the voting?
Pardon?
We had about one-third abstentions, had about one-third LAD, and we had about one-third diagonal as well. So your decision, Perez.
Well, if you want the operation to be quickly finished, we do the LED. Otherwise, it will take. You have to get another conduit as well. I mean, the diagonal is definitely doable. That's not the problem.
Okay. We think it's doable, but
The runoff is one thing I.
Right, we're going to have a runoff. We're going to have one more vote. LAD only. Diagonal as well. No, we're still undecided, Perez. I voted LAD only, but I'm going to go and watch Dr. Moon just now. So
Okay, fine.
you decide. You do what you want to do.
Let's just do the LED then.
Yeah. Okay.
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 Yeah.
All right. I think we all agree and we all recognize that you do a nice graph, but
Heavy force, please.
we're going to be very interested to see you do this LAD.
Yeah, sure. Okay. No, release this first. Okay, now release this. Okay, so we'll be opening the lower interface, and then expose the LED and do the LED. And please fix this. It shouldn't be moving up and down. Yeah, thank God it's not a multi-vessel. You don't know at all, man. It would be a disaster. कौन? अरे जिसको मालूम है उसको रखना चाहिए ना.
I'm good. I'm good.
Put that. Hey, give me a clip, please. Clip, small clip. Short. Short भी दे दो. Another short now. Short नहीं है क्या? So they are doing things as if they've never done an Ofcom CABG ever. They'll do Ofcoms, no? It doesn't look like the way people are doing. Okay, anyways, doesn't matter. The right angle, please. Forceps, please. You can have the cautery. It's on 60, right? Yeah. Hmm? Yeah. Yeah, you should have assisted, man. You guys have no clue of. Okay. Let's go here. Can I have the retractor again, please? Oh, sorry, either you showed me the wrong one. eh? Retractor? नहीं 5 दे देंगे.
Hello?
Yes.
Hello? Sanjay,
Yes.
can you
Yes.
hear me?
Yes.
Hello?
Yes, we can hear you.
Faucet, no? Can I have the coker?
Sanjay, can you hear me?
Yeah, I can hear you.
Please present the
Let go.
case. It was
Hold it.
taken in the OT1. This
Gently.
is the fourth case.
Got it?
Okay.
Yeah, present the case.
No, don't. Okay, that's good. Let go. See, lady is right in the bank. Are we live or we are not?
Yeah,
Yeah,
you're still
we
live?
can we
Are
can
we
hear.
live?
Yes, we can hear you.
Yeah, so can you see the,
We're not on scope. We're on boom.
yeah, can you show the scope, please?
It's a little blurry, just the scope.
Can you have the cleaner? Something to.
That's better.
Can you see that?
Yes, yes, we can see.
So that's bang in, like right below my incision now.
Right.
So let's have the octopus now again. ये निकल गया सब. Why have you removed all that? We need to put the octopus again. We're just remounting the stabilizer. Yeah. निकाल दे मत जाओ, it will be finished. So normally, can we have the boom camera? So normally I don't use all this concoction, which actually is the thing which Medtronic provides, because it's just too cumbersome.
We're still on the endo. We're
Can
still
we go on the
endo.
boom, please? Are we on the boom?
No, still endo.
Can I have the bullet again, please?
Now we're on boom. Okay, now we can see you boom.
Yeah, so see, this is all a big complicated concoction which they have provided, Medtronic has provided, but normally we don't use this. Unfortunately, they don't have what we need. We just use a very simple arm which we always use to hold the mini mitral retractor, and it's very easy to use the octopus. This is very complicated and not very flexible, so to say. Anyway, but we'll make do with that. So can we move now onto the scope again, please? Faucet, debate. Are we on the boom now? Are we on the
Endo.
scope?
Endo. We're on the scope.
Yeah. So this is you see this black thread. This is the octopus which has been pushed in, and this is the bullet which helps to push it in. So once it's pushed in, we release the screw at the back and just push it in, and we remove this.
I see.
Once this is removed, then we clip on the actual pods onto it. Okay, one second. Yeah, okay. Right. So after you've clipped it on, you give it the position you want it to have. Don't. First suction on. Suction's on.
Now,
Okay, fix. Yeah, now fix it. and then you put the suction on, and then you tighten the whole thing so that it's fixed.
Okay, done.
Okay, yeah.
How easy is it to manipulate that, to
Pardon?
get how easy is it to manipulate the octopus to get it into the right position typically? Fairly easy with that?
Basically, matter of practice. Initially, you will feel, don't always hold this. Initially, you will find it a bit difficult, but once you get used to it, then it's reasonably easy. Can I have the blower, please? We need a. You have a two shunt? Two or a 1.75, don't know later. Forwards, please. So it's a nice vessel here. Okay, that's good. Now let's get the mammary. Okay, can I have not rubber shot, just mosquitoes, please. I don't like rubber shots for this. Mosquito, please. And can I have you have a Jameson? You know what a Jameson is? Okay, forget. You don't have a Jameson? What do you use for a mammary? Pots you have? Big one? Yeah, please give me a big pot. Then give me the fine Castro. Okay, is the shunt ready? So always take sort of space sutures on either side of the mammary so that it's held in place. Can I have a mosquito, please? Another one. No, that good. Okay. Okay. 11 blade. After opening, I'll take the forwards, these forwards again. The yeah. Okay. And then the shunt. Low, please. Let go of your faucet. The blower is terrible. Just don't just blow, please. Blow on this side, please. You can have the shunt. Only one, yeah, 1.75 faucet.
Peros. Hi,
So
Perez.
we usually put a shunt in. Now in this situation, because the vessel is occluded, there's no point in putting a controlling stitch proximally. And I don't like to put a,
That was exactly my question.
and I don't like to put one distally because of obvious reasons.
Not even if it is a silicone sling kind of thing.
Pardon?
Even if it is a silicone sling, you don't like to use either of
No,
those?
I don't like. We usually use cell savers, so.
Ah.
And you don't lose that much, like you use about 50 cc maybe.
What does everybody do here? But without a sling, you don't occlude proximal and distal.
Okay.
So you're still, your assistant may be using some occlusion.
Just for momentary occlusion. That's very momentary, like just for.
Vascular bulldog. A lot of people have many ingenious ways of trying to put on either side. Stays, vascular bulldogs, clip, forceps, something to reduce the flow. But
See, all that
here,
is not, I mean, that's all possible easily when you're doing it through a sternotomy. It's not that easy when you do it. The best way, obviously, to do it is to put a sling around it. So if it's not an occluded vessel, I would put it proximally, but I don't like to put it distally anyway.
Yeah, I don't like to use them. I don't use them.
Pardon?
Yeah, I agree. It's Cliff. Yeah, I agree with you, Perez. I don't like them, but I know others differ.
It's not, I think, worth the blood you save.
Well, if things go wrong, it certainly is not, which I've seen.
Just show everything.
and Cliff, do you have an idea where exactly on the LED, which part of the LED this is? How proximal,
It would
middle?
be mid to distal.
Mid to
So like
distal.
just about, yeah.
And is there a view upon that? How, I mean, in this case, it was much proximally occluded. Whether
Yeah,
the retrograde
much
filling was
proximal.
going, if you
Retrograde
see,
filling all the way till the proximal
all
aspect.
the way
yeah.
till the top.
The
So
proximal CTO.
when you get a picture like this, I don't mean minimal invasive or sternotomy, but if you leave that aside, you would probably go as proximal to get as much septal as possible. But here is the balance of practicality versus idealism, and you try and do what it is. Is that correct?
Even if you put in the mid segment of the LED, it will still perfuse the proximal part of the LED till the occlusion, all the septal and everything.
But I think the ideal concept is to put it as distally as possible, because then you have the proximal protection. Like whenever, if there is a plaque proximally coming in, then you have the distal flow.
Yeah.
So did you mean as proximally or
No,
as
distally, yeah.
near
Since-
the apex?
Yeah.
No, I don't think so, because the size will be small. Wherever you get a good size, you put
No,
it in.
like based on the lima size, if the lima is good, then you put it as distally as
if
possible.
you
I
are
don't think
putting
you would-
lima distally, that means you are using the distal segment of lima, which is not very great. You should use a bigger size of the lima wherever it comes to.
I don't think you should go very distally, but
Should not
mid
go.
to distal, mid to
Mid is
distal
the
at the
best
most is okay.
Well, I think this is David Taggart's argument, isn't it? Again,
Yeah,
that one we should
greater protection you have
to go
from proximal
the
plaques.
argument against stenting is that there's this
The difference between
disease that
stenting and grafting.
develops just afterwards. So in this case, absolutely. I mean, you can do it. As I see it, the vessel is one of these acute occlusions, and the vessel looks very good beyond it. So I would essentially graft this one here where I could see it.
Yes.
And if you had
Yes,
any issue with length or with the obesity of
Yeah.
the patient, but I'd really not use a very distal, smallish lemur to go distally here. But it's a different disease process if you've got coronary irregularities and then you go distally. But I can remember from years ago when I was at Stanford, then Bruce Wright, who's now retired, used to do his coronary grafts. He used to do all the grafts other than the LAD, he used to do the distal first, because he said the distal runoff was most important. when he did the LAD, he always did the proximal first because he said the proximal side was most important to get back to the big septal. Where would you graft? Where do you normally, Prakash?
My principle, to be frank, is as proximal as possible, at the not the shortest straight length, but still a loose, lazy S, but as proximal to get the biggest flow size mammary, just after the disease, biggest flow. I agree with the concept that you can have retrograde flow,
Are you showing both ends?
but a retrograde to a blocked artery
Yes, sir. Yes.
with the septal, I have my doubts.
I think I agree. What do you do? I was just while we watch Perot do this very nice anastomosis. What do you do when you've got two stenoses in you've got a tight proximal stenosis and then say a moderate midsection stenosis? What's your strategy? Then do you graft twice?
No, I mean, you have many scenarios, but Punjabi law really states that you go through the lesion for the second one, proximal and distal, through the lesion, and you supply both. But I sometimes it's not practical, sometimes it's not possible. Then I will do only the distal. I'll sacrifice the middle part to do the distal, but I don't like to do two grafts because I find. Anyway, there's not much experience. We don't.
You got two grafted. Do you do?
I will try to cut through the plug and get away on the both sides.
So if you got a long stenosis or sometimes two stenoses, what's you're a two grafter or you just graft distally?
If the mid segment is tight enough, then I will same mammary. I'll graft proximally as well as distally. Just a kind of jump. Yeah, because the proximal septals will be supplied. And the distal will be also supplied. That's easy to do it.
If the LAD is
yes, Dr. Parikh.
in this where there's a totally occluded LAD and filling retrograde collaterals, and it's a long LAD, probably we are seeing till mid and distal LAD. So if the lesion is there in the distal LAD or in the mid LAD, and there is a good proximal segment, we can do it a skip. Suppose if there is no lesion in between, wherever it is epicardially placed and where we can comfortably do it, we'll do it. Because it's always better to do the anastomosis as proximal as possible and at the same time without getting into difficulties like dissecting it to intramyocardial.
Of course. Yeah.
That's the only perspective.
So we got two lots of evidence, right? We got evidence that providing reperfusion to the first septal has a prognostic benefit. And we've got evidence that incomplete revascularization has a negative prognostic benefit. So the argument that we don't really have is where you're at with these intralesional LADs. But generally speaking, I buy the philosophy of David Taggart and others that what is most important is to get a good Lima graft. And we've said that previously, and Prakash, you said that previously. You got a good Lima graft. But if you've got a good long vessel and a good sized distal LAD, then as distal as possible.
Put it
that's the one place we beat stents, right?
Yeah, that's the difference. There's the whole difference between stenting and CABG.
Right.
You have long proximal protection.
Correct.
Can we just take you away for the brief case summary of the aorta repair which is getting ready in OT1?
Feroz, we're leaving you for a little bit.
Yeah, sure.
Just a couple of minutes.
Yeah.
So we have this 73-year-old lady who came to us. Who came to us with the presenting complaint of shortness of breath of NYHA class 2 and class 3 for 1 month. She's a known case of systemic hypertension on medication. On echocardiogram, transthoracic echocardiogram, there is severe aortic regurgitation. The aortic root, at the level of root, it's not dilated as such. However, on echo itself, we could make out that ascending aorta is dilated. Normal lifted morphology, ejection fraction of 50%. On ECG, there is normal sinus rhythm, no STD changes. On CT aortogram, there is aortic ectasia, normal morphology of the leaflets. Aortic annulus was 26, sinotubular junction was 43 mm. Proximal ascending aorta is 50 millimeter, and normal epicardial coronaries. We'll just have a short run of the CT loop.
Okay.
Is it okay, the microphone? Okay, perfect. Okay, I think it's good. Yeah, that's good. What's that? Oh, okay. Are they, okay. We're just waiting for that. Oh.
So just the CT loop is running here. Arch vessels. Innominate is slightly larger. This is the DTA, part of the DTA arch. This is the level of ascending aorta, which is dilated to the tune of 50 millimeter. And at the level of sinotubular junction, it is 43 millimeter. And aortic annulus is good to go. Yeah.
I think we measured it just the distal at just less at about 43
millimeter.
as well.
Yeah, 43 millimeter.
It comes down again.
Yeah, 43 millimeter.
So we're hoping to avoid.
Yeah. So on echo, we had a second look at the echo again, so which actually reiterated the findings of CT aortogram and said that aortic annulus is 26 mm only. So we'll just have a look at the OT findings to actually see whether we need to do a subannular constriction or not in this case. But anyway, ascending aorta is dilated, so we have to do a ascending aorta replacement, or probably a remodeling at the level of STJ to get the leaflets right. Over to Dr. Mark, OT1. Yeah, get back to OT1.
Yeah. Are you there?
Yeah.
Yeah, we're here, Mark. We're with you.
Yeah. Are they there?
We're here. Can you hear
We're
us?
just waiting for the ACT. We underdosed the heparin, I guess, a little bit. So it might be a couple minutes. We've made some measurements in the arch. It really measures out at about 32 at the before the innominate. So I don't think we're going to plan on doing a arch procedure. It's also very heavily calcified in zone 2. So we think that might be troublesome to do. We were able to cannulate in a soft spot right across from the carotid, kind of a zone 1.5. And then we've got a root vent in that's about ready to give our antegrade. There's central regurgitation that's moderate. It looks like one of the leaflets, the non-coronary leaflet, has some thickening centrally, maybe a rheumatic type picture. I'm not sure we're going to be able to do anything to that leaflet. Application won't help. It's not excessive leaflet with prolapse. It's foreshortened. Duran years ago described a unraveling procedure that maybe we'll take a look at and see if we could do that. But I think mainly we're going to try to decrease the sinotubular junction to increase coaptation of the leaflets and ideally shoot for a mild central regurgitation at the end of the procedure. I don't think we're going to get to no regurgitation without replacing it, but it's not significant enough that we need to replace it.
What do you measure it at about 5 centimeters? The
aorta
50?
itself?
Yeah.
Hey, Dr. Castro, can you measure the aorta? What you think the big part? It looks very abnormal, very saccular.
Biggest area?
I looked at it and thought it was yeah, it's a little over 5, which is pretty good size for this lady. She's not very big. What's her BSA, guys?
Yeah, can you both comment, please, Dr. Moon and Dr. Katsu? Just let us know your thoughts about absolute measurements versus sort of one that's adjusted to the patient to BSA.
Oh, I see.
BSA.
Would you replace with BSA? Well, it depends. I think for, certainly look at aortic size index. You know, the guidelines usually say to, you have a patient outside of the norm, we don't really know what the aortic size index is. So if they're extremely tall or large or extremely short, really doesn't fit into them. But for the general whole, you can size it to BSA. Obviously, you know, the US guidelines sort of change where now we're looking at ascending aortas or aortic roots at 5 centimeters rather than the 5.5. And that data is really as a result of looking back at retrospective reviews in the IRAD database that patients are starting to dissect. About 54% of patients have aortic dissections when the aorta is under 5.5 centimeters. So I think we have to be cautious. I think we have to look at every patient as an individual, and obviously the 75-year-old who had a stable aorta at 5 centimeters for 10 years may not be the person who rushed to surgery. So even if their aortic size index is in the higher range, I'm not sure who's done to replace unless they have like valvular dysfunction or things like that.
And do you adjust as well for bicuspid valve or not?
Bicuspid.
Bicuspid, I mean, it's really the risk of dissection in population for bicuspid is less than 1%. So if the risk of your surgery is higher than that, I think you have to really think about it. So
No, I'm talking about aortic size. So
5 centimeters.
So you're just 5 as opposed to 4.5 for bicuspid.
Yeah, I'm usually more on the conservative side, 5.
Yeah, I am too. What are your thoughts on that, Ram?
Yeah, I mean, I think, you know, some of it also has to do with the
You okay?
quality of the tissue that you're looking at when you get in
You
there.
guys okay at 350?
And
okay, let's go on.
yeah, and you know, some bicuspids, I think, you know, with really thinned out tissue, I worry about further
Can you get to
dilation.
the vent or
Look
we
at the
need to clamp?
rapidity of.
So we're watching you, Mark, but we kind of agree with you with regards to the size criteria.
Yeah, she's small. She's 1.5 BSA. The 5 centimeter, it looks very abnormal. She's got heavy calcification in the arch. It's thinned out in the ascending, although it tapers nicely to the nominate artery. So that's why we're not going to do circ arrest. That and also the technical issues with calcification in the arch, especially since it's not dilated. I'm just standing here. These guys are putting in an 11 ventricular vent. Then we're going to cross clamp. We're going to arrest the antegrade. We don't think the regurgitation is significant enough that that's going to be a problem. I guess that'll show us how bad it is. If we can arrest with antegrade cardioplegia without the LV dilating up excessively, I think we're okay. Just trying to get it to be mild or improving it and leaving it as is. We don't want to do a valve replacement unnecessarily.
Oh, you don't have much time now.
And you're going to use Del Nido for this?
I think we're using custodial again was the vote. No, Del Nido? Huh? What's guys, what cardioplegia do you have? Custodial or Del? Okay, yeah, we're using Del Nido. I was outvoted.
Well, at last night's dinner, you said Del Nido for this one.
Yeah, that's definitely in the ventricle. Here, let's put it under this, over there.
It's not in. Hold on. Okay, go ahead, come down. Yeah, thank you. Can I have a?
Yep, down, yep. Do you have a tie? Tie? We're gonna have yellow on the root vent. Is that okay? I mean the LV vent? Yellow? Yellow is on? Vent.
It's the vented.
DeBakey? Forceps? Do you call them DeBakeys here? Okay.
It's okay for now.
You call them magics, right?
I used
Mark?
to, but nobody knew what I was talking about. So, well, now I work at the place where DeBakey invented them, so I gotta call them DeBakeys.
So for the audience at Stanford, where Dr. Moon and I were together, the Shumway, Professor Shumway didn't like Dr. DeBakey.
Just show me that.
The entire field is rotated 90 degree right now.
One sec, I can't.
Uh,
No. Now you can see the
yeah,
whole thing.
now we can see. Now we can see nice and fine.
Does it fix it?
I don't know.
That's all the way. Okay.
Did you fix the lung, Dr. Piros?
No, so what we do is now we'll just do hemostasis, check everything. And finally, before you take the lung up, once again, have the suction, please. That's very important. When you take the lung up, I'll just show you. You keep the suction here. You can see?
Yeah.
You keep it next to the mammary, and then you ask the anesthetist to blow the left lung so that the lung actually goes over your suction and not on the mammary, because it can push the mammary this medially and can rip it off. So you have to be very careful when the lung is blown up again at the end of the surgery. That's the last thing you do, and then close the thoracotomy.
You mean to say the medial edge of the lung should not go beyond between the epicardium and the mammary?
No, it should not like go beneath the,
Yeah.
and push the mammary.
Push the mammary
anteriorly.
away anterior.
Yeah, because it can rip it off.
Yeah, yeah.
So you have to protect the mammary when you're
right
blowing up the lung again. And I guess that's about it from our OR. I mean, we'll close some of the pericardium now, and I usually prepare the pericardial fat layer and then just cover the mammary with the pericardial fat.
Okay.
So that that's protected from the lung as well.
That's another great job, Perose.
Well, we wish we could have shown 2 or 3 bypasses, but anyways.
We knew you were itching to do it.
Yeah, that's fine.
No, you've done a beautiful graft there with a lovely flow. That's perfect.
Yeah.
And
it will be good for
did
him.
what Taggart wants us to do, graft distally.
We had one patient who had come back for an AVR. He underwent a mid-cab in 1997.
I think so. There's
And he
nothing to see
underwent
right
an
now.
AVR in 2020.
Yeah.
2020, I think,
Stop.
or 2021. And his Lima LED, you couldn't even identify where the anastomosis was. It was as if the mammary is a single graft right up to the apex of the heart.
Don't sell it to us. You got to sell it to the cardiologist, Perose.
Yeah, they are pretty much convinced. To be honest, the cardiologists really believe in the Lima, but if you're going to open the sternum, they will not send it to you. If as long as you're not opening the sternum, they'll flood you with cases. Believe me, because that was what I was told when I moved to Toronto, that you will not get a single vessel ever. And we've done almost close to 100 now in 2 years.
We'll go back to OT1 now.
Perose, we're leaving you, but thank you. That's a great job.
No problem. We see you later. Okay, so now, yeah.
I need a
Left hand.
no. I need a right hand. That is a left. Yep. Yeah, I'll take the 7.5.
That's a right. That's a right.
That's right. Okay. That doesn't look like a right. That is not a.
Pooja and Mark, we're back with you guys here. So it looks like you've.
No, don't let go. No. Help me pull that. Yeah, thank you. Yeah, this is the wrong glove. That's a glove.
I know, but it's not.
It's okay. I got it. It's fine. I'm wearing a left glove on my right hand, so might look a bit inside out. Okay, perfect. Okay, 2 forceps. Are you guys there?
Hi, Mark. Hi, Pooja. We're back.
Okay. We had an incident where I ran out of right gloves, so I'm wearing a left glove on my right hand. So we're gonna have to move fast. My hands are getting squished.
Left.
Okay. We can look here. Can you guys see in here? Pretty good?
The angle's a little bit off, but yeah, that's better.
What are we looking? Oh, there's the camera coming in. Okay. Good. You got to get on the 30-degree.
Yeah, that's
That's a little close. Yeah. Okay, you can see the leaflets there, right? Really nice.
Yeah, we can see it.
There's probably a little foreshortening of this leaflet a little bit. But why don't you take a forcep and go there?
Another perfect.
And they're all pretty even. There's a little, not really prolapsed. The nodules in the center. We just have a little malcoaptation in the centrally. I think if we pull the sinotubular junction together and up, we're gonna have a good result. Do you want to do any suspension of these or not really? No, I think we just take the bites right above it.
Can trim the graft just a little bit here and here.
Okay. We're gonna trim the aorta a little shorter.
Pick up another pair. Pick up, yeah.
Mark, does your non-coronary cusp seem to have a shorter free edge length than the other two?
Have a shorter free edge?
Yeah. Does it
Yes,
look like?
I think it does. But I'm not sure in order, we'd have to shorten the free edge of the other two. And because you can see that this non kind of prolapses down a little bit. Not really prolapse, but it's foreshortened, I think. I don't know. What do you think?
Yeah, no, I agree. I think in this situation, sometimes you have to, when you put that ascending graft on, sometimes putting it back on a little bit asymmetrically so that your non-coronary isn't taking up the same circumference helps avoid, sort of matches the asymmetry of your leaflets.
Should we take some of the non-coronary out? Is that what you're suggesting?
Well, no, just when you're putting the graft on
Yeah.
to not place it so
tangled up.
symmetrically, but to you can sort of place the coronary the commissures in the same proportion that the leaflets seem to be located.
Yeah, that makes good sense. Yeah. So we'll take that down. We'll take it a little lower than on the non.
Chris, you want to comment?
I don't think that's all.
Chris, you want to comment on that?
Yeah, I
But
think
you're
that's-
going right
Here,
down
we're
now,
tangled up in
right down underneath the valve, right?
I can't have this tangled up.
Yes.
Okay, that's good. That's perfect. All right.
Mark, what are
do
you
think?
working on now? Pooja, what are you working on now?
We're just trying to figure out how to, how much of the cusps to take out. I mean, how much of the sinus to take out. The right coronary sinus is a little thinned, but remember the root sinus itself and the root annulus was not dilated. So
Probably placate this leaflet once you put the graft in.
we're gonna put the graft in and then we'll assess if we can placate. It looks like this this left coronary cusp leaflet is probably longer than the others. What do you think?
Here, I'll hold that.
Well, can you guys see that leaflet? That
Chris, what are your
Dr.
thoughts
Katz
there?
is grabbing right there? Hez?
You guys see it?
Yeah, how do you distinguish between geometric height and effective height, Mark? What do you think about the effective height for all those? I think Ram is right. One of them is a little bit
Yeah.
lower.
28. Can we have
the
a
others.
28 graft?
28 graph.
Yeah, I think these ones are good, and then this one's relative. So
Yeah, I think you're right. We could,
The 7-0 shoulder.
yeah.
See it? So little. Prolapse. So we can like push this one down like this. You could do it up front right now.
Yeah, okay.
Yeah.
Can we get a 6-0 proline? 6-0 proline. Guys, we think we're gonna
Okay. Listen.
placate this left a little bit. So outside in, inside out. Then we'll tie it with it going outside.
Just from here to here.
Yeah, get rid of the thing.
6-0.
6-0?
To me.
Mark, I heard you ask Pooja about the subcommissural annuloplasty a la Christian Cabral.
That doesn't ever seem to really work, do you think? We don't need, we don't.
Cut it, cut it.
Cut it.
Yeah. I'll squirt my hand quite a bit. I have no idea how to.
Okay. Wait.
I know. I'll
Okay.
wait till you have it.
Good. Oh, tighter. Okay, you got it, yeah.
The camera just so tiny bit back is right now.
I'll just tie it from this angle.
That looks like a central free margin plication of the left coronary cusp.
So, you got it? Here.
Yeah.
Yeah, that's good, thank you.
There you go.
Yeah, we did a central plication of the left. It looked to be bigger than the others.
Another pair pickup. So these, yeah, it looks like right length in the center. Just the center of that, the center.
We think we have equal length now in the three. You got a ruler? We could, ruler? You want to stretch them?
Yeah.
Yeah, it's 2.3. 2.4, yeah. I can't measure it like that.
Okay, so you hold that side, I can walk.
Oh, yeah, 2.3. So I think we got even height. So what we're gonna do is, put the sinus-tubular junction together and reevaluate. What are you gonna? We're gonna trim it down a little bit. We want the anastomosis to be right at the sinus-tubular junction, so we can, taper that in. Okay, right there.
You're gonna do it 120, 120?
Is it possible, you guys, to turn the volume up so we can hear them a little more? Hear them a little more? Is that the volume louder? Louder? Okay. Okay, we are good. Beautiful.
Are they giving you a HemoShield or a Vascutech there?
RBC.
I think it's, I don't know, HemoShield or something. Yeah. You want 4 or 5? 4?
RB, that small needle? Yeah, the small needle.
17, yeah, 417. What is 417 now? 417 and
40 RB.
Can they see this from here now?
We could see it.
So, yeah, hold on.
Can we? Oh, okay. That's not the needle we want. We want the RB. We want the RB needle. RB. RB, you had it already.
The one I showed you, remember the first?
Yes,
one?
yes, we got it.
Yes.
Yes.
Well, we did a cut for.
We did a cusp repair right here, and it looks like a nice sinus-tubular junction. This looks, is this a 28? It really looks big.
No, double.
Double it. Well, we can't open 2. Wait till I get this organized. Have a snap, please. Hemostat? No, 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 let go. I need a shot. Okay, go ahead. I need a hemostat out. Out. Hemostat, please. Can we get that camera back on? Hemostat, clamp, clamp. Kelly, clamp.
Roberts.
Yeah. No, 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 no. I need a hemostat. That. Okay. Whatever, that's good. Okay, perfect, thank you. Hold on a second, I'm gonna need more. I mean, stop, you need more. This is short. Okay.
I know, of course, that's, different. Okay, thank you.
That's good.
Mark, can you ask him what graph that is? I don't recognize that.
I don't
graph.
either. Can we see the package, the box? The box, the graph? Yeah, yeah. The outside box. Yeah. Yeah. Do we? Yeah, yeah. Yeah. Yeah, that's, oh, yeah. It's an oscillate brawn. Let's see that. Oscillate. There you go.
You say Braun? That's a Braun graph from
It
Germany.
says Braun sharing experience oscillate. AES oscillate. AESCULAP. And it is Unigraph KDV 28 millimeter. I don't know what it is. Here, what? Stop. No, this should not. Where? Why? Why do we have an eye? Well,
Nerve hook. Nerve hook, please.
nerve. Oh, good. Okay. Okay, good.
Pooja, how's that handle? That looks like a nice graft.
How does it work?
Handle. How's it?
Very malleable, yeah.
So far,
It's not as stiff as that gel weave, We'll see how hemostatic it is.
have nerve hook, please. Nerve hook. Okay.
Hey, Mark, you're doing the approximate.
Well, because we want to be able to look in the graft and assess the leaflets after we've done the sinotubular junction portion. Now, obviously, we use two grafts like you did this morning. We could obviously accomplish that, but we're going to try to just use one graft and do two anastomoses with that. If we were doing a circurest, we'd do the distal first, and then come back to the proximal and use two grafts like you did. Just mainly out of ease. Yeah. Let me pull them up. Yeah, that, yeah.
Mark, do you ever use a technique of infusing cardioplegia into the graft before doing the distal and seeing what the root pressure looks like to get a sense of the valve?
That sounds like fun. We'll do that. That's a good idea. That will allow us to test our leaflet repair. Oh, hold on, stop. This is all tangled and I don't like that. Okay.
Ram, what technique do you use to test
Yeah.
your valve in vivo?
Yeah, so we actually have used a little scope that you can put into the graft. So put a Schmidt on two sides of the graft and put a little scope inside, and you can infuse a clear saline. Look actually at the coaptation through the graft. So that's kind of a technique that you can use. You have to if you use clear cardioplegia, the donito obviously has blood in it, so you can't see through it. So if you're going to do that, you have to use blood-free cardioplegia.
This is fun, guys. Good job today. This is fun.
How about you, Chris? What would you do to assess your valve, if anything, before coming off?
I've tried all of them, like every single one of them. I pressurized the root with a clamp and put like a vein, just given cardioplegia. I like to see it stiffen up. Otherwise, it's just visual before we unclamp. You could take 3 forceps and push down all 3 bellies and see how they coapt. You could pull all 3 commissures up and see they coapt. You turn the LV vent on, and if you see it suck down, that's also a nice one. But I think by far the most effective one, I think I said it earlier, is to use Hans H.J. Schaefer's calipers.
That's the one that looks like a little curved
Right.
belly and has the screw on the top that sort of tells you your coaptation height.
Absolutely correct. Yeah, I think that's a great way to make sure you don't have prolapse, and you can measure the effective height. And I think it's a great one for someone beginning to do this, because you haven't calibrated your eyeballs yet.
You have one more shot.
After a while, you really don't need them
yeah,
anymore,
thank
because
you,
you sort of
perfect.
just know what height they're supposed to be. But when you're just beginning to do this case, it's tough to say that you don't have trained eyeballs.
And how are you using that?
Well,
So
let's
would
put
you
that
measure
root
the
vent back in, I
geometric
guess.
height? You were talking about measuring both the geometric and effective height for each
Yeah,
of the
but we'll do it
leaflets.
distal to where we're gonna use
So
it.
do you actually measure the geometric height and then put the
Yeah.
calipers in to measure the effective
Oh,
height?
yeah.
And
Yeah,
what
always.
numbers are you looking for?
For geometric height, I want a geometric height
Well, we
greater
gotta
than
use the root
18
vent. They don't have-
millimeters.
They had their.
I think some people go down to 17 millimeters.
That's with 14 inch.
Most patients will have like a 20 millimeter geometric height, which is a luxury for us. 18, then I'm really thinking about retraction and not doing a valve repair. We'd have to do something that you guys do all the time with a cusp extension.
Little extensions. Yeah. If you're going to do an extension, probably better nowadays, we're more likely to do it in the belly rather than the leaflet edge. Because the leaflet edge extensions tend to fail quite quickly. So leaving a coaptation zone of leaflet and putting a little extension in the belly is a little bit more durable, at least in our hands. Looks like you have a pretty good match there, Pooja.
I had to make up a little bit on the anterior side. Move along on the aorta.
We were talking about testing,
Yeah, we're gonna test.
Pooja and Mark. What are your thoughts? How do you test?
We're gonna put a cardioplegia at the end of the cap.
We weren't
Okay.
gonna test until you guys suggested it, so now we're gonna do it. Huh? Center? I think it looks pretty good.
The thing is, it wasn't leaking much beforehand, so we hope it's not leaking now, Mark.
Well, yeah, I've had that phenomenon before. Okay,
Want to cut the graft a little bit?
yeah. Matt?
So we
I don't
went in
think
the
so.
other room where we had great flow in Perosa's Lima LAD case, and Chris had a very nice result from his
Can we have a 4-0
repair.
rolling?
Then we can clamp it. Where's that
Yeah.
cardioplegia?
Here. Let's get a 4-0 in here. Can we have a 4-0, please? Well, wait, no, this is not it. Stop. That's not the cardioplegia. That's a section.
The cardioplegia line, the one we use to give.
Cardioplegia.
We're gonna have you run cardioplegia to the root. Okay. Okay, so Just clamp your own
This,
bed.
this won't work. Oh, we need a handheld catheter. Yeah, that. No, not that, not that. The one we had before would, like, osteo. There we go.
So
Good, very good.
what interval you are going to give delnido cardioplegia?
Yes, we gave Delnita.
We're just gonna give some to test the valve.
Oh, this is for testing the valve. Okay.
Yeah.
So in general, when do you repeat your second dose?
45 minutes usually is what we're routinely. Okay, how about saline?
This is
Bulk
a
saline?
fun question because Ram is with Pedro
Clamp,
Delnito.
clamp.
So
Clamp
Mark does
yellow.
45 minutes.
Clamp yellow.
We give 90 minutes.
You do
Don't
90
clamp it
minutes.
yet.
90
Stop.
minutes.
I do
this is
60
not running.
minutes.
I don't want that there yet.
Niraj with me
The
today
binky.
says he goes to 90 minutes.
I can't.
And Ram, what's the right answer? for
presume
that?
90 is
Are you flowing? What? How much?
250.
What pressure? Pressure? Okay, guys, can you hear us?
Yeah, we've been watching you, Mark. We didn't want to ask you questions while
Okay.
you're working with a brand new team, but that looks pretty good.
Yeah, we've got, we have no LV dilation. We've got, they're flowing 250 a minute at a did you measure pressure or pressure? 140. So that's good.
Well, that's good.
I think we're gonna be okay with that.
That looks good.
Even if we got a low rigor, it's just not clinically gonna be significant. Okay, off on cardioplegia? Okay, here, you wanna take that?
No.
Thank you. Mets. Okay, so we're done with the proximal. We're gonna,
Yellow back on, please.
Yellow back on.
okay, so.
Talk us through this measuring, because this is something that
Well, some people say that if you're working with a resident, huh? We'll be able to cut it shorter. I think it's gonna be perfect.
Oh, it's long on the back.
If you don't cut it, if the resident doesn't say it's too short, then it's too long. Because it generally ends up being shorter than anyone would think it would be, because you don't want it to kink or bend. So this length is gonna be good. Wait a second, should we cut this back a bit?
you don't fill the heart up, you don't fill the RV and then measure it. You just. But you're right, except every now and then you get a resident who's want to do standard deviations outside the bell curve, so you got to factor that in.
Positive or negative? Okay.
That happens both ways. That's the way the bell curve works.
Okay, Shad? Yeah, good, thank you. Yeah, you got it right there.
Mark, now you're stitching again. If everything's good, there was a question while you were busy about interval that you use for.
What's that?
You're not using Delnito, is that right for this case, or you moved back to Delnito?
We use Delnito, and nobody really knows what to do, right? But we generally repeat a dose at 45 minutes, if need be. If it's going to be, if we get to 45 minutes and it's just going to be another 5 or so, we won't give it 5 or 10. We're not going to give another dose. Just so our heart will beat pretty rapidly. That's the beauty of it, is the heart just starts beating right away.
So we got Ram here who works with Delnito, so we better just check that that's right.
Well, yeah, Ram, Delnito always said, well, the issue is you got to keep the heart cold though too.
Yeah. No, I was just mentioning earlier that our criteria are a little bit different for kids versus adults. In kids, we'll go up to 120 minutes with a single dose. But in an adult patient, potential coronary disease, we're doing it every 60 minutes.
Yeah, and I guess it depends if it's a normal ventricle or not.
Yeah, exactly. Trying, so it is a judgment call. It's not a black or white. I noticed that you took some more of that distal aorta. You trying to get as close to the clamp as possible, or what was your thought process there on the distal aorta?
Yeah, it's not absolutely normal. Like we talked about, it's her arch is just heavily calcified distally, but we didn't want to circle rest because of that, but we wanted to get as close as we can up to that arch. We cannulated in zone 2. We found a soft area just anterior wall, but the whole posterior wall was calcified. So we cut it up. We're just trying to get close. I always use felt, but Dr. Katru doesn't. Huh?
You want to bring it down?
Well, go inside out then. Nerve hook, please.
You use felt on the outside, on the aortic side, Mark?
Pretty routinely, but this looks pretty good. I mean, we have to be careful though. We can't. If you have someone who's not putting the sutures in on the curve of the needle, like a junior resident, you would let do a few bites. You're gonna want that felt on there, or a new resident. That's good. Okay, let's reshod that. And then I gotta pull towards you. I like to cinch them up one at a time. That's why I like to do one at a time, because if you do more than one at a time in an abnormal aorta, it'll tear. Marfan patient, whatnot. Or this lady's aorta is not normal either, that's for sure. Okay, good. Well, no, there's a lot of aorta around there, I think. Yeah, let me just follow the area. Okay. Nerve hook, I don't like the way that's set. Let me fix it. Okay. I always follow from the inside here to keep the tension off of the pull onto the aorta.
Mark, what is it like working with your former resident who's now a full-fledged attending?
She works too fast. She sutures too fast for me. I can't keep up. So I've had to tell her to slow down a few times. Not that she's doing it incorrectly, but I lose focus.
So Perot's had a great result with his graft, and Chris with his valve sparing route. So we got 3 out of 3.
Hopefully we make 4 out of 4. We're in the home stretch here.
We're in the home stretch, but it's got to be 4 out of 4. It's the result that counts.
This would be the grand slam, Mark.
Yeah. Well, what this lady needed was this abnormal aorta to be gone, because you say, oh, it's 5 centimeters, she can wait. Well, this is exactly the patient that comes in with a dissection, acute dissection, and boy, then it's a real mess. She'll tolerate this surgery just fine. Okay.
So I agree with you. I think a woman with a body surface area of 1.5 and a 5 centimeter aorta has got to be treated.
There we go. Beautiful. We're just eliminating any shod. Good. Okay. Let's switch that. Great. Excellent. And there's more graft here than you think. It's kind of folded under.
So Mark, I'm not a Teflon person. I stitch exactly the same way.
Yeah,
but at the same time, my videos, if I go a bit slow, I can just speed it up a bit. Then I look like Pooja, and then that also looks great. But I'm not just you're not a Teflon person, neither of you, which is a good thing. But I'm just wondering, or do you change depending on the aorta?
Yeah, I usually use Teflon, but Dr. Do you ever, Dr. Ketchu?
Yeah, dissections.
Dissections.
For sure.
Some people do dissections without. I think I've had Dr. Malaisri say that.
Chris?
Yeah, I'm not allowed to use pledgets or Teflon.
So I do. I do
Mark,
it.
Mark, did Craig Miller tell you never to use pledgets and Teflon?
No, when I used to suture, he said we better use pledgets. But then once I left, he realized maybe it was me. But no, we actually will always use felts. And I did a couple articles with him. We did an internal felt, a medial felt, and an external felt. We just did push so much felt, it was crazy. But he definitely changed over the years. And it didn't take very long because you were only there a couple of years. Let me do some more. A couple of years after me. Can you guys clamp the yellow? Clamp the yellow? Clamp yellow? Clamp the yellow? And fill up the heart.
Thinking of a saline, like with a, yeah, that one. That thing.
Okay.
That one's gone.
Okay, let me get this guy out.
For a dissection, I used called it my donut technique, and I thought it up. Well, I think I stole it from somebody taught me, but where I roll the adventitia into the aorta. So I've got an adventitia inside, and then wall, and then outside, and then about 3 years ago, it was written up in the journal or in operative techniques. That really annoyed me because
You thought of it.
well, I thought of it simultaneously. I don't know whether it was like, but I probably stole the idea from somebody anyway. So there you go.
Empty out heart. Empty. Yes.
Yeah, wrong yellow one. Sorry.
Yellow's on. I'm gonna tie it over that bump.
That's what I wanted.
With transplants, we never used to use.
Can we go head down? Head down. And then you got a needle.
Needle number?
Like 19. That's good.
18.
Just a needle. Do you have anything?
Yeah, we're done. We're just,
Waiting for a needle. Good. Yes. Good luck. Okay, perfect. Oh, no, that's okay. Good, thanks. Just go ahead and pump down.
Go down.
Go ahead, I'll pump it right now. Go ahead.
The
Back up.
The camera moved, Mark.
Yeah, we're gonna raise the head back up. Okay, table back up. Okay, good. Sponge? Okay. You call sponge? 4x4? Sure.
Water in right now.
Sucker. Yeah.
You don't need more.
Telling.
4x4? Sponge? Okay. We just wait. Yeah. I don't know, whatever they do. I hope. Really warm, right? Get this and set it in here. Whoop. Right here, yeah.
Mark, we're likely to, I'll check with the organizers, but from your point of view, is there anything you want to share with us before we leave and or
No, I think we got the right size here. It looks good. We've got the left ventricle staying completely empty. I think we're gonna be good without any issue. So we're just gonna let warm up. We're about 34 point something, 34.5. So it's gonna take us 15 minutes or so, warm up, and then we'll make sure things are dry and join you downstairs or upstairs or wherever we end up.
Okay, well, I think they're just essentially going to be some closing comments. I'm not sure whether we're going to,
Okay.
those will proceed. You're coming back or
Okay, we will, we'll make sure things are gonna be safe here and then, meet you guys, to head on back. Tell everybody we said thanks.
no, we are all listening to you. So thank you, Mark. That's great. Thank you.
Any questions?
Thank you
Any
both of
queries?
you. And Pooja, great job,
Thank
both of you.
Thank you. Okay. I've dropped a lot of instruments. Yeah.
So we are
Oh,
taking
thank you.
away from OT. Yeah, everything is done. Yeah, all it over. Okay. Thank you so much. Thank you so much for being with us throughout the day. It has been a long journey. Okay. Yeah. Okay, sir.
Oh, God.
One small announcement. We are going to meet at 7 p.m. at Vivanta for the post-conference dinner today. Yeah. 7 p.m. Vivanta. Thank you.
We get 7. Okay. Thanks a lot.